21st Annual Scientific Meeting of Indian National Association of Study of Liver. I believe we are all good to go. Thank you so much, everybody, for being on time. Let's start with the special interest group on hepatitis B virus. And for the chairperson for the same are Dr. Vinod K. Dikshit, Institute of Medical Sciences, Banaras Hindu University, Varanasi, Dr. Anil Arora, Sir Ganga Ram Hospital, New Delhi. The chairperson for the same, Dr. Vinod K. Dikshit, Institute of Medical Sciences, Banaras Hindu University, Varanasi, Dr. Anil Arora, Sir Ganga Ram Hospital, New Delhi.
Good morning. I welcome you all to this important morning session of a special interest group on hepatitis B. First of all, what we like to have the best abstract which we have chosen, and we like to present them, and then we'll discuss them, and then after that we'll have the program on meet with the expert, and that will be followed by this. So to begin with, I will invite Dr. Arup Bepe. He's there? Arup? Yeah, please come. So he's going to present the abstract, the prevalence of the liver disease and the fibrosis in chronic hepatitis B and hepatitis C patient at presentation based to the vibration control treatment elastography. Dr. Arup, please go ahead with the project.
Good morning, everyone.
And you know the timing, you have to present for 7 minutes, and then you have to finish it, and then 3 minutes for discussion. Okay? Right.
Good morning, everyone, and respected chairperson. I am Dr. Arun Vaidya, and I am working in the Department of Gastroenterology at KM Hospital, Mumbai. At the outset, I would like to thank the INASL team for this opportunity to present my study abstract before all of you, titled Prevalence of Liver Steatosis and Fibrosis in Chronic Hepatitis B and C Patients at Presentation based on Vibration Controlled Transient Elastography. So approximately 296 million people worldwide are chronically infected with hepatitis B, and another 58 million people are infected with hepatitis C, placing them at increased risk of developing cirrhosis and its complication, including HCC. And also there is tremendous rise in the incidence of metabolic syndrome. So chronic hepatitis B and C are associated with liver steatosis and advanced fibrosis due to infection itself or metabolic comorbidity, and early identification of fibrosis and liver steatosis is important and necessary for prognostication and patient management. Although liver biopsy is the gold standard, but nowadays with the advent of non-invasive investigations, it is reliable, quite reliable to do the study. So aim was to determine prevalence of hepatic steatosis and fibrosis in chronic hepatitis B and C patients at index presentation using FibroScan, and to study metabolic syndrome as a risk factor for fibrosis and steatosis development. So this was prospective study done from November 2022 to April 2023, and inclusion criteria were patient above age of 18 years with chronic hepatitis B and C. Exclusion criteria was pregnant females, AST/ALT level more than 100, presence of jaundice or ascites clinically, unable to perform transient elastography due to obesity, hepatitis B and C co-infection or HIV co-infection, patients with alcohol abuse more than 30 grams in males and 20 grams in females, and patients on medications that can induce steatosis and fibrosis like corticosteroids and methotrexate. And LSM values and CAP values were assessed by a professionally trained technician, and LSM was expressed as kilopascals and CAP as decibels per meter. Only procedure with at least 10 valid measurements and success rate of at least 60% and interquartile range less than 30% of median LS values were considered reliable and used for analysis. And when the transient elastography was performed, relevant patient information including medical history of diabetes, hypertension, dyslipidemia, alcohol consumption was obtained, and lab parameters, liver function test, and lipid profile were done within 14 days of transient elastography. So these were the some definitions and grading we used. Metabolic syndrome was defined as more than three or more than three of the following: fasting glucose more than or equal to 100, or presence of diabetes mellitus on treatment, blood pressure more than 130/85, or known case of hypertension on treatment, triglycerides level equal to or more than 150 or on treatment, or HDL level less than 40 in males and less than 50 in females or on treatment. And central obesity was defined as waist circumference more than 94 in males and more than 80 in females. Fibrosis grading was done based on several studies. F0 was considered when LSM value was less than 6. F1, F2 was considered when 6 to 8. F3 was considered 8.1 to 12.5, and F4 were considered more than 12.5. And steatosis severity was graded in three. S1 mild, that is around 5 to 33% of steatosis, was considered taken from one study, equal to 222 to 246 decibels per meter. S2 was 247 to 273 decibel per meter, and S3 was more than or equal to 274 decibel per meter. These were our results. Total 207 patients were included. Hepatitis C, 31 patients, out of which 16, that is 52%, were female. Mean age was 48.6. And F1, F2 fibrosis was seen in 13% patient, F3 in 6.5, F4 in 29% patients. S1, that is mild steatosis, was seen in 10%, S2 moderate around 13%, and around S3 severe steatosis in 29%. And metabolic syndrome was seen in 7 cases, of which 6 had steatosis, of which S1 was 1, S2 was 2, and S3 was 3 cases, and 5 had fibrosis, and both were significant statistically. Among 176 hepatitis B cases, females were 59, 34%. Mean age was 41 years. F1, F2 fibrosis was seen in around 18% cases, F3 in 16%, and F4 in around 10% cases. And steatosis S1 mild, that was present in 16.5, S2 in 13% cases, and S3 was seen in 25% cases. And metabolic syndrome was present in 10 cases, and all had steatosis, and this was statistically significant. And 6 had fibrosis, F1, F2 in 3, F3 in 2, and F4 in 1 case. And another finding was normal AST ALT values were seen in patients with F1, F2 fibrosis around 58%, and F3 fibrosis around 46.4%, and in F4 fibrosis around 56% had normal AST ALT values. So I would like to conclude by saying that every patient should be subjected to transient elastography, fibroscan for prognostication and management. And on this basis of study, 1/3 patient of chronic hepatitis B and C had significant fibrosis and moderate to severe steatosis. And metabolic syndrome was presence for associated with significant fibrosis and steatosis, and should be managed aggressively. Thank you. And this is our department, beautiful young department, and I would like to thank all of them for this contribution.
Thank you, Dr. Arup. Is there any question or any comment on this paper, Dr. Akash? Any? Okay. Yes, Dr. Amit.
Yeah, Dr. Arun, what is the application of this result?
This
Clinically.
actually, we want to show that at the index presentation, what is the prevalence. And so 1/3 of the patient on this basis of this study had significant fibrosis, that is LSM value more than 8. So this will help in the management and obviously prognostication of the patient. So despite
I
ALT,
agree.
AST
Probably
normal.
your result could be better if you can compare your LSM values with APRI, FIF4, etc., which are more easily available. Probably the result will make more sense.
Obviously, this is our interim results. We are going to do that.
To answer Amit's question, I think we now recognize that metabolic syndrome and NASH, along with the Hep B, Hep C, is an important driver for progression of fibrosis. And here in this study, by identifying that almost 1/3 of these patients have these factors, I think you need to address not only Hep B or Hep C, but you also need to address the steatotic liver disease, which is associated with them very aggressively. So I think that's one of the. It's important to recognize this component. Now, whether this will have an effect or not by intervening, I think that the subsequent studies will be able to tell us.
Yeah, Arun, my question is here. So how do you know here on the desk, on the plate here?
Yes.
How do you know that this is not a part and parcel of the viral hepatitis? Unless you treat, suppress the virus, or in case of HCV, if you try to have an SVR, how do you know this is not occurring because of the viral disease? And why do you want to attribute metabolic components?
No,
Because 40% of the population will have some diabetes, some hypertension, some metabolic syndrome.
correct. We have shown that almost 7 patients of hepatitis C who had metabolic syndrome, almost all had steatosis and fibrosis. So it is also one of the contributing factors when we compare without metabolic syndrome. So I think it is very important to address both along with hepatitis C, because if we can cure hepatitis C, but the progression to the cirrhosis and another HCC we can halt by addressing metabolic syndrome also.
Can I ask one question?
That's- yeah.
Arun, nice presentation. My
Thank you.
question is that you have shown 1/3 has steatosis and around 25% has significant fibrosis. But what is the correlation between these two? Is it that all significant fibrosis patients have steatosis, or all significant steatosis has significant fibrosis?
Yes.
What is the relation?
In
That you have not
hepatitis
shown.
C, it was seen that in patients of steatosis there was significant fibrosis also, but not in the cases of hepatitis B.
Yeah. Okay, thank you.
Thank
Thank you for finishing on time. The next presentation is by Dr. Vivek Nagrale. His talk is on dissecting virological and immunological factors to predict outcome in HBe antigen negative chronic viral hepatitis B in patients after discontinuing oral nucleoside analogs. Dr. Vivek is from Calcutta, PGI Calcutta.
Thank you everyone for giving this opportunity. I am the resident of hepatology from the IPHMR Kolkata, and I am to discuss this abstract dissecting the virological and immunological factors to predict the outcome in HBe negative chronic viral hepatitis in uh, after the stoppage of nucleoside or nucleoside analog. As we are know, there is no currently the virological cure for the chronic hepatitis B patients, and those who have required the treatment needs the lifelong treatment. But this lifelong treatment or long-term treatment suppress the viremia, but may it leads to the T cell exhaustion. When we stop the nucleoside analog treatment, which leads to subsequent increase in DNA level, and its DNA triggers the reintroduced T cells response against the HB infected hepatocytes, and it might clear the HBsAg level. So, aim of this study is to assess the therapy virological and clinical response as at baseline 6 and 12 months following the cessation of oral antiviral in HBe negative non-cirrhotic viral patients, and second is to assess the therapy immunological changes with effect to HBV specific CD8 and CD4 T cells along with the natural killer cells. So we included those patients who have continuously taken tenofovir or entecavir monotherapy for at least 2 years and shows the complete suppression of virus at least for 1.5 years. So this was our study plan. We selected CHE negative CSV patients, 32 patients. After selecting, we randomized it into 2 arms in 16 each arms on arm A is off therapy, arm B is on therapy. And also in off therapy, those have relapse and non-relapse, we are also categorized. In biochemical and virological parameters, we checks ALT at baseline and every 3 monthly, and HBV DNA at baseline and every 6 monthly. For the immunological parameters, which was done by the flow cytometry, we assess HBV specific CD4s and their cytokines level, natural killer cells, total and their subsets. So this was our results. In over the period of 1 year, we found the clinical relapse when we denote as a clinical biochemical plus virological relapse, where ALT is more than 2 times and the DNA is more than 2000. We found as only the 12.5% found in clinical relapse, while on in virological relapse will only indicated more HBV DNA more than 2000, and there is a ALT normal or less than 2 times the upper level of normal found, or around 44%, while biochemical relapse where the HBV DNA ALT more than 2 times found in 25%, and only the 12.5% required the retreatment. While we also notice when the most of the relapse found in first 6 months of the period, and we follow the next 6 months, those have DNA more than 2000s, they came found to have less than 2000, that is inactive carrier state, and ALT was also normal in subsequent visits. Second, we test the HBV specific CD4 and CD cell expressing the cytokines. As we know, the interferon gamma, TNF alpha, and IL-2 are the pro-inflammatory and antiviral cytokines. We show on the both CD4 and CD8, the relapse and all relapse patients, they have increased percentage of this cytokine level as compared to those have on the relapse, while those have not the uh, sorry uh, they have increased percent of they have increased percentage in off therapy, both in relapse and the non-relapse, but their percentages increase more in relapse group than non-relapse group, while on therapy shows there is a significant decrease in percentage at baseline and 6 month, from baseline to 6 month and 12 month, while interleukin 2, there is no any significant changes at on therapy group at 6 month and 12 month. We know the interleukin 10 is anti-inflammatory, which seen that on off therapy there is a significant decrease in relapse group, while there is no any significant in on therapy group. Also, we express the NK cell activation receptor expression, there is a total and their subtype CD56 and dim and bright. We found there is no any significant difference, while interferon gamma producing this is cytokine also shows there is no any significant difference in on off therapy group, while in on therapy there is no significant difference in total and CD56 dim, while interferon gamma producing this NK cells is significantly decreased in bright subset of patients. Also, we checks the trail expression, and we found there is no any activation or in off therapy group, while in on therapy group they have down regulated or their percentage is decreasing. So, in summary, we can conclude the virological relapse found in 43.5% of patients, biochemical relapse found in 25% of patients, clinical relapse 12.5%, and majority of patient 88.5% treatment over the 1 year of follow-up, and the minority of patient 12.5% required retreatment. HBV specific CD4, CD8 cells that express the pro-inflammatory cytokine in increase in of the stoppage of therapy, while the anti-inflammatory IL-10 is a decrease in arm A. There is no change in NKP44, NKP46, NKG2D expression, and in the both the group, while trail expression down regulated in arm B, and there are no any change in arm A. So we can conclude that after discontinuation of nucleoside therapy, there is a significant proportion of patient develop virological relapse. However, the clinical relapse were only 12.5%. The upregulation of antiviral cytokine and inactivation of natural killer cell associated with no alteration in trail expression was seen with many patients, which may prevent the clinical relapse, and there is a suggestion of antiviral can be considered with the close follow-up.
Thank you for finishing on time. We can have a question from the floor. Dr. Akbar, please.
Yes, Akbar from Japan. The study is very important. The thing is this, I could not understand the whole study because the method has been said. You are telling that it is the HBV-specific cytokine, but the method does not indicate that it is HBV-specific cytokine. To do so, you have to do the tetramer assay, which you have done, and we don't find this type of study. The second thing, the number of the patient is so small that it is very difficult to make a conclusion. But to use the term that HBV-specific cytokine or something HBV-specific, it is very difficult to draw a conclusion from this study. So you should place the data very cautiously. Otherwise, this can give a very strong misconception about the whole story of the NA stopping, failure up, and other things. Thank you.
Hello, I'm Ashish. Actually, you have taken low viral load patient, yeah, for the nucleotide stoppage, right? Low viral load. So I think you should look for the seroconverter predictor immunological, like T Follicular helper cells, plasma B cells. They secretes antibody. That's on the basis of you are saying immunological relapse. You have taking the NK cells and different cells. It's like not more than that much relevant. So if you have
Because
studied,
we took the NK cells and HBV, they are the adaptive and innate cells component. While the NK cell is mostly uh, required, leads to activation of NK cell leads to activation of innate cells, and there is a haphazard killing of the hepatocytes, which leads to the bad flare. Actually, we want to look for this bad flare when we can't continue the lifelong treatment. There is a side effect also, and there is a cost. In our country, the drug is very important. So we can stop those substance of treatment to patients who can benefits after stoppage of therapy. We can.
yeah, yeah, but like we are telling that functional cure on the basis of generation of surface antibody against the surface antigen. So which cell secretes antibody? The plasma cells. And there are a lot of study which showed that IL-21 predict the seroconversion. So when you are looking for the seroconversion marker, I
Already
think
we are E negative, E
yeah.
positive to E negative. There are seroconverted patients.
Dr. Vivek, what is the relevance of this study? 50% of the patient will get back to the normal viral DNA high load. Would you not treat them? Do you wait for biochemical and then the clinical relapse to occur?
Sir,
Every second patient has a higher viral load.
Sir, we have found that there is a viral load more than 2000, around the 50 or 44% of patients. But when we follow these patients over the 9 and 12-month follow-up, actually we found that those have more than 2000, considered as 20,000. They are patient come back to less than 2000 HBV DNA level, and the ALT was persistently normal and subsequently 6 month or 9 month and 12-month period. We also follow this patient over the or next 1 years or maybe 5 years if the budgets are allocated for this for long-term follow.
Is it not relevant that you should look for other parameters? Like, did you try to correlate it with HBsAg quantitative level, which can predict which patients are likely to remain suppressed after withdrawal? Or, as Dr. Nora said yesterday, if you have investigations like HBC correlated antigen or HBV RNA, which is a reflection of underlying amount of cccDNA, these will be better predictor rather than leaving 50% of the patient in Indian scenario to on the fate of recurrence of and relapse of the HBV DNA.
Yes, sir. Actually, this was our third aim but we, due to the financial problem, we preserve this syrup patient in our lab at minus 180 degree. We will do in later when the once the fund is available.
Okay, thank you. If there are no questions, can we request Dr. Amit to come and follow and start the next session? The panelists for the experts for the uh, meeting are Professor Nora Tolan, Professor Akbar, Dr. Mamun Al Mehtab, and Dr. Vinod is here. The panelists for the meeting are Dr. Ujjal Podar, Dr. Sunil Didich, Dr. Brij Sharma, Dr. Ashish Vyas, Dr. A. Kanta Singh, and Dr. Mahapatra. May I request everybody, Dr. Nora, Mamun, and Dr. Akbar to be pleased on the stage.
Can we request the panelists to be in the front row? For this session, we so for this session, we don't have any formal kind of case-based discussion. We have some important questions which I have highlighted, and we'll like to take opinion of the house and our expert panelist. Probably the most important parameter when we are managing our patient of hepatitis B is serum ALT level. That what should be the cutoff? As the different cutoff has been given by different societies, ASLD is giving 25 international unit for women and 35 for men. In India, we are still using 40. We don't have any large population base result to define our own cutoff. So can we take opinion of expert, Dr. Arora, I can start with you that what cutoff we should use, because Hep B guideline treatment, it's always based on 1.5 time, 2 time upper limit of normal. If we take 25, then 50 will become the 2 type upper limit of normal. If we are taking 40, then what should be the cutoff we should take in India?
Yeah, I think this question will be more relevant when you are trying to define normal and abnormal. Every individual country, every individual region, unless you do a good quality long-term epidemiological studies, you cannot be doing a decent job like what has been done in US. Even if you look at different countries and different societies, the variations range anywhere from 30 to 20 to 35 to 40. These are different as per the laboratory parameters. But I'll try to put another question for you. In relevance to hepatitis B, why is it that you need a particular cutoff to be treated? If you look at the way the paradigm is changing in management of hepatitis B and the type of drugs which you have available at the moment, what is reasonable is any ALT which is just abnormal, anything which is above the upper limit of normal in any particular lab, that should be good enough for us to start thinking that we should give antiviral therapy. So this cutoff of 1, 1.5, 2, I think this is losing relevance. I have a talk tomorrow, I'll give you evidence for all that. I think unless you have a good quality epidemiological long-term data, especially in a varied country like ours, where you will have different population, urban, non-urban, those different type of BMIs, this will have no relevance. Anything which is abnormal should trigger antiviral therapy in our scenario at least.
I agree, sir, that it's losing its value, and gradually we are moving that everyone should be treated regardless of ALT or fibrosis status. Probably next a decade we will move to that stage. But still, we need an answer. So, our panelist can answer. Dr. Podar, will you like to add anything on it? Especially in present era of growing burden of fatty liver disease, when we have lots of ALT contributed by fatty liver.
I think, Amit, I agree with you. We need to have a cutoff because we don't know that at what level of ALT that immune function is triggering. Basically, this hepatitis C, you treat everybody, that is irrespective of the immune status. Hepatitis B, you are heavily relying on the patient's immune system is helping in get rid of the virus. We don't have that kind of drug which will eliminate the virus without the help of innate immune system. So that's why there is relevance of cutoff of ALT. I can say that in children, there are various reports to say that the first 1 or 18 months of age, they have a higher ALT normally. So they say that less than 18 months, the study from US said that it should be 60 in boys and 55 in girls, but more than 18 months of age, they get the adult value, you take 40 and 35. But there are studies to say that even in children, the upper limit of normal should be 30. In India, we don't know what should we take. That the study by Amrapurkar has said for a male it is 27 and for female is 17 as the upper limit of normal. So still we don't have the answer what should be the normal value.
Yeah, actually ALT has less value when we are starting treatment, but probably for the monitoring of the patient, we still need that whether ALT is improving or not. So yeah, I know this question will remain unanswered. Yes, Dr. Akash.
With the correction of, so we have done a population-based study for Western Indian population, including people around 22,000 people with normal BMI, which is published in Indian Journal of Biochemistry, where we found that, and we have done viral markers for everybody. And we found so it was a mixture of rural and urban, and we found that the normal values was 22 and 25. So it is not very different for men and women. So it was for women it was 22 and for men it was 25.
Yeah,
so now
actually,
that is what we are now following in our practice.
Yeah, ALT is, we are in less dilemma when person is not having metabolic syndrome or obesity or overweight. We are in more dilemma when we have component of fatty liver disease or metabolic syndrome, that what is the real ALT value. Anyway, we can move ahead. Another important question which most of the time remain unanswered or which are not in discussion these days is role of hepatitis B virus genotype. Have we moved to the stage that genotype is not having any role as of now, similar to hepatitis C virus, or still there is hope and we need to probably need to do some more research and discussion and research about it? Dr. Noora, can you answer it?
Well, interestingly, we just finished a big trial in the United States where we were using the combination of peg interferon and tenofovir for a 4-year study. And in the end, actually, genotype was a major driver in the outcome, to our surprise. And so it made me realize that there are really big differences in terms of the outcome of treatment by genotypes. So most of the time, we actually don't get genotype. But I think if we have that data, I think we're going to learn more and more as we move to new forms of therapy that it may be relevant. It probably is, at the moment, not something that you would use clinically, but I do have a sense that as we move to a more personalized approach where we have more treatments to choose from, that there may be relevance in having the genotype. But today, for example, in my practice, I do genotype because I'm interested in it, but I don't use the genotype to make any decisions about treatment. Because for the most part, with nucleoside analog therapy, it works for all the genotypes, right? So there's not really a benefit in helping us make that decision. But I think with therapies evolving, it's going to change.
Yep. Is it possible, like in hepatitis C, when we were treating with pegylated interferon, where the immunity was playing a role, then genotype was playing a role? And in Hep B, we are presently treating with oral drug, nucleoside analog, and they are not working through immunity. They are directly working on the virus, and that is why again the role of genotype has gone down. Whether if we go back to some immune mediated therapy which are coming back in some phase 1 phase 2 trials are going on, or again we can go back to pegylated interferon, and then again genotype will emerge as a new marker for success or failure of treatment.
Yeah, I think Amit, another relevant issue is that in scenario like in India, where majority of genotype is genotype D, which is a very poor response to a pegylated interferon. That is another reason most of us are not doing. First of all, it doesn't occur, and even if it occurs, as Don Nora said, the response of pegylated interferon is primarily to genotype A, which is less than 5% in India. And I don't think any of the hepatologists for the last 10 years in India would have treated. Now, I'm not talking of pediatric population, adult population, their hepatitis B with interferon.
Actually, sir, pegylated interferon availability is again an issue. So, yeah, yes, sir, please.
So about the genotype, I just like to give one information. So we had 360 patients of chronic hepatitis B from Bangladesh, and we genotyped it. We found almost equal percent of genotypes A, C, D, and A without genotype B. Then we did the full genome sequences of most of the cases, and we found that the appearance of one mutation was mostly present in the genotype C. Then out of these patients, we did two groups, and we found that the people who had the mutation at 1728 or something like this had more pro-inflammatory cytokine, more activations of the antigen-presenting dendritic cells, and this has been published. So if someone like to know that actually whether genotype have some role in actually the mechanism, so we have published in viral immunology, so you can check the paper. So we did something and we found that why genotype C is so virulent as it is told in this area. And this is due to the production of something like so. So we checked only up to the cytokine levels and not more than that. So maybe the genotype C with a specific mutation in 1728 and maybe the 1633 and was more producing inflammatory cytokine. But we're not sure actually, it was an observational study. So we can do this type of a study in future also.
Amit, can I make a comment
Yes,
about
sir, please.
genotype?
Yes, please.
I beg to differ with Dr. Arora about the prevalence of genotype. From SGPGI study, adult study, Rakesh Agarwal has published 10 years back, shown that genotype A is around 40%, genotype D is 60%. We did in a subset of children, our proportion is 45% of kids where we have done genotype A, 55% D. So it is not that just 5% A, especially in North India where we work, in Lucknow, this is the proportion. Obviously the study from West and South showed genotype D is probably 70%. In the Eastern India or Northeast, there is a proportion as genotype C as well, which is not documented in other part of the country.
Sir, will you like to add some comment on a specific role of genotype in relation with mother to child transmission?
Because particularly this D type of actually genotype has been shown to have relevance to the parental transmission. This is one of the report I have read actually. So that can have some relevance.
Yeah. Dr. Brijesh has published a paper from Himachal. Yeah, and
we have done one study in joining to China. Here the genotype C was most prevalent in that population, and you are also one of the authors in that study.
Dr. Shenoy here. Can I ask?
Yes,
can I
please.
give a comment? Yes. I think the question of genotype cannot be generalized that D is the most common in India. I think this has evolved because of a few studies by Dr. Priya Abraham from Vellore and others. We did a study somewhere in 2009 to 2011. About 100 samples were genotyped in the Anna Kramvis laboratory in South Africa, Johannesburg. There is a project called Diversity of Hepatitis B across the world, Japan, Italy, India, and Greece. Among the 100 subjects which we have genotyped, 90% are Geno A. And among them, the Geno A1 is the most subgenotyping The paper has been published in World Journal of Gastroenterology. My PhD student was the first author. Deepak Gopalakrishnan and Dr. Vinay Kumar is also one of the authors. So I think we cannot make a passing statement that Geno A is the predominant one in India. Geno D is predominant. I think we require a more sampling of population across India, subject to the prevalence of the disease, and then make a comment. I think till that time, I think the comment that D is most common is not.
I agree, sir. As of now, we have very limited data because it has very limited clinical relevance, so people are not doing it, and
No,
it's
no,
not
no,
available.
no, no. I don't think there is a clinical relevance is poor. There is a lot of clinical relevance. For example, in South India, in my center, we get a best response to pituitary interferon. But unfortunately, the alpha 2B is not
Available. Yeah, I know.
not available. Regarding the progression to HCC, I think there is a relevance of genotyping. Genotyping A has got a higher prevalence.
My point of taking up this issue was entirely that genotype has not dead actually. Still it has relevance in relation with SCC, probably the risk of transmission, risk of developing chronicity, response to immune mediated treatment. So these are the factors, mother to child transmission, where genotype could have some potential role and we need to explore them. So that was the entire point. Yes, Dr. Ashish.
Yeah. We have recent experience of vertical transmission from central India. I was working in AIMS Bhopal, and we followed hepatitis B pregnant female and their newborns. And we have done 22 newborns after 6 months, because the vertical transmission definition is positivity of surface antigen after 6 months of delivery, and we found the D in all, and all 22 baby, all are HBV D genotype.
Thank you.
Amit, just to add here, we have published data of 25 pair of mother-child transmission, where we have shown 44% are genotype A and 55% genotype D, and identical
Means mother baby
phenotype,
same.
mother baby plus their genetic composition.
Right.
So it is not that genotype D will have vertical. Genotype A as well has the vertical. It's basically the viral load which determines during the pregnancy rather than genotype.
So probably I'm successful in raising this issue that many questions have remained unanswered relation with genotype. We have Dr. Akbar with us, so I will like to use this opportunity to take his opinion. How far we have reached in relation with the therapeutic vaccines? Sir, you are working on it. So what is the progress, and are we likely to get it in near future in a decade or two?
Well, the therapeutic vaccination actually started in 1982. And at that time, HBs antigen was used not for as a therapeutic vaccine, but it was used by Dynastag at that time. In 1994, Paul et al. Used the therapeutic vaccine using the HBs antigen-based vaccine. Then after that, after the 2008, there's a lot of therapeutic vaccination combination passed on. For example, in China, they use the surface antigen anti-HBs complex. We use different types of therapeutic vaccine in mice, whole transgenic mice and all human, and mostly in the human. So the combination therapy was done, but nothing yielded any kinds of good outcome so that we can use the therapeutic vaccine. Then finally, from 2009, we started to use a new vaccine, that is the combination of the HBs antigen and core antigen. This was developed in CIGB in Cuba, and it was a nasal vaccine. Then in Bangladesh, we made a phase 1, 2, 3 clinical trial with the vaccine, and we published the 5 years follow-up. And this year, we are going to publish the 10 years follow-up of 160 patients. And out of this, 80 patients received PEG interferon, and 80 patients received the NASVAC, that is the nasal vaccine. Still, there is no safety issue. Regarding the efficacy issue, about 70% become negative for HBV DNA. And they lost their HBV DNA in the blood, but we don't know about the other things. The thing is this, the ALT was more or less normalized, and this was 5 in 5 years follow-up. The 10 years follow-up will be in this year, and I have come to Bangladesh to institution this thing, so we'll get some data about it. The thing is this therapeutic vaccine, possibly, and now, before 1 year, we have started another clinical trial in which we have stopped nucleoside analogs in patients who had low viral load, and then gave therapeutic vaccination in one end, and other group received the nucleoside analog plus therapeutic. And after 1 year, we found that even if we stop nucleoside analogs, there is no flare up when this was replaced by the therapeutic vaccine. We have not yet published this thing. We are just compiling the data, and it seems that it will work. So we think that therapeutic vaccination somehow works. Now we are going to develop a better regimen of therapeutic vaccination, but at this point, but our sample size is 160, and it is better than peg interferon because we are just comparing these two side by side. But maybe we need to see the 10 years follow-up. And the interesting thing is this, the patients who receive peg interferon, 9 patients develop liver cirrhosis. But the patients who receive therapeutic vaccination, only one cool, they did not develop liver cirrhosis, none of this patients. So we are very hopeful about this thing. And it is a randomized trial, and the randomization was done after enrolling the all patients and then by the scientific method. Yes.
Can I ask a
Yes.
question?
Yes, please.
I think the area of therapeutic vaccines is very exciting, actually. And I think for the first time, really, in the last year or so,
Yeah.
we are seeing a lot more interest in therapeutic vaccines. And I think maybe it was triggered in some way by COVID, and a lot of vaccine development occurred during that time. So I think there's a lot of hope. Do you use a threshold of surface antigen to decide who you're going to use the vaccine in? Because I think the trials are suggesting that it's those that have the surface antigen levels of under 1,000, under 100, that are actually the right group to be doing therapeutic vaccines. So do you use that as a criteria in your trials?
Let me say, the thing is this, in Bangladesh, most of the patients is E antigen negative, anti-HB positive. So the patients who was anti-HB positive, the virus load was more than 10 to the power 3 copies per milliliter. And those who are E antigen positive, the virus load was more than 10 to the power 4 log, 10 to the 4, more than 4 log per milliliter. And also, we have some patients who have the viral load more than 10 to the power 10 log in our cases. So we took, but the most of the patients, 78% patients was anti-HBE positive.
I'm interested in S antigen.
S antigen. Oh, the thing is this, when the study was started, we could not measure the S antigen. But after that, with the France people, I just forget his name, we estimated the S antigen, and we find that there is some decline of the S antigen. Let me add something else. This study was started in Bangladesh in 2009, but at that time I was working in Japan, but we did not get the permission from the Japanese PMDA. Then ultimately in 2017, the Japanese PMDA gave the permission, and a phase 2A study was started over there. And they found the age-based antigen was reduced in their patient was receiving the nucleoside analog. But they did not give the permission to stop the nucleoside analog. And this was presented in ASLD last year. Before that, 3 years consecutively, we presented our data that therapeutic vaccine reduces the HBS antigen. But in some patients, we also found anti-HBS, but at the same time, HBS antigen was also present. And we now decipher the anti-HBS antigens complexity and other things. So this is now going on in Japan, and a phase 2B clinical trial is continuing in Japan with this therapeutic vaccine.
Can I just ask you, I think the other thing that we're seeing in the trials with therapeutic vaccines is it sort of depends on also how you're doing the sort of the initial and then the boosting, right? So like what's your thoughts about the importance of that, the first but the second one as well, the boosting effect?
Well, the thing is this, I know that the analog published the same type of the vaccinations, but the construction is a little different. And the construction they prepared in the East, we prepared the full genome, full length of the core antigen. And this core antigen possibly contained, it was developed in the E. coli. We think that there is some specificity in this thing. The next thing, we give the vaccine in the nasal route. It was given by nasal route. And one cool of 5 vaccination was given by the nasal, and then another cool was given by the nasal and the subcutaneous. So this is the mode. And the third thing, the amount of the vaccine. We gave 100 microgram of the surface antigen and 100 microgram of the core antigen. So there is some difference. But I think that maybe the other people will be developing something like this, and maybe we can get some more data about this. Thank you.
Amit, there are three advantages of giving a therapeutic vaccine. First of all, it will prevent the entry through the anti-CP receptors. It will neutralize the HBsAg in the blood, thereby decreasing the level, theoretically trying to boost the immunity. And recently, there have been attempts to tweak the FC component of the immunoglobulin chain so that that can stimulate HBV-specific immunity. So these are three premises by which it can act. How much will it translate into real practice? I think maybe
I think
like
we are,
Dr. Akbar
as
will
of
show.
now, we are far of
Yeah, we are far
achieving
off it.
any therapeutic
But it makes sense.
significant
If you have more
outcome from.
antigens,
Yeah.
different routes, makes sense. It may end up
But this
stimulating.
vaccine work through the enhancement of immunity, and in the same track, we can say there are lots of immune-mediated therapies are coming up actually, which are not preventive, more of therapeutic things. So, any
No, just one thing I have to tell. This is not only therapeutic vaccine, it is also preventive vaccine. Because there is a group of people who are vaccine non-responder. We gave 3 therapeutic vaccine to this vaccine non-responder, and they all developed anti-HBs, although they did not develop anti-HBs due to getting the immunization from the HBs antigen-based vaccine in Japan. This was studied in Japan and was very, so Bangladesh, there's some estimations and other method, but this is one thing. The another thing, in the therapeutic vaccine, we found tetramer-based CTL production due to the induction of the therapeutic vaccine, which is a core antigen-based things. We have not published, maybe this year ASLD will give this data because we are now compiling this data. And as the works by the Bartolotti and Miami's group, they found that the core antigen is protective for the liver disease and for the HBV DNA reduction and ALT normalization. Maybe this is one of the mechanisms. And we're not sure about this is the best dose or not because we used only one dose. So we're now thinking to use another dose to have the more optimizations of the therapeutic vaccination protocol.
Thank you, sir. So another important thing which remain many time undiscussed and we need to know is hepatitis B virus reactivation in context of immunosuppression. So it is very common to use 20 milligram of voice alone or 40 milligram voice alone for 4 weeks, 6 weeks for so many conditions related to GI or non-GI indication, especially skin diseases, bronchial asthma, etc. So how much is the risk of reactivation you see? The guidelines recommend to test for core antibody, and if antibody is positive, then give prophylaxis. So in real life, Dr. Sunil, can you say that how much you are seeing the reactivation in real life setting where you are using immunosuppression? Are you testing all your patient before starting immunosuppression for core antibody?
Actually, when you are using these compounds for a short period, like you are giving in a UC patient for maybe a few weeks only, then probably it's not needed. But when you are using it for a longer period, then you need to test them. And then especially when the person is undergoing chemotherapy, targeting the immune cells like the rituximab and other, or any other immune
Biological,
suppressive.
basically.
Yeah.
Rituximab is the most potent reactivator known for.
So in that case, I think there are recommendations to start the antiviral compounds.
So like in Crohn's disease, Crohn's disease, autoimmune hepatitis, here we use steroid for long period of time.
AIH, anyway, it's a part
so
of
it's
your
causing
backup.
significant immunosuppression. So how commonly are we doing, or we shall test for core antibody and follow the guideline?
Like in AIH is already the part of the workup of the underlying liver disease. So we all do all the markers. And with regards to IBD, I think the person is undergoing therapy with biologicals. Then we test them and treat them. Otherwise, it's not. We don't do it.
Dr. Mahapatra, will you like to add something?
As you have already mentioned, for biologicals, before starting biologicals and small molecules, we usually do in IBD. And autoimmune hepatitis, we have already done the test anti-HBC prior to before starting any treatment in autoimmune hepatitis. So it's a already mentioned that rituximab is the most potent to cause this viral enhancement. So we usually do this type of
Right.
things in particular cases.
Anybody from our experts, sir? Yeah.
In fact, we published these guidelines on the
INASL.
role of prophylaxis versus anticipatory therapy in patient on biological and immunosuppressants. There are three groups of agents which will have different propensity to reactivation of the virus hepatitis. The maximum reactivation occurs with the anti-CD20 antibody, that is rituximab, and all patients with bone marrow transplantation, as those with solid organ malignancies who undergo transplantation. In them, not only should you test for HBsAg, anti-HBs antibody, but also as a routine core antibody. The classical example is rituximab, that even if anti-HBc is positive, if the patient has not got an antibody done, in a patient who is being treated with anti-CD20 antibody, the chance of reactivation is very high. So by default, you have to cover them with prophylactic antiviral therapy rather than follow up and look for it.
For
But
that
so far
high
as
risk, yeah.
steroids are concerned, any dose which is less than 20 milligram in routine practice, you do not need to cover them with prophylactic antiviral.
Yeah, that.
Just Amit, can I
So,
little bit
yes, sir,
one
please.
line?
Yeah.
Is basically you have to stratify risk stratification. Risk stratification is basically based on what is the chance of reactivation of hepatitis B. If it is more than 10% chance, then obviously all patients, whether it is HBC positive, negative, any of these three, anti-HBs positive or total anti-HBC positive, will require prophylaxis. That is only what Dr. Arora said, rituximab or bone marrow transplant. But rest of the cases, it is between 2 to 10%. When you are giving steroid, even the therapeutic dose of steroid, HBsAg positive patient required, but total anti-HBC positive, HBC negative, you can just monitor. You need not to start prophylactic therapy. So
There are
risk
three groups.
stratification is very
Yeah,
important.
there are three groups. Low group is less than 1%.
1 to
Moderate group
10
is
and
1 to 10%, and more than 10% is the high group.
Yeah.
High group is this
Yeah,
anti-CD
yes, sir.
antibody.
Thank you, sir. So I would like to thank my chairperson, panelist colleague for making this wonderful discussion and bringing lots of knowledge in. Thank you, sir. So our time is up. Many more questions are left, but unfortunately we cannot take them. Thank you.
Much everyone. To all our chairperson and the speaker, thank you so much. Now we move ahead with the presidential oration, and the chairperson for the same are Professor Dr. Radha K. Dhiman, Sanjay Gandhi Postgraduate Institute, Lucknow, Professor Dr. Ajay Duseja, Secretary General, INASL, Professor and Head of PGIMER, Chandigarh. All right, everyone, kindly be seated. We are about to begin with the presidential oration. Our chairperson for the same are Professor Dr. Radha K. Dhiman, Sanjay Gandhi Postgraduate Institute, Lucknow, Professor Dr. Ajay Duseja, Secretary General, INASL, Professor and Head of PGIMER, Chandigarh.
Good morning, everyone. So, welcome you all to day 3 of the meeting, and we're starting with the presidential oration. President of INASL 2022 to 2024 is Professor S.P. Singh, and I'll request Professor Dhiman to invite him for the oration.
Thank you, Dr. Ajay. Professor S.P. Singh, a dynamic personality, was the professor and head of the department of SCB Medical College, Cuttack. And he also remained in the INASL as a Secretary General for 6 years. As far as his association in INASL in the governing council is concerned, that exceeds 12 years. Now he is the president of the INASL for the 2 years, and this year he is completing the first year, and next year would be his second year term. His main specialty is where he is basically involved. Patient care and the research include the NAFLD and others being the peptic ulcer disease also. With this brief introduction, may I request Professor S.P. Singh to deliver the presidential oration.
Thank you, sir, for the kind introduction. I'm sorry, my talk, some people may take offense at the president giving such a talk. But as one of my students said, A, B, C, D, E goes on for whole day for, all the 3-4 days. Please change it. So last night I decided to make the slides, and I am going to speak on l'affaire INASL, a torrid affair. I was born in this small town in Vidarbha, central India, Wardha, on the Ides of March 1957, was transplanted to Cuttack, and I have spent all my life in Cuttack for more than 66 years. In 1975, I joined this medical school. This is one of the most ancient medical schools of India. This medical college, or the institution, started 300 years ago. And this is what I was. So now you have the answer of my colorful shirts. My first rendezvous with INASL, I think there's some problem in slides. Anyway, doesn't matter. It was in Bombay, 1984, the Silver Jubilee Conference of ISG. See, in those days, I favored that actually. We had a joint conference of gastroenterology, endoscopy, and the liver group. Together we were there. But then later on we split. In those days, it was not INASL. It was the Liver Study Group of India. And due to my exposure to gastroenterology and hepatology there, I joined CMC Vellore in 1988. My wife is there. This is the graduation day, my daughter. And while I was there, I made this presentation. Unfortunately, it didn't see the light of day. This was related to portal hypertension. I was not very popular with a lot of maybe teachers. So because of some lacunae, my research was shot down. I believe if this was published, there would have been at least 2,000 citations by now. This was on the colonic, gastric, and small bowel changes and the absorption profile in patients of portal hypertension. After my DM, I thought I'll have a rosy time. I'll come to Orissa. People are there. There is vacancy. People are suffering, and there are 2 vacancies. Unfortunately, the government posted me in this remote hamlet in the district of Keonjhar, in a community health center where I was to promote removal of the Juango tribes from the face of the earth, promoting family planning, DM gastroenterology, with interest in hepatology, promoting family planning, tubectomies, right? After a struggle of a year, I came down to again this medical college with which I am associated for 66 years. In childhood, I had frequently broken arms, broken legs, bones, eyes, injury, and everything. And very frequently, I would visit. My dad would bring me to this hospital. Orissa is famous for 2 things big. Bodo, they say. Big. Bodo means big. Bodo Deola and Bodo Medical. These are the 2 main things which, help you out in crisis. Bodo Deola is the Lord Jagannath Puri, and Bodo Medical is our hospital. You may have Apollo, you may have more hospitals, you may have every damn corporate hospital coming here. But Bodo Medical, I think, will remain unless the bureaucrats and the politicians destroy it. In 1990, I joined the Department of Gastroenterology as assistant surgeon. Couldn't become a faculty immediately. It took another 2-3 years for me to become. You can see no electricity, no fan, no AC. Doing colonoscopy, temperature, ambient temperature 42 degrees, 45 degrees. So I would open my shirts, and without my shirt on, I'd have to do colonoscopy. Then we went on to a better place, and this was the super specialty block. Welcome to the super specialty block of SC Medical College. See, right in front of the stairs, it is blocked by parked vehicles. So, why I show this? when people compare my, meager H index with those from AIMS, from PGI, they should know where I have gathered those H index, They should understand that and give me some respect. My affair with INASL, it was love at first sight. As I grew, INASL also changed. You can see the changing logo of INASL here. This is the first logo I could get my hands on. And then later on, in second one, we got the name put national. That was after, Professor Acharya and his friend did a coup, and INASL, which was derailed, was brought back on the rails. When did I join INASL? Perhaps in 1987, 36 years ago. However, it was in 1993 at this wonderful place in Goa that I entered the governing council of INASL as a co-opted member. For organizing this conference in 1995, here also you can see the brochure. ISG conference in association with Indian Association. National was not there. Later on, we made it national. This is from that conference. Lord Jagannath blessed us, blessed me also. And during that conference, I did this hepatitis symposium, and suddenly I realized, like Lord Buddha having, realization. Everyone is presenting so much of paper on, data, this figure, those figures, but the plight of the poor man is not changing. He doesn't know what is hepatitis. He doesn't know what is vaccine. He doesn't take vaccination. So something needs to be done. The need for soul searching. And then I entered INASL's, the inner group, the governing council. I have almost served INASL, you can see, from 1993 onwards in some capacity or the other. And even if I was not there for a year or two in between, I'm a very nosy guy. I don't leave anyone in peace. So I was co-opted in 95, 96, I entered the governing council, I got elected, then I became treasurer from 2006 to 9, and then secretary general from 2009 to 2015. So another 2 years as president-elect, so it's almost 2 decades in the governing council. I don't think anyone else has been there. My specialty was, I thought we need to have task forces on different diseases so that we have, concentrated people who focus on particular problems. We didn't have that sick concept then, and we formed I tried to form this NAFL task force, that the first task force, but there was a lot of resistance, I don't know, some sort of resistance or inertia, whatever it might be. Then I got fed up. I said, okay, I am forming an Indian Working Party on NAFL, and the meeting will be in Chennai. Then Professor Acharya, Dr. Chawla, they said, nothing, you can't do that. You have to do it under the aegis of INASL. Why do you want to do Indian Working Party? Why not INASL? I said, well, I want that to happen. So it became INASL Task Force on NAFL. Yes. Now, these are the classic, chronology of Lincoln's failures. He has failed the maximum number of times in various, elections, and failure was also with me in various. These are only a few examples. 2005, S.P. Mishra defeated me by 1 vote. We got equal number of votes. Casting vote was cast by then President. So I lost. 2016, defeated for President-elect INASL. Some friend stabbed me in my back. And in 2018, I thought someone else deserved it more because he had told me a couple of years ago, my son wants to see me when I come to London, that I am president of INASL and I want to introduce you, Dad, as president of INASL. I called him up. Don't you want to become president of INASL? Yes. So I'm withdrawing. You get elected. So the new Secretary General takes over in 2009 in Delhi. There were huge problems. We didn't have registration. We didn't have a proper conference management. We didn't have any office, no clerk, no secretary, no income tax returns, no journal. Already the think tank The think tank had already thought that a journal was due. You know, these were the people, think tank. They sat down, I think in Calcutta, they called me and they discussed with me that there's need for a journal. And then different names were there. This was the name which we thought of. And then they told me it has to be of the level of hepatology. We will not be satisfied with, probably hepatology was then, I don't know, the impact factor was more than JHEP. So I applied. I was a small little guy, got a provisional ISSN number, but alas, for various reasons, I was told that this is, you are too junior for being editor, you and the other person who was then selected as editor. Someone senior should be the editor. I said, fine, I'm happy, no problem. But then the other person said, I don't think there is need for a journal. So the journal was dead for quite some time, 4 years, 5 years. Then when I took over, see, this is the ISSN number I got. I was getting repeated reminders. What happened to your journal, sir? When will it come out? We have given you a number. I said, please hold it. Let me become Secretary General. Then you will have the journal. And then I asked Professor Dhiman, would you like to be the editor? He said, yes. I said, please give it in writing, your consent. The next governing council got it passed, and the journal started from 2011, the supplement issue of the conference. And what a start, what a beginning. Opening impact factor this year is 3. So it's a great moment for us. And personally, I'm very happy. I had invested even even though, initial thing, I spent my personal pocket money and put it here and got everything moving. But alas, it's borne fruit. Then after 2009, this is the first INASL conference I organized in Bhubaneswar here 13 years ago. And they were very bad times. MCI said, you can't get funds, you can't use funds for the doctors to travel, for whatever. But anyway, somehow managed that conference in 2010. Next, we had in Chandigarh. I had this note. So I got this. And you can see there are so many people who are going to speak. And secretary's report. See, this program, the main thing is the secretary's report. The others may not speak. The secretary's report cannot be less than 20-25 minutes. So the diktat come, no. In PGI, people can't listen to anyone whosoever he may be more than 5 minutes. I said, you have to listen to me or we move out of PGI. We don't have the conference in PGI. Okay? Chota bachcha samajh ke humko na bhala na re. So, I spoke for my 20 minutes. Then we had taken a decision. We need to change the pattern we run in INASL. Vivek was there, I was there, then Vivek was the president. And we decided we need to have INASL should run the conference. It should not be run by individuals or organized individuals. It has to be run by INASL. So that whatever money comes out of it, accrues, INASL gets it, and we then invest it in research, in development, in journals and other things. So this journal was the landmark journal, the landmark conference, the first conference. And I had then written to Kenneth. I said, look, Kenneth, what are you doing there in Europe and America? See, this is the land where you have maximum number of people, you can earn maximum here. So Kenneth people came running here and they organized this conference for us. 13, and this is, of course, the 2012 Guwahati conference. A lot of problems. We were threatened by one of the big hospitals in North India. They went around the country telling, INASL is nothing. What is INASL? The real conference will take place in our place. We have 25 leading hepatology experts coming all over the globe. Then I rang a pharma company. If you dare support this conference, you will face the consequences. And I'm sorry, I scuttled that conference. That conference had 25 international delegates, but not even 10 national, internal faculty, but not even 10 Indian delegates. They were nurses, they had to get in nurses and pharmacists to fill up the room. 2012 was a roaring success. You can see the who's who of hepatology. Just Bajaj, patting. He still remembers the name of that baby elephant. Paolo is there, Hari Kanjivaram, and the rest of them are there practically. So we had, this is just we had a very nice conference in spite of all odds. Then I thought, in one of the meetings in Delhi, one of the gods of hepatology told, what is INASL doing? You should be publishing guidelines, you should have guidelines on different diseases, you are not doing anything. I told him, sir, we will have a guideline on every possible conceivable subject in hepatology within the next 5-6 years. And we set about that, and now we do have one of the best guidelines on different aspects of liver diseases. Hepatitis B, NAFL, different aspects of Hep B, pregnancy. Now, the portal cavernoma cholangiopathy consensus statement, this was planned much earlier by Dr. Dhiman, but after, when I came over, we had these HCV meetings in Lucknow, plus Acharya, you can see him there. We had this consensus meeting later on nutrition and liver disease again at Chandigarh. It's again Dr. Dhiman and all that planned. But in addition, a lot of other meetings were held. We had this position paper on NAFL. One of my senior hepatologists, he always wanted a book to be published. And every secretary, be it ISG or be it INASL, used to, sort of, oh, we don't need a book. There are so many books there. So I said, no. I told Premashish Da, you will have a book. When I am Secretary General, you will definitely have a book. It may not be a big fat book, but we will have one. We will at least start off with volume 1. But that was all. Volume 2 never came out. So this was the one which was released in Guwahati, INASL Clinical Manual of Liver Disorders. Then I thought, with all this, we need to cooperate with other societies across the globe. I reached out with INASL, had a meeting. We had a meeting in Vienna. I took Dr. Dhiman along with me because my term was going to come to an end. You can't be the secretary for more than 6 years. But unfortunately, it didn't take off as well as it should have. My tenure of Secretary General ended in 2015. There are a lot of learning curves. I ran the society without any association management, without anyone. I was secretary, I was everything. I saved at least 20-30 lakhs. But still I was blamed by a lot of people for my inadequacy, my incompetence. I got it registered, I got a PAN number, I got a TAN number, I did everything which INASL didn't have. But anyway, hepatologists who were after me when I was Secretary General think, sir, just look the other way after that. Once I was no more Secretary General, I learned that. I never thought hepatologists would treat me like that. The new dispensation treated me with contempt and disdain. I was asked to cancel 2 major meetings we had planned when I had planned as Secretary General. I was asked to cancel the Andaman meeting, Andaman Hepatitis B consensus meeting. I had got everything done, And I was asked to cancel the ACLA meeting scheduled to be held at Gopalpur. I agreed to forget the Andaman's meeting, but I said Gopalpur meeting, I dug in my heels. I decided it was time to take the bull by the horns. I got this acronym CARE. We had a meeting in Gopalpur, Consortium for ACLA Research in the East, a very nice meeting. Now everyone always tells me, please hold another meeting in Gopalpur. They are not interested in ACLF, they are not in anything, they are in Gopalpur. These are some glimpses from that meeting, and this is the publication ACLF in India, the Indian National Association for Study of Liver Consortium Experience. Check the phatte. I waited for 2 years for the HBV task force to convene a meeting for formulating guidelines. It didn't happen. I said enough is enough. I then caught my friend SP Mishra, look, ISG must have its guidelines. If INASL is not interested, ISG must have it. And deliberately I did that. And then the men in INASL then decided to request me to organize a meeting on the aegis of INASL, to which I acquiesced. I wanted that to happen. We had a meeting on 11th and 12th February 2017. I had already had 2 meetings earlier. First in Mumbai in 2010. See, no guideline came out. Second meeting in Bhubaneswar, it was scuttled. by 2 luminaries. Gone. Third, Andaman first attempt didn't happen. Second attempt, we did have a very successful meeting. This is the famous Kalapani, the jail at night, the soundlight program going on. Everyone enjoyed the meeting. We had 2 days of brainstorming, and we had it there because 66% of Jarawas had been infection. So we thought it was the right place to have it. So we published the work. I thought I need to mention this. The World Hepatitis Day, we studied it 2001 in Cuttack. This is Bloomberg's notes on his biography, which surprisingly he sent to me. Then I later on, in 2005, INASL was the first body to endorse World Hepatitis Day before WHO did. Then ISG followed. Pediatrician didn't, other organization didn't. There were a lot of resistance from some organizations in Delhi. They said, we have our own day, why do you want to have another day? I said, no, 20th July will be the day. 19th May 2008, I was in Geneva to launch the World Hepatitis Atlas. And finally, my dream came true. 2001, you can see me holding a crutch, my hair, and 2010. It took 10 long years. And after that, yes, INASL has treated me in a much better way. We had this NAFL-SASL-INASL consensus. Thanks to Corona, we learned to handle anything and everything. On Zoom, we had this World Hepatitis Day meeting. And then the global consensus people ignored us. They didn't call. Indians, we didn't matter to them. I said, no way, if you don't invite us, it's up to you. You may not invite us, but then don't call it global. This is my request. So after 1.5 years of pestering, they gave up. And here is the INASL tie with the INASL logo. I was there in Chicago, ringside view, and then again in Washington, and from there I landed in the home of hepatology, that is Geneva INASL office. So I'm very happy that things are where they are today, vis-a-vis INASL's position in the global hepatology, in the world of hepatology today. And yesterday my daughter had come to see what her dad is doing here. Anything worthwhile? So there should be some take-home messages at the end. Think big, whatever your size may be. I have taken on a lot of Goliaths. Indian, American, European, doesn't matter. I am not afraid. The sky is not the limit. You can do anything you want, provided you really want it. What limits your goals is your mind. And you all must have read, if wishes were horses, beggars would ride. Right? Absolutely right. Yes, they would not ride, but fly to Chicago, Washington, D.C., Geneva, and I don't know, so many places. This is me, my own photograph. Thank you. My family joins me in thanking you all for this opportunity. Thank you all.
Thank you, sir. I think for taking us through your journey with the INASL, and we salute you for your significant contribution to the Indian National Association for the Study of Liver. Thank you very much. We are learning and we will continue to learn from you. May I request you to please come in the center for the felicitation.
session. The chairperson of the same are Professor Dr. Anil C. Anand, Kalinga Institute of Medical Sciences, Bhubaneswar, Dr. Anup Saraya, AIMS, New Delhi, Dr. Abhijit Chaudhary, Indian Institute of Liver and Digestive Sciences, Kolkata, Dr. C. E. Apen, Christian Medical College, Vellore. We request our chairpersons to kindly chair and judge the session as well, and requesting Dr. Ajay Duseja to guide them with the instructions.
Sir, as mentioned in the program, there are 5 presenters, and each presenter has total of 12 minutes, so 9 plus 3, which means that the timing is for 9 minutes and 3 minutes is for discussion and the question answers. And as I said, we'll giving you the scoring sheets as well, so we'll request you to kindly judge them on the basis of their originality, novelty, timekeeping, and presentation. And uh, we will score them together for all the judges after this is over. So 9 plus 3 is the.
Thank you. I think this is time to start the plenary session. May I invite the first speaker, Dr. Swagat Majumdar, and she's going to talk to us on sponging of 5 convergent tumor suppressor microRNAs by Inc. RNA. It's a long name, promoter, hepatocellular carcinoma. I don't know how you pronounce it, so we'll listen to you. Your time is 9 minutes, and we'll have 3 minutes for discussion.
Okay. Good morning, everyone. This is Shagota Mujumdar from IPJMER, Kolkata, and my today's topic of discussion is sponging of 5 tumor suppressor microRNAs by LNC-RNA KCNQ1-OT1 promotes hepatocellular carcinoma. So to start with hepatocellular carcinoma, it's not changing. So to start with hepatocellular carcinoma, or HCC, which is the 6th most common cancer and the 3rd most common cause of cancer-related mortality worldwide. Viral hepatitis infection is one of the most important etiologies of HCC, which causes chronic inflammation in healthy liver, promotes fibrosis, progresses through cirrhosis, and culminates to HCC. The available treatment modalities of HCC involves both curative and non-curative treatment. In the non-curative one, we have systemic therapy, of which the most important is sorafenib, which is a multi-tyrosine kinase inhibitor that blocks important pro-tumorigenic pathways and promotes apoptosis. But sadly, it increases the life expectancy by 6 to 9 months only, so we should look for other effective therapy. Now, carcinoma development has multiple regulatory checkpoints, of which the most important is the post-transcriptional regulation. And non-coding RNAs, mainly microRNAs and long non-coding RNAs, are main drivers of this kind of regulation. So in our lab, we have next generation small RNA sequencing of HCC versus control liver tissue specimens, from which we obtained a list of deregulated microRNAs. From the downregulated microRNAs, we have selected this topmost 6 microRNAs based on this criteria. That is, a log to fold change should be less than -1.5 and with significant p-value. Next, the GEO dataset further confirms our observation that these 6 microRNAs to be globally downregulated in viral hepatitis infected HCC. QRT-PCR validation in more number of both HCV as well as the HBV infected liver tissue specimen strengthens our observation that these 6 microRNAs are downregulated. Next, to understand the molecular mechanism of these microRNAs, we did the cake pathway analysis with their predicted targets and found a very interesting phenomena that 5 out of 6 microRNAs are targeting a single pathway, that is the signaling pathway regulating pluripotency of stem cells. 5 out of 6 microRNAs except for MIR451A. Next, we did the MIRNet analysis, and it identifies the genes which are falling under the category of the signaling pathway regulating pluripotency of stem cells and are commonly targeted by these 5 microRNAs. And these genes are BMPR1A, BMPR1B, ACVR2A, and ACVR2B, which are interestingly both type 1 and type 2 receptors of the BMP signaling cascade. Coming to the cancer stem cell or CSC properties, CSC is a small subpopulation of cell which are having some unique characteristics like self-renewal, chemoresistance, and EMT. We want to explore the role of these 5 microRNAs in in regulating the CSC properties. And why? Because as previously mentioned, they were commonly targeting signaling pathway regulating pluripotency of stem cells. So to do this, at first we cloned and overexpressed these microRNAs in HCC-specific cancerous cell line HU7 and did some of the experiment relevant to the CSC properties. And as you can see in the tumor sphere formation assay, mid overexpressing cancerous cells were showing a significantly lesser number of spheres than the anti-mid treated cancer cells or the vector treated cancer cells. In case of chemosensitivity assay, the mid overexpressing cancerous cells were showing more sensitivity towards the drug 5-FU than the other two sets. EMT or epithelial to mesenchymal transition is one of the hallmark features of CSC, and we found that the mid overexpressing cancerous cells were showing lesser number of EMT marker gene expression than the other. Mid overexpressing cancerous cells were showing significantly lesser migratory as well as the invasion property. So overall, we have concluded that these 5 microRNAs are convergent tumor suppressor microRNAs, and upregulating these microRNAs would be beneficial in regulating CSC properties. Now, as I have mentioned that these 5 microRNAs are commonly targeting both type 1 and type 2 BMP signaling receptors. So in order to explore their role in CSC properties, we blocked both type 1 and type 2 receptors with the ASO, that is the antisense oligo treatment, and we repeated the same experiments and found the exactly comparable data. So here we observed that either upregulating the microRNAs or downregulating their direct targets were showing comparable data. So 5 microRNAs are altering CSC features through the BMP signaling cascade. Next, we want to explore how these microRNAs are getting regulated. So microRNAs can be transcriptionally or post-transcriptionally regulated. At first, we expected them to be transcriptionally regulated, so we checked the premier expression in control versus HCC liver tissue specimens, but found no significant changes. So we opt out for the post-transcriptional modification. So one of the principal mechanisms by which mature microRNAs can be post-transcriptionally regulated is by long non-coding RNA or LNC RNA, which can act as competing endogenous RNA and thereby sponging microRNAs and block them to function. Bioinformatic analysis revealed that these 5 microRNAs can be targeted by a single LNC RNA, KCNQ1-OT1, which we found to be one of the topmost upregulated LNC RNAs we found in our cohort. And this is the exact same cohort we have been previously used for the next generation small RNA sequencing. So the QRT-PCR expression validation revealed that KCNQ1-OT1 is one of the topmost upregulated LNC RNAs. Knocking down the KCNQ1-OT1 by CRISPR-Cas9 technique reveals in absence of KCNQ1-OT1, the individual 5 microRNAs are upregulated. And finally, the biotin streptavidin magnetic pull-down assay confirms the direct physical association between the microRNAs and the LNC RNA. So we overall concluded that the LNC RNA KCNQ1-OT1 is a potential oncogenic LNC RNA that sponges 5 microRNAs. Now, as I have already discussed the role of these 5 microRNAs in modulating CSC properties, and here one single LNC RNA KCNQ1-OT1 acts as a master regulator and sponges all of these 5 microRNAs. So we hypothesize it must have some role in modulating CSC properties as well. So to explore this, we knocked down KCNQ1-OT1 again with the CRISPR-Cas9 technique and repeated the same experiment. And as you can see, in absence of KCNQ1-OT1, cancerous cells are behaving similarly. Lesser number of spheres generated, showing more sensitivity towards the 5-FU chemotherapeutic drug, lesser EMT marker gene expression, lesser migratory and invasion potential. We finally validated our observation in vivo in NOD skid mice. And as you can see, in absence of KCNQ1-OT1, the tumor size and volume is drastically reduced. So we finally concluded that blocking LNC RNA KCNQ1-OT1 would be a beneficial in regulating CSC properties. So to summarize the whole scenario, KCNQ1-OT1 is significantly upregulated in HCC, thereby sponging 5 tumor suppressor microRNAs. In absence of this microRNA, their direct targets, that is the type 1 and type 2 BMP receptors, are getting activated, thereby resulting in the constitutive activation of the BMP signaling cascade and modulating the CSC properties. So blocking KCNQ1 OT1 would be beneficial and better therapeutic approach in case of HCC. I would like to acknowledge my guide, Professor Shoma Banerjee, our director, sir, Dhali sir and Chaudhary sir for their constant support, Dr. Subhash Gupta sir and Dr. Shalin Agarwal for providing us the liver tissue samples, all my co-workers, and of course, all the patients who have participated in the study, and UGC for funding my fellowship. Thank you.
Thank you very much. The paper is open for discussion and questions. Please, sir. Actually, most of us probably do not fully understand the process involved in this research. So we'll love to have questions.
There's a lot of science, congratulations. But I have certain basic questions. Because if you see the gene which you knocked out, actually upregulated the microRNA, which prevents more differentiation of liver cancer. That is your message, which is shown in cell line, also in animal models. Okay, and that predominantly works on stem cells, right? And you see in primary liver cancer, about some people comes from stem cell mutation, because HCC is a multi-step genetic mutation which can happen in stem cell. They are usually aggressive tumors clinically, but HCC per se, because of matrix modulation, right, in the liver cell per se can become a stem cell because of various types of mutations, starting from telomere mutation, telomere promoter mutation, cell cycle synthesis mutation, and various other mutations which occurs over a period.
So request you for a short question, sir.
Are you asking this is selectively working for stem cells, or it is working, this knockout is working for, in general, for all liver cancers?
Sir, can you please repeat this?
I have a similar question. I have a similar question. One is, okay, you showed this long non-coding RNA is involved in the whole MIR process. In clinical practice, how do you expect to take it to the patient without using siRNA or some target like that, which in clinical practice has not worked very well? So how do you take it to clinical practice? And two, because it might, like he said, it might involve other stem cells, what do you expect side effects, when you take it to clinical practice?
Okay, actually, sir, we are exactly planning to do so. As we have found that this LNC RNA is one of the, it can be one of the interesting therapeutic approach. So next we are trying to, nanoparticle mediated antisense oligo delivery to the specific tissue. And for that, we are trying to modify the nanoparticle surface with the ligand specific for the receptors. Like if you want to deliver the nanoparticles to the hepatocytes, so we are trying to modify the surface of the nanoparticles with the ligand specific for the asialoglycoprotein receptor 2, ASGR2, which is specific for the hepatocytes. So we are planning to do so.
Thank you, Swagata. I think the time is up. Thank you very much.
Thank you.
The next talk is by Dr. Manas Vaishnav. He is going to talk about comparison of 1-day versus 3-day terlipressin in cirrhosis with varicose bleeding, an open-labeled randomized controlled trial.
Good morning, everyone. I am Dr. Manas Vaishnav. I am going to present my study titled as Comparison of 1-day versus 3 days intravenous terlipressin in cirrhosis patient with acute variceal bleeding, a randomized controlled trial. This study was conducted at All India Institute of Medical Sciences, New Delhi, and I am presenting on behalf of my team. I have no disclosures. So, acute variceal bleeding is a common and sometimes a fatal complication seen in cirrhosis patient, occurring at around 10 to 15% per year. 5 days rebleeding and mortality are in the range of 2 to 8% to 8 to 12%. 42 days rebleeding rates are in the range of 3 to 30%, and 42 days mortality is in the range of 15 to 20%. Amongst these patients, most common cause of death is being uncontrolled bleeding followed by sepsis. These patients have standard medical treatment in the form of combination therapy of intravenous vasoactive agents like terlipressin, somatostatin, or octreotide, plus endoscopic varicose band ligation. Available literature and various international society guidelines like ASLD, Bavino, APSL suggest variable duration of therapy in the range of 2 to 5 days. So, optimum duration of vasoactive therapy post endoscopic band ligation is a matter of debate. There have been multiple randomized control trial comparing short course of vasoactive therapy to that of a standard duration, and these studies have found that there have been no differences at 5 days rebleeding rate, 42 days rebleeding rate, and 6 weeks mortality rate between the short course and the standard duration of therapy. So, in our study, we aim to compare efficacy of 1 day versus 3 days terlipressin therapy in cirrhosis patient with acute variceal bleeding post endoscopic intervention. The primary objective of our study was to compare rebleeding rate at 5 days between patient randomized to 1 day and 3 day terlipressin arm. The secondary objectives were rebleeding and mortality at 6 weeks, differences in HVPG measured on day 1 and day 3, and occurrence of adverse events in both the groups. We screened all consecutive patients presenting with cirrhosis and acute variceal bleeding between August 2020 and October 2022. Those who were suspected to have variceal bleed were started on IV terlipressin. This patient received upper GI endoscopy within 12 hours of index presentation. Endoscopic variceal band ligation was performed if indicated, and after that, patients were assessed for eligibility and randomization. HVPG measurement was done after randomization. Patients were randomized into 2 arms, 1 day arm and 3 days arm. Those who have been randomized to 1 day arm received IV terlipressin 2 mg 4 hourly for 24 hours. Those who have been randomized to 3 days arm received IV terlipressin 2 mg 4 hourly for 24 hours, followed by 1 mg terlipressin 6 hourly for next 48 hours. After the cessation of vasoactive therapies, patients were started on carvedilol. Repeat HVPG measurement was done at the end of day 3. We performed block randomization with the block size of 6, and allocation concealment was done using sequentially numbered opaque sealed envelopes. We included all cirrhotic patients with acute variceal bleeding who underwent EVL. We excluded those who had acute on chronic liver failure, chronic kidney disease, spontaneous bacterial peritonitis, variceal bleeding secondary to non-cirrhotic causes, and malignancies. Sample size calculation was done based on the prior study by Azam et al. The non-inferiority margin was chosen to be 5%, and for achieving 80% power at 5% level of significance, a sample size of 150, that is 75 in each arm, was calculated. Coming to the outcomes, the primary outcome of our study was rebleeding rate at 5 days. And secondary outcome of our study was where 6 weeks rebleeding rate, 6 weeks mortality rate, HVPG response rate, and adverse events. These patients received standard medical treatment according to ASLD and Bavino guidelines. Upper GI endoscopy was done within 12 hours of index presentation, and those who had refractory bleed were received TIPS or Denisla stent insertion in the form of rescue therapies. So, out of 1200 patients who presented with upper GI bleed, 727 had variceal bleeding. We included 150 patients, 75 in 1 day arm and 75 in 3 days arm. After inclusion, one patient from 1 day arm was detected to have extrahepatic portal venous obstruction, so this patient was excluded. Finally, 1 day arm had 74 patients and 3 day arm had 75 patients. The patient's baseline characteristics between the two arms were similar. The median age was 40 years, with almost 85% patients were male. The predominant etiology of cirrhosis was alcohol. The median MELD was in the range of 13 to 14. Almost 8% patient had active variceal bleeding at the time of endoscopy, and 75% patient will belong to child class B or C. So coming to the result part, the rebleeding rate at 5 days was 4.1% in 1 day terlipressin arm, and 3 days terlipressin arm was 5.3%. There was no differences between the two groups. Coming to the secondary outcomes, the 5 days mortality rate was similar, rebleeding rate at 42 days was similar, and mortality at 42 days was similar between the two groups, and there was no differences between the two groups. Coming to the portal hemodynamics, we had almost 60% paired HVPG availability, and when we compared the HVPG value at the day 3, sorry for the slide issues, the delta HVPG change, that is HVPG reduction from baseline day 1 to repeat measurement measured at day 3 was -1 in 1 day terlipressin arm and -2 in 3 days terlipressin arm, with no differences between the two groups. When we defined HVPG response rate as more than equal to 10% reduction, almost 47 to 62% patient developed this response with no differences between the two groups. When the HVPG response rate was defined as more than equal to 20% reduction, almost 1/3 patient had this response with no differences between the two groups. Coming to the adverse events, we observed that those who received 3-day terlipressin as compared to those who received 1-day terlipressin developed higher number of adverse events, with adverse events profile being similar between the two groups, and diarrhea and headache being the most common adverse events. Our study had certain limitations. Blinding was not done. Majority of patients did not have active varicose bleeding on endoscopy. Our study included patient with median MELD 13 and CTP 8 at presentation. This result may not be valid in patients with higher MELD and CTP scores. Not all patients had HVPG done due to COVID-19 pandemic. So, to conclude, ladies and gentlemen, in a cirrhosis patient with acute varicose bleeding who underwent endoscopic varicose band ligation, 1-day terlipressin is as good as 3 days terlipressin in controlling 5 days rebleeding rates, 42 days rebleeding rates, 42 days mortality rates, and HVPG response rate at day 3. However, those who received 3 days terlipressin developed significantly higher adverse events as compared to those who received 1-day terlipressin. Thank you.
Thank you very much, Manas. The paper is open for discussion.
Can I? Yeah. I think this is a good paper, but I would like to point out a couple of points. Now you're saying that everybody received EVBL, and then you're measuring the terlipressin after EVBL. So most of the studies were where vasoactive therapy was given as primary therapy without endoscopic. You look at the earlier papers. So once you've done successful EVBL, I think the duration of terlipressin therapy really doesn't matter much, I would think, clinically speaking. The second point is logistically, you from the time of presentation, within 12 hours, you've done your endotherapy, and immediately you've done your HVPG, and then you started your terlipressin. But the patients also received terlipressin from the time of admission till the time of EVBL or HVPG. So you really don't have a baseline HVPG to compare. You only have the HVPG measurement after you've initiated the therapies. So I would not expect that also to change significantly in the next 72 hours. I really don't know what measuring HVPG at those 2 points are going to benefit in terms of any clinical interpretation or correlation.
So, sir, that's a very good question. But when we see a real life scenario, it is important to perform endoscopic basically intervention to stop the bleed prior measuring the HVPG. And we measured HVPG after performing the endoscopic varicose band ligation, and patient had already received the terlipressin. So I agree that it may not be a real baseline HVPG as at the time of bleed, but we compared the similar outcome. So delta change may be the similar between the two groups. So that's the point.
No, I think
Excellent presentation, Manas.
Thank you.
My question is the basic premise, as Dr. Shiva said, of giving terlipressin therapies to try to plummet down the portal pressure so that the bleeding does not occur. till you do a definitive mechanical plugging of the varices, which was done. After that, why didn't you stop it? Why? What is the what is sacrosanct about continuing for 1 day, not 3 days? Why don't you stop it? Once you have seen the varices being plugged in front of you, no active bleeding, just stop it. So why not day 0 versus day 3?
Yeah, yes, sir. So when we searched, when we formed this research question, we had this question in mind. But the available literature has suggested that prolonging the overall data has suggested that giving after 24 hours should be given. There have been studies who have compared 0 day versus 5 days, 0 day versus 3 days, but we choose to design the trial in this manner.
Manas, are you aware of another paper on this from PGI Chandigarh?
Sir?
A similar paper on this from PGI Chandigarh. What were the results?
Sir, I am actually not aware.
It is already published.
Yeah.
So what were the results there?
Sir, I have to check, sir.
Okay, thank you very much.
Yeah. Thank you, sir.
The third paper will be presented by Dr. Pratibha Garg, and she'll be talking to us on integrated, unsupervised and supervised machine learning unveils the unveils and predicts the clusters with distinct profiles and survival in acute and chronic liver failure. Are you all right?
Yes. So, good morning everyone. On the behalf of Department of Hepatology, I, Pratibha Garg, PhD student of Dr. Nipun Verma, will be presenting today's plenary talk entitled Integrated, Unsupervised and Supervised Machine Learning Unveils and Predicts the Clusters with Distinct Profiles and Survival in Acute and Chronic Liver Failure Cluster ACLF Study. We understand ACLF is a heterogeneous entity and more than 40 different definitions exist for the syndrome. However, the common denominator remains the same for all of them, that is acute insult manifesting over an underlying chronic liver disease leading to a gamut of signs and symptoms. And this heterogeneity is beautifully explained by this European group, where they have explained 3 different phenotypes of acute decompensation and further 5 different grades of ACLF ranging from grade 1A, 1B, grade 2, grade 3A and 3B. There are 50 different permutation and combinations possible for the presentation of this syndrome, which are quite challenging to interpret through inferential statistics. And we understand that machine learning is superior and more precise to recognize complex linear association between the data points to understand such heterogeneity. There's already a lot of pre-existing studies that have demonstrated the utility of machine learning models in phenotyping heterogeneous syndromes such as diabetes, sepsis, ARDS, OSA, and we have also previously used machine learning to predict mortality with high discriminating capacity in APASL ACLF patients. So we thought a question to ourselves, what if we take all the ACLF incomers and put their clinical data into machine learning and let the machine itself understand the complexities and let machine give us the different phenotypes based on the clinical characteristics? That is an unsupervised machine learning approach. And once we have got different phenotypes and we can understand the differences between them and we could correlate them with the outcomes, we thought of integrating the supervised machine learning to predict these different phenotypes identified. So in this study,
so good morning everyone. I am Dr. Ashrita, Senior Resident Department of Pediatric Hepatology, ILBS. I'll be presenting my topic, that is analysis of plasma bile acid composition in Indian children presenting with progressive familial intrahepatic cholestasis. So as we all are aware, that progressive familial intrahepatic cholestasis is a group of inherited cholestatic disorders which mainly results from defect in one of these transporters present at the biliary canalicular membrane of hepatocytes, or defect in the proteins which are responsible for synthesis and intracellular trafficking of these transporters. After the initial discovery of the first 3 genes, that is PFIC 1, 2 and 3 so-called, that is ATP8B1, ABCB11, and ABCB4. In the last decade, multiple new genes have come up and they are known to cause a similar spectrum of disorders, difficult to differentiate only based on clinical history. The estimated prevalence of this disorder is 1 per 50,000 to 1 per 1 lakh births. And in Indian setting, it accounts for around 8% of the total cases of neonatal cholestasis and 34% of cholestasis beyond the neonatal age group. We all are aware that the total bile acids are elevated in PFIC, but is there any implication of bile acid composition in diagnosis, prognosis, and treatment? The data is very scarce. One of the major studies published was in 2018, wherein the serum bile acid composition was compared between patients of ABCB11, that is PFIC2, and healthy controls. So what they observed was that the secondary bile acids were present in the serum despite absent BSEP expression. So this raised a question that probably there are alternative routes of excretion of primary bile acids despite absent BSEP transporter. And they also noticed that there was increase in glycine and taurine conjugates of primary bile acids, that was cholic acid and chenodeoxycholic acid, as compared to the cholic acid and chenodeoxycholic acid per se. So that probably suggests that hepatocytes are adapting to make the intracellular environment more or less hepatotoxic. They came up with a diagnostic panel wherein they saw that in ABCB11 there was increased detection of lithocholic acid, taurolithocholic acid, glycolithocholic acid, and hyocolic acid as compared to healthy controls and other undiagnosed cholestatic disorders. Apart from this, they also observed that the taurine conjugates of the hydrophobic bile acids were significantly lower in the UDCA treated patients. A similar study was done by Emmerich et al., but this time they analyzed the bile acid composition in the bile and especially pre and post PEBD therapy. And what they saw was that the post-biliary diversion, there was a trend towards increase in CDCA to CA ratio in the bile. This paper from 2012 was done in primary biliary cholangitis, not in PFIC. But they also showed that there was a trend towards reduction in taurine conjugates after UDCA therapy. So what I want to emphasize is probably bile acid composition will help in analyzing the diagnosis as well as in prognosticating. So with these studies in the background, we hypothesize that probably the PFIC subjects will have altered bile acid composition in plasma, which may differ among its subtypes and hence may help in diagnosis and prognosis. Our primary objective was to analyze the composition of plasma bile acids in PFIC and compare it with healthy controls. And a secondary objective was to compare the plasma bile acid composition among different types of PFIC. We included all children who were less than 18 years with genetically proven PFIC with clinical and biochemical evidence of cholestasis and histopathological evidence of intrahepatic cholestasis. We excluded those mutations which were unrelated to PFIC spectrum. So it was a cross-sectional study. We collected EDTA sample at the time of enrollment. Patients who were already on UDCA therapy, we did not stop the drug owing to presence of intense pruritus in them, but the dosage details were documented. The plasma was separated by centrifugation and stored at -80 degrees till analysis. Then it was subjected to global untargeted metabolomics using a high performance liquid chromatography and using the C18 column to separate the bile acids. The bile acids separated this way were identified based on their monoisotopic mass and was matched with error less than 0.0001 Dalton. We used SPSS version for analysis. Our data was not normally distributed, so we used non-parametric tests for analysis. So this is the baseline parameters of the subjects who underwent plasma bile acid composition analysis. So we can see that majority of them belong to the BSEP type of PFIC, followed by MDR3, TJP2, and FIC1. The median age at the time of analysis was 11.5 months. The median serum bile acids was 122 micromole per liter, and almost 75% were on UDCA therapy and 25% were treatment naive. The median UDCA dosage was around 20.6 milligram per kg per day. And out of them, 12.5% were already transplanted. So after eliminating the post-transplant patients, we analyzed the bile acid composition and compared it with healthy controls. So what we saw was there was elevation of both cholic acid as well as chenodeoxycholic acid in PFIC as expected, but the elevation in the chenodeoxycholic acid was significantly high. Along with that, there was elevation in the glycine conjugates of primary bile acids as well as secondary bile acids, and reduction in the taurine conjugates of the primary and the secondary bile acids in the PFIC group as compared to the healthy controls. But when it came to UDCA per se, even the UDCA was comparable in both the groups, but the taurine and the glycine conjugates were significantly elevated in the PFIC spectrum. So this is a heat map demonstrating the same. So we can see here that the glycine conjugates are significantly elevated as compared to the taurine conjugates, which were significantly lower in the PFIC spectrum. So when we did an intra-group analysis between the different types of PFIC, here we only took those type of PFICs which had more than 5 samples each. So what we saw was, except cholic acid, which was higher in BSEP and FIC1 as compared to TJP2 and control group, rest of the biliary acids were comparable between the 4 group, but was the other comparison was similar to what I've already told, that is between the healthy controls and the PFIC spectrum. So to conclude, that the plasma of all subtypes of PFIC showed a greater concentration of relatively toxic CDCA, as well as increased glycine conjugates of primary as well as secondary bile acids. In contrast, the taurine conjugates of both primary and secondary bile acids were significantly lower in PFIC cases as compared to healthy controls, and unfortunately we could not find any intra-group differences. Our limitations was that the sample size was lower, and the correlation of plasma bile acid composition with survival could not be done, as there were only 2 deaths after the collection of samples for analysis. Comparison between pre and post diversion also could not be done because of cross-sectional nature of the study. These are my references. Thank you.
Thank you very much. The paper is open for discussion. Can I ask the first question?
Sure.
Do you think this is the relative bile acid concentrations that you have shown? They reflect the true concentration of these bile acids in PFIC, or it is the effect of UDCA?
Sir, it could be the effect of UDCA. Ideally, to see in the disease per se, we should have stopped the UDCA, but owing to intense pruritus, we had not stopped. But reduction in taurine conjugates have been proven in previous studies also, that UDCA therapy per se can cause reduction in taurine conjugates.
Okay. Dr. Koshi?
The change in bile acids, you're not going to use it for diagnosis, because diagnosis has to be genetic anyway.
Yes, sir.
So unless you say that this change has some implication for therapy, you can use UDCA in one type or bile acid diversion in another type. It doesn't have much significance, clinical significance. So what do you think, where does it take you?
Sir, actually, based on that study from Liver International, as I've told, that they actually gave us a diagnostic panel for ABCB11 mutations, we thought probably we can identify the intra-group differences between different types of PFIC, and lesser than the genetic test, probably we can diagnose this. That is what was our intention, and probably prognostication in future.
Yeah, my question is, you have bile acids which have to be excreted into the biliary system
Right,
after
sir.
conjugation.
Yes.
Now, how can the different receptors be cherry picking taurine, cholic acid versus chenodeoxycholic acid and putting it selectively into the biliary system? And in any case, if you have viral hepatitis, drug-induced hepatitis, or any cholestatic jaundice, there will be regurgitation back into the circulation. So what is the relevance of this? Neither does it tell you the specific genetic mutation, neither the cause nor the etiology. Then how does it help?
So the intention was only to differentiate different types of PFIC based on the bile acid panel, but unfortunately we did not get any result.
Yeah, just a small question. All the patients were on UDCA?
75% of them were on UDCA and 25% were treatment naive.
Okay. But then the serum levels of UDCA were so low. I thought the whole purpose of UDCA was it was supposed to replace endogenous bile acids and become the dominant bile acid.
Yes, sir.
But I don't see any difference in
Yes, there was
UDCA
no
levels in controls or patients or treated or anything.
Yes, sir. So the
that means
UDCA.
UDCA was virtually ineffective.
Yes, but the conjugates of UDCA was quite significantly elevated in the PFIC diseased group as compared to the healthy controls.
Thank you, Ashrita.
Thank you, sir.
The last paper today is by Dr. Ashish Kumar. He is going to talk about the predictive scores for mortality in MAFLD related acute and chronic liver failure, development and validation of a MAFLD, MELD, sodium and MAFLD ARC scores.
Thank you, judges. So the topic, as Dr. Anand mentioned, it's predictive score for mortality in MAFLD related ASCRF. So the background of this study is that NAFLD related acute and chronic liver failure is increasing. With the increasing prevalence of NAFLD or MAFLD or MASLD, the new name, whatever you call it, there's an increasing prevalence of NAFLD, and so we see a consequent increase in ACLF also occurring in this population. So as you can see, India has got very high prevalence of NAFLD. So while there is good data on ACLF in general, as well as ACLF in specific populations like in alcoholic liver disease or HBV related patients, studies specifically on ACLF occurring in MFLD patients are lacking. We do not know what is their outcome. We do not know what is the predictors of mortality. So we had 3 research questions and consequently our aims. The first research question is that what is the 90-day outcome of patients who develop ACLF and underlying NAFLD? What are the baseline factors which determine the 19-day outcome in these patients? And can we tweak the commonly used severity scores such as MELD score or R score to better assess the mortality risk of these patients, ACLF patients? So I'll combine methods as well as results in my description. So we took the patients from the ARC database. The ARC database consists of centers, more than 95 centers from all the Asia Pacific region under the APASL. And now this consortium has got more than 9,000 patients with varying degree of follow-up. So we requested the ARC database to provide us data. So we got data of about 3,000 patients who had 90-day outcome recorded. So data consisted of etiology of chronic liver disease, etiology of acute precipitant, baseline variables, treatment variables, hospital course, and 90-day outcome of all these patients. From this, we excluded those patients whose etiology was other than NAFLD. So we excluded alcoholic liver disease, HBV, Wilson's, autoimmune, and we included only those patients whose etiology of chronic liver disease was labeled as NASH cirrhosis or NAFLD or NASH or MFLD by the treating unit. So we had 369 patients, and then we randomly divided these patients into a derivation cohort, which consisted of 70% of patients, and validation cohort. So our derivation cohort and validation cohort was very well matched. I would like to point you on all these patients had underlying NAFLD or NASH cirrhosis. So the precipitant or acute etiology was predominantly HAV or HEV, that means viral etiology in about 30 to 40% of patients, DILI in about same number of patients, sepsis in about 20% of patients, or unknown etiology in about 20% of patients. All these patients were very sick. Their MELD score was about 30 and MELD sodium score was around 30 to 32. And all these patients had approximately, both validation and derivation cohort had similar mortality of approximately 50%. So now I'll focus only on derivation cohort, which is 258 patients. Their 90-day mortality that approximately 51 patients only survived,
and 49 patients died. In our cohort, none of the patients had actually liver transplantation. So this is in absence of liver transplantation. So when we looked at the baseline factors predicting mortality in the univariate analysis, we found that the usual predictors were platelet, bilirubin, high bilirubin level, INR, creatinine, which are the usual predictors of mortality in any ACLF group of patients. Apart from that, we also found that presence of diabetes also influenced the mortality, and the precipitant, what precipitated ACLF, and especially non-viral etiology was a significant factor in the univariate analysis. When we entered these in the multivariate analysis, again we found that diabetes as well as the non-viral etiology significantly predicted, apart from the usual predictors of mortality. So now our next question was, can we tweak these new factors which we have found, that non-viral etiology and diabetes, can we add those into the standard severity scores like MELD score or ARC score? So now we entered these factors into the multivariate analysis. So we use the MELD score plus diabetes plus etiology, and we use the binary logistic regression analysis. And as you can see, and then we picked up the beta coefficient from these and formed the equation. This is log odds of mortality. And when we multiplied both the sides with integers, so that we get a pure MELD score, and then we found out that if we add 12 points for diabetes and 12 points for non-viral, we can get a new score. So the new score is that take the MELD score, MELD sodium score, add 12 points if diabetes is present, add 12 points if the etiology is non-viral. For example, if the MELD score was 20, and if the patient had diabetes and if the patient had DILI, so we add 12 for this and 12 for this, so the new score would be 54. And similarly, we'll not add if the etiology was HEV, so we'll not add for the non-viral etiology, and similarly other. So the minimum score would be now 6 and maximum 64. And when we use this score and compared with the original MELD score with the new MELD score, and we find that the area under curve is much higher, 780 as compared to 715. And when we tested this new score in the validation cohort, again we found that this was validated and its area under score was higher. Similarly, many people now use ARC score. So can we tweak the ARC score using this diabetes and non-viral etiology? So we followed the same process, and we found that if we add 5 points to our score for presence of diabetes and 5 for non-viral etiology, we can get the similar score with a minimum of 5, maximum of 25. And both in derivation and validation cohort, the area under curve was higher. So what are the strengths of our study? This is the first study on MAFLD ACLF from all over the world, and with growing prevalence, this study was needed. The data is obtained from entire Asia Pacific, and the new scores are very simple. You just have to add 12 points for diabetes and 12 points for non-viral etiology to MELD score. Or if you are using R score, just add 5 points each. And we validated these new score in the validation cohort. However, there are certain limitations. It's a retrospective study, obviously, because it's a pooled data. And the diabetes data, we had only factored presence or absence. So we did not have whether the duration of diabetes and what was the glycemic control, because these performers did not have all these data. And certain other metabolic parameters which are important for NAFLD patients were not available, such as obesity and metabolic syndrome. So to conclude, 50% of MAFLD ACLF patients die by 90 years. And apart from the usual predictors like bilirubin, INR and all that, presence of diabetes is important, and presence of non-viral precipitant predicts mortality. And these new scores are very simple to calculate. You just have to add few points. And these are better at predicting the outcome as compared to the original scores. But these scores will need further validation in prospective studies. Thank you.
Thank you, Ashish. The paper is open for discussion.
Oh, well, Ashish, a good study. But did you compare diabetes and viral etiology with MELD versus ARC. You have the data to calculate the area under the curve in both derivation and validation model. Second, did you understand? You use ARC score and MELD sodium score. And to both you added diabetes and viral etiology and gave scores. You showed the combination in comparison to MELD alone is better. Combination in ARC alone is better than ARC. Did you compare the MELD with addition and ARC with addition?
MELD with the...
MELD with 12, ARC 5. Did you compare the area under the curve?
No, so the new scores had combination with the MELD plus diabetes and the...
That I understand.
Yeah.
I'm asking, you have compared in separate two cohorts each. Did you compare
the question is MELD ARC and MELD sodium, NAFLD MELD sodium. Which one is better out of the two?
Among the two, yeah. So I did not show, but we had all the 4 scores also, and among them the ARC was better than the MELD score.
Thank you.
Yeah, you mentioned the limitations. You mentioned it was good, and you mentioned that it requires validation. But there is one additional point which shows in your slide, especially for the ARC, that the derivation and validation scores, the area under the curve, it's a little apart from each other. So that's a warning sign that we need more validation.
Yeah, it's the limitation of being a retrospective data, and most of these patients actually of ACLF database have alcoholic liver disease and B. So very limited. Out of 3,000 we could get only 400 patients.
Shiva? Yeah, my question is with reference to your cohort. You've taken 369 patients, or all of them are one group. Then you divided them into 268 and 111. First, how did you decide which patients go into a validation? Initial cohort and then the validation cohort. How
this was done by random computer-based randomization. So for the derivation cohort, this is separate. Validation is separate. There are many ways of making the validation cohort. Like we can use a different center, or we can use different duration, and this is also one of the valid method of doing computer-based randomize.
So even though it's the same cohort, you're just applying the same criteria retrospectively to two different cohorts within the same group.
Yeah.
And you're still saying
so we derived it from one cohort and then we validated in a different cohort.
So in a prospective study, are you going to use only to predict mortality, or is it going to help you to decide upon liver transplant? Because these patients were not transplanted. So what are we going to do with this new scores?
So these new scores are predictive scores, similar to MELD score, similar to CTP score, similar to so many other scores. So where to get all these cutoffs for when to transplant, when to admit in ICU, we need prospective studies. Exactly. So this is actually a retrospective study, and we just found that these scores are better than the native scores.
So you're planning to do a prospective study?
Thank you very much.
Should be.
Thank you very much. No more questions.
Thank you.
Dr. Pratibha, are you ready? Please come. You'll have to start from where you left. I'm sorry, we can't give you the full 9 minutes now.
Yes, switch. So as I had already briefed about the heterogeneity and the complexity of the ACLF syndrome and how inferential statistics could not, interpret the different phenotypes. So we thought of implying machine learning to understand such complexities, and there are pre-existing studies that have demonstrated the utility of machine learning models to understand heterogeneous syndromes. So we thought of, integrating supervised machine learning with unsupervised machine learning. We started with giving our data to the machine. So the machine itself, understand the complexities among the data points based on the patient's prognosis and phenotypes. And we let the machine stratify the patients based on the inherent characteristics of these data points. Once the machine could identify the different phenotypes into and formed it into the clusters, we thought of integrating the supervised machine learning models to interpret these clusters. So in this study, we ambidextrally enrolled patients. The retrospective data was collected from 2015 to 20 and prospectively between 21 to 23. And after data cleaning, we had data of 1,568 patients. And we subjected these data points to three different clustering approaches, that was density-based, distance-based, and model-based approaches. Based on the validation matrices, which I'll be subsequently discussing, we proceeded with model-based clustering method for choosing our optimal number of clusters. And once we could identify the meaningful clusters, we could understand the evident differences between them. We correlated these clusters to their outcomes, and finally we integrated supervised machine learning models to predict the clusters that we identified. So these are the baseline characteristics of our patients. The mean age of the cohort was 44 years and the cohort was predominantly males. Most of the patients were fitting the APASL definition as well as EASL definition of ACLF, and alcoholic hepatitis was the most common acute decompensation. The mean MELD score of the cohort was 29 and cliff-off was 10, and as expected, the non-survivors had poorer disease severity scores and higher number of organ failures than the survivors. So this first slide of results is just to show, first we tested whether at all our data was fitting for such kind of clustering analysis, and yes, it was, which is shown by the Hopkins statistics, which was close to 1, and the diagram here shows the heterogeneity of the data. All in all, we did 9 different clustering methods, density-based, distance-based, and model-based. We tried several permutation and combinations based on the only categorical numericals, variables, both categorical and numerical, including baseline as well as dynamic variables. And overall, the distance-based and density-based clustering models showed unsatisfactory results as shown by these validation matrices, the Silhouette and Dunn's index. And finally, we went ahead with the model-based clustering, that was latent class model, and we identified 4 clusters with overall more or less equal proportion of patients in all these 4 clusters. Already simulation studies exist which have proven that the model-based clustering approach is better for predicting clusters in a data set where we have both numerical as well as categorical mixed model data. So the best model was chosen based on the minimum BIC score and the one having the minimum misclassification probabilities. Then we explored the clinical characteristics of these clusters that we identified. Cluster 1 was comprised mainly of the APASL ACLF group of patients, while cluster 4 had the maximum patients fitting EASL or EASL plus APASL criteria. More than one acute event, grades of HE and rate of infection progressively increased from cluster 1 to cluster 4 that we identified. And amongst cluster 2, there was lowest proportion of patients having alcoholic hepatitis, and this group was comprised of patients with the lowest rate of tensor grades of ascites. And looking at the disease severity scores, there was a clear gradient effect from cluster 1 to cluster 4 with the poorest grades, poorest scores amongst the cluster 4. And looking at the organ failures, there were glaring differences between the proportion of organ failures such as cerebral, circulatory, and renal from cluster 1 to cluster 4, while there were clear-cut differences in pulmonary, liver, and coagulation failure between cluster 1 and 4. The differences between cluster 2 and 3 were not significantly different. So just to summarize these clusters that we identified, the cluster 1 was mainly comprised of ACLF fitting APASL definition, higher proportion of alcoholic hepatitis patient with milder grades of ascites, largely without HE, lesser infection and low MELD scores with no leukocytosis, whereas the extreme cluster 4 was mainly comprised of EASL or a PASL plus EASL patients, denser grades of ascites, higher HE grades, higher rate of infection almost 80% and higher MELD score with severe leukocytosis. Cluster 2 was mainly comprised of female patients and viral hepatitis was the most common acute and chronic insult amongst them. Half of the patients were having infections, and cluster 3 was comprised mainly of EASL group of patients with moderate ascites, and 60% of them were having infections with moderate leukocytosis. So these were the basic characteristics. And then we thought of a question like, what is the utilization after we have identified these clusters? So we tried to look at the impact of outcomes of these clusters, and as we can clearly see, the patients in cluster 1 primarily survived, and of 4 they primarily expired, as shown by the Kaplan mirror analysis. There was an increasing rate of mortality from cluster 1 to 4, and mortality in cluster 2, 3, 4 was significantly higher compared to cluster 1, and this remains significant even after adjustment for CLIF-C ACLF. And we made a model in which adding this cluster information to infection, ACLF definition and CLIF-C ACLF, it improved the prognostication power of CLIF-C ACLF by 11%. Finally, after having an idea of the differences of these clusters and its impact on outcomes, we utilized supervised machine learning phase, and we generated different models, namely extreme gradient boost, random forest and decision tree. Although the performance of extreme gradient boost model, including the dynamic variables of patient, had the best performance, but we use decision tree models because of their better explainability and deployability, considering the lowest number of variables it required.
Can you summarize your talk, please?
Sorry?
Can you summarize your talk?
Sure, sir. Finally, we use the decision tree model to predict these clusters, and it had a good accuracy of 80 to 90%. So finally, just to summarize just to see the implications of our findings.
Come to conclusion slide, please.
Sure, sir. So the conclusion was just that the machine learning for the first time could identify the clusters with distinct phenotypes and outcomes in ACLF patients. Stratification of patients into these clusters could guide their prognosis, resource allocation, and guiding liver transplant decisions in ACLF. Further studies are needed to assess utility of these clusters informations in evaluating treatment response in ACLF, as these variables such as socioeconomic factors, treatment related variables were not available when we did the analysis.
Thank you very much. We can have just 2 questions.
You had used machine learning for already added different clusters, because APSL doesn't do organ failure, right? Doesn't take previous decompensation, doesn't take sepsis. You saw that.
Yes.
Whereas ESL, SLD takes organ failure with acute decompensation criteria. So these are different clusters, very clear, right? And there will be a mixed bag. So why did you use machine learning when this is already clinically clear?
Sir, basically we tried to understand, we did not mention the outcomes directly, we did not give the machine a pre-labeled data set that okay, these are the survivors and these are the non-survivors. We just gave the clinical characteristics, and then we let the machine understand based on only the variables what is having what. The machine has segregated the patients.
So she has validated the existing 2 poles of ACLF definition.
Sir, the 2 poles
Okay,
as well
thank
as the
Any other question? If there are no other questions, then thank you very much. And we close the session. I'll request the judges to give the result sheet to the organizers.
Thank you so much to the people on the dais for judging and chairing the sessions. And thank you so much to all the speakers. Now we move ahead with Dr. S.R. Nayak Memorial Oration. The chairperson for the same are Professor Dr. S.P. Singh, President of INASL, Chairman of Kalinga Gastroenterology Foundation, Professor Dr. Ajay Duseja, Secretary General INASL, Professor and Head of PGIMER Chandigarh, Professor Dr. Manoj K. Sahu, Organizing Secretary INASL.
Good morning, everyone. So, welcome to this very prestigious Dr. S.R. Nayak Memorial Oration. A few words about Professor Nayak. Professor Nayak was born in Santa Cruz, Goa, and was brought up in a middle class family. And after completing his MBBS MD from Maulana Azad Medical College, New Delhi in 71, he worked as a registrar at Irvin Hospital, New Delhi. And then in 1973, he moved as lecturer in tropical medicine to Postgraduate Institute of Medical Education and Research, PGI-MER, Chandigarh, where he spent 9 years at various capacities. And during his period, he went on for 1 year to a Commonwealth Fellowship to St. Bartholomew's Hospital in London. And in 1982, he decided to move to KM Hospital, Mumbai, and in 87 to Lucknow to head the Department of Gastroenterology at the upcoming, Sanjay Gandhi Postgraduate Institute, SGPGI, Lucknow. There he also served as the Dean of the Institute. Dr. Nayak was a gastroenterologist with excellent clinical, teaching, and research skills, and his major interests in gastroenterology were viral hepatitis, particularly hepatitis E and hepatitis B, gastrointestinal motility, physiology, malabsorption, and gastrointestinal infections. Dr. Nayak laid a lot of stress on teaching of physiology and pathophysiology in addition to clinical methods. In Mumbai, Dr. Nayak started work on hepatitis B virus infection and the mechanism of its chronic persistence, and showed that the carrier state for this virus was related to the defects in antigen presentation and a hyperactive anti-HPS idiotype network and infection of host lymphocytes by the virus. He also did a lot of work in the community hepatology, and he investigated a large epidemic of hepatitis in Kanpur in 1991 and undertook several community hepatology projects. He also, scientific communication, medical writing, and editing were areas very dear to his heart. And Dr. Nayak was associated with the Indian Journal of Gastroenterology since its inception in 1982. So, Dr. Nayak left us in 2002. So, INASL started the oration in his memory in 2010. And the previous recipients of this oration, to name a few, are Professor S.K. Acharya, Professor Hollinger, Professor Hausinger, Professor Bernardi, Professor Sanyal, Professor Morgan, Professor Dushiko, Professor Patrick Kamath, Professor Kudo, and Professor Akbar, and last year was Dr. Swain. So for this year's Dr. S.R. Nayak Memorial Oration, I'll request our President, Professor S.P. Singh, to come and invite the orator.
It's my privilege to invite my friend, Professor P.N. Rao, who is the orator for this special prestigious oration. P.N. Rao, of course, doesn't need any introduction. He is just my opposite. You can see from the dress, and dress is only, that speaks volumes about. He Chandigarhite. He got his training in gastroenterology from PGI Chandigarh, worked with a lot of big people, and obviously that affects you, that grooms you, and that's why he's not only just a great hepatologist, but in addition, he's a gentleman par excellence, and then a hardcore INASL man. That's very important for me. Dedicated to INASL. That's very important. After a stint at Chandigarh, he moved on to different hospitals and headed a gastroenterology department. Later on, he decided no, hepatology needs his services. He had a special inclination for hepatology, so he moved from Nizams to Usmania. Then he's worked in Medivin Hospital in different capacities, headed different hospitals. The hepatology, developed hepatology there, dumped the endoscope. Like, most hepatologists, after DM hepatology, they are doing a lot of colonoscopies. He doesn't do endoscopy. And finally, he has settled down for, I think, last decade or more at AIG, Hyderabad. He's got a large number of publications, but most important is his dedication to hepatology and dedication to INASL. So friends, give him a big hand. He is the most apt orator for SR Naik's oration. I think he's worked with him also probably in Chandigarh, I'm not sure. Professor Rao, please.
Thank you, Shivram. Thank you very much. I thank INASL for two reasons. One is considering me fit for this oration, and second thing is it is in the honor of Professor S.R. Naik, whom I have got an boundless dedication, admiration, who has guided me through my MD and then DM in PGI. Two words apart from whatever has been said. He has got the highest standards of a clinical ethics, which I have imbibed from him from my younger days. Another thing which is there is a no nonsense as far as the research is concerned. And ethics in the research again was one of the highest standards which he has set in, right? And I am thankful for INASL for considering me. Thank you, Shivaram. Well, then the topic which I am chosen is a holistic management of NAFLD, rather an introspection, right? Let us see what we have achieved and then what we have to go. You know that the number of publications, and then I'm not going to go through all the important ones. And holistic and then holistic, both the words have been accepted by the Oxford Dictionary. I won't go into the holistic. That means holistic includes sometimes yoga, meditation, and all lifestyle things. But holistic means the entire data which we have should come to one platform for us to decide what we have to do. I shall not go into this, which you have been discussing. Tomorrow also we'll be discussing about the MASLD and the MAFLD. But suffice it for me to say that it is only an old wine in the new bottle. 2002 ASLD has said that metabolic steatohepatitis, but somehow there were no takers. 2011 MAFLD was coined again. Again there was no takers. But for the last 2 to 3 few years, the amount of the enthusiasm which people have shown just for the name MASLD and then MAFLD. I was wondering why S and then why F, and I was told that fatty is a stigma and therefore we want S. That's the answer which was given to me. And of course, what is in a name is an old adage, and this is now the present situation. Don't never argue with a pendant. Well, then why I have shown all these world maps? It is because of the close association, and it is basically We don't have a cause and effect relationship like HBV, HCV, Wilson, autoimmune. And the reason why the whole world, diabetes is going to go up, obesity is going to go up, alcohol is going to go up. And everything is based on these two comorbidities. If you ask me, the health industry is going to be on only two things. One is ALD and another is obesity. The two things are going to rule the world in future. I am pleased to see on the left-hand side that there is a global prevalence of even a non-obese or a lean NAFLD has also been projected. We know that it's a totally poor awareness and asymptomatic. That's the reason why it is invincible. And on the left-hand side, you have got the established associations, which are, we know that. I put it as a GEM, that's the genetic, environment, which includes the diet, drugs also, and the microbiota, and then which is now the buzzword for all the illnesses in our body. These comorbidities are the ones which have contributed to the words coming like an MASLD and then MAFLD, whatever it is. On the right hand corner, you can see that the genetic factor, there's so many factors, genes, which are trying to harm the liver, but their only protective factors are very few. So far, we have found only two protective factors, that HSD17B13 and MARC variant, which we have not found in Indian population in our studies. Well, then there are four always you will find. That is the PNPLA3 we know, and transmembrane 6S superfamily 2 is another very common. GCKR, which is related to the glucose metabolism. MBOT7 and again another one, and we have not found GCKR and the MBOT7 in our studies here in India, and mainly from our center and then other centers. The two important ones, why the two important ones are, as you can see on the top, that the NAFLD, the risk ratios is across the disease pattern, whether it is a fat accumulation, whether it is an inflammation, whether it is a cirrhosis, and then ultimately hepatocellular carcinoma. If you look at the other genetic polymorphism, they are lesser. The next one which comes into the race is only transmembrane 6 superfamily 2, that is TM6SF2. You find that there is a lower one is a protective gene, that is HSD17B13, which again we have not found in our studies when we look particularly at this point. That means that we do not have even this protective gene in our genetic disposition. Well, then what is the relationship between the gene and NAFLD? We have got a candidate genes and then the risk genes, protective genes, and other things which I am going to tell now. The last one, drug development. Even people have concentrated on the genes and targeting the genes for NAFLD treatment. Well, then we were one of the few first ones to detect the PNPLA3 association and then TMS also, and also seen a variant in lean NAFLD, and that is what's called the PEMT. And this is across India, not that I'm not all inclusive, but some of the important ones where they have shown association with the PNPLA3. There are variations are there in the proportions and the genes which one has found out, right? And even for India Institute, there has been a data. And recently from PHRI, Professor Shenoy is here. This is, of course, the abstract where they're going to a very good study in a large numbers, which compared with the biobank from the UK, and then there's going to be a good reference article about the NAFLD and the genetics in. And similarly, along with us, GCKR and MBOT, they have not been found in ours and also in their population from the Kerala. And we have done this unpublished data on a whole exome sequencing, small numbers, of course. But what is interesting to find is that we found that the rare variants are there, apart from the two which are there already, rare variants which are pathogenic. That means they have been associated with ALT and then AST elevations. And in some, the biopsy proven non-alcoholic steatohepatitis. That means we need more data on this, and there has been a diversity of our results from across the world and also even inside India also. Well, then I told you about what are the protective genes? These two genes, that is the HSD-B17B and MARC variant, have been found predominantly in the European population. And in our unpublished study, which is currently under review, we have not found these varieties. Both the protective genes we don't have. Whether there are more protective genes are there, we have to do still an extensive study on the genetic aspect. Well, then some people said, why don't you add a gene? Don't depend upon only one gene, add 1, 2, 3, 4. And then you will find the proof of concept study and then subsequent events have shown that if you add more than one gene, this is called a PRS, that is a polygenic risk scoring, and that is going to increase your risk identification and the risk stratification. Well, somebody said, why don't you add a gene and then a metabolic parameter? This particular study is in alcohol, but the genes which they have seen is NAFLD genes, not alcohol-related genes, right? We know that the genes PNPLA3 across all the liver diseases, whether it's a B, C, or alcohol, it adds to the progression of the clinical liver disease. And these people have added the gene and then add parameters. Look at this on the right hand corner. If the HOMA-IR is more than 2.5 and it is a GG allele, GG allele is a risk allele, then you got a chance of a 68% having advanced fibrosis as compared to the left hand side blue circle where your HOMA-IR is less than 2.5 and the CC, which is a protective allele, it is only 7%. That means this is the reason why. And some people said, why don't I add a clinical research scoring and then the genetic scoring? See, people have tried all types of combinations in predictions, and this is from the Biobank from the UK, and integration of the genetics genetic scoring and the clinical fibrosis scoring is certainly going to add to the prediction of the severity of the liver disease, mainly particularly in individuals who are at risk of a NAFLD. Well, then what about therapeutic interventions? People have seen that you give them a lifestyle on the top, you can see there, and the middle one is for the diet, and the last one is for the bariatric surgery. And they have found out that the interesting point is that allele gene is a risk gene as well actually. Actually, in these studies, it's been found that G has been protecting. Some of these variations still understood, we have to still explore. Allele gene associated with a greater reduction of intrahepatic component. This is for the lifestyles. This is for the diet. And this is for the bariatric surgery where and PNPLA3 and has been associated with, but not the other one. So there is a lot of amount of diversity is there. That means genes are important in predicting your therapeutic responses also. And look at here. And this is the one which says that the genes modulate the DNA in the liver. That means that people have treated the microbiome in the gut. And this proof of concept study shows that inside the liver, once the bacteria reach the liver, there also the genes are going to modulate, and it's been mechanism of a production of an alcohol in the liver. We have known that alcohol is produced in the gut. You know that when the policeman says and then sees, but you say I have not drunk, but still they may find out. That is, we know that the concept of alcohol production by the gut in the bacteria is now coming up. And this proof of concept study shows that this alcohol is produced in the liver itself. So this is a new concept which is coming up, which has to be further be explored. We have an IBD microbiome research lab which is there. A good microbiome research lab is there. And here we took volunteers, 25 volunteers, this IBD study, thanks to Rupa Banerjee who has given me this slide. And day 1 to day 28, volunteers who are doctors who have taken a Indian modified Mediterranean diet and look at that microbiome data from the stools on the day 1 and then day 28. Needless to say that bad food, bad bacteria, good food, good bacteria. And that is ultimately the concept, too much simplified a concept. So we have a lot of unresolved issues are there as far as the microbiota is concerned. It is still an evolving field. This what I said, candidate genes, gene plus parameters, polygenics risk scoring, gene microbial intervention. These genes microbial intervention has been seen diet and then gut microbiome, and drugs like an OCA has also been seen to alter the bile acid metabolism. Genes are important here again, and I have shown you that the liver and then microbiome and liver microbiome is also being influenced by, and therapeutic interventions I also told you. Then let's come to the environment. Genes have completed. As far as the environment is concerned, what have you achieved? Suppose if the data is given Mediterranean data, these data, many of the data are very good for reducing ALT, glucose, improves NFLD, but what about a fibrotic NASH? We don't have any certain guidelines for fibrotic NASH, what kind of a diet is going to be helpful. When you look at the Mediterranean data, this analysis shows that if you have a Mediterranean dietary interventions without any energy restriction, it's not useful at all. There is no ALT decrease, and that metabolic parameters have not decreased. On the other hand, if it's hypocaloric, same Mediterranean hypocaloric data has shown improvement in the ALT reduction. So it all depends upon again the what kind of calories, where you are getting the calories from. Mediterranean, as we know, that is from PUFA and then well, then we have a lot of barriers in implementing these things. We know that somebody wants to take a less food and exercise more. Nobody would like to have it, and therefore we have both the physician's perspective is there and the patient's perspective is there, and the lack of information, lack of transmission, lack of a counseling, and these are some of the reasons why. Some of the reasons why the lifestyle interventions have not been successful. And we know that this is a very landmark study where they have done a dual biopsy beginning and then later, and with the lifestyle interventions, we know that everybody talks about this 45% reversal of fibrosis in if you reduce by more than 10% of your weight over 1 year, right? But how many people have been found to follow this? 10%. That means that the lifestyle interventions like the diet and then exercise are not going to be helpful. We may suggest to them, but we should not depend upon this. They are not going to be helpful. As far as the drugs are concerned, we have drugs for many drugs are there, and again, screen failures, need to do the dual biopsy, lack of ideal markers, surrogative biopsy endpoints rather than the clinical endpoints. How far you are going to give it? 5 to 6 years, some people said. How do you sure that in these 5 to 6 years the patient is, he is not changing his weight, he is not changing in the habits. Longer the period, the more of a comorbidities and then other things are going to come up. So, and therefore drugs are difficult. This is only a representative slide. Many drugs are going to come, many will come, some will stay, some will get proved, but again we have a problem of we are going to show only the placebo bar is just slightly more than the placebo bar. Then people have looked at the combination trials. Why not we and even there we have got the challenges both in the number and also the fact that a previously taken the synergetic effects of the drugs and a phase 3 and then phase 2, previous phase 2, you cannot say that it cannot be there in the phase 3, and therefore combination therapy is going to be a very big problem. Well, then now the concept of a nutrigenomic is coming up here, and we got the inherited susceptibility because of the genes, and then on the right hand side you got the gut liver derangement, which I have conceptually I have already told you, and there is going to be influence of the diet on the intestinal microbiome and the genetics on the liver microbiome, and therefore this is a nutrigenomic is now the that means that people have to combine all the three factors, that is the genetic, environmental and the microbiome, to find out how to go about in future. Well, then on the left hand side you can see we are in this particular world now, that is we are only going by the algorithms of some of the data which we have on hand, either for the diagnosis or for the therapeutic interventions. Suppose if you don't talk about artificial intelligence now, you are a novice. And just now you have seen on ACLF, the study from PGI Chandigarh and other areas where how it transforms some of these machine learning, deep learning, and combining the artificial intelligence is going to the future. And then I suspect that that may be the answer in future for NF, non-alcoholic fatty liver disease, both for diagnosis and the management. And there mean empty number of papers, as you know. These are only, I think, two things will be perhaps important. One is a biopsy interpretation, and the radiomics, that is interpretation of the the imaging quality. So apart from the clinical data which has just been shown in ACLF, is the one which is perhaps we need to amalgamate the artificial intelligence and the big data management. And we only hope to have a human non-alcoholic steatohepatitis on a chip, which has been there already. Somebody has been predicting that it is going to happen. And also all this data, some people, everybody is looking at a different angle. Many people are looking at the basic research in the all kinds of an omics, metabolic omics, and genetics, and the other clinical data, extensive data is going to be produced. But all this is going to happen in a different world. That means this is the elephant which we don't want, right? But what we want an elephant is this elephant which we want, right? And with this we have a big data which has to be amalgamated. And then I think that the NAFLD and then ALD are the lifestyle diseases, and as predicted, there's going to be a phenomenal increase in the future, and therefore for all our issues about the NAFLD, cirrhosis, and hepatocellular carcinoma, the lifestyle modifications of a diet and then exercise are almost impossible to practice. Pharmacovigilance search for a newer and then combination drugs will continue to hold the stage, is welcome. But personally, I don't think that is going to solve the problem. The genes appear to play a significant role for susceptibility, progression, modulation, and interventions. Microbiota research is likely to yield a promising results. Using artificial intelligence and the big data management is the key for personalized medicine, not only in NAFLD, perhaps in other fields also. And that's my thank you very much. And thank you for INASL for giving me the attention. Thank you, sir.
Thank you, Professor P.N. Rao. We are extremely grateful to you being the orator for this prestigious oration. May we have the honor to felicitate you. We are inviting you kindly, sir.
On viral hepatitis is about to begin. The chairperson of the same, I'll request them to please join us on the dais. Dr. Samir Shah, Global Hospital, Mumbai. Dr. Francesco Paolo Russo, University Hospital, Padua, Italy. Requesting our chairperson, Dr. Samir Shah, Global Hospital, Mumbai. Dr. Francesco Paolo Russo, University Hospital, Padua, Italy, to please join us on stage. Dr. Shamir Saha, Global Hospital, Mumbai.
Good morning. Hello, everybody.
can I ask you to take seat so we can start the first with the session? I'm pleased again to be here, and I thanks again all the organizer. The title of this session is Viral Hepatitis, and I will start with the first speech, and I will ask Professor Chaudhry to come to the podium, and the title of his presentation will be Treatment Decision in Immune-Tolerant HBV. Thank you again, Professor Chaudhry.
Thank you. Thank you, Mr. Chairperson, and a very late good morning to everybody. So, my affiliations as put here had been IPGMER, and I'm right now very vigorously transitioning myself from IPGMER to Indian Institute of Liver and Digestive Sciences, the way immune tolerance transitions to immune active phase, and I would love them to transition to immune active phase. So what I'm going to discuss with you in the next 15 minutes is, how a lazy and complacent immune system fails to mount an immune response against a body which is parboiling with hepatitis B virus infection, and that makes creation of a state of peaceful coexistence not that much peaceful as data says, yet empowers or enables and confuses the societies to have clear guidelines on how to treat this group of people. These are the subset of people, these are the outlier phenotypes whom all the societies have kept on the corner and told that we cannot treat them as of now unless there are definite indications. So what I'm going to discuss is the pros and cons of treating them and what dictates our treatment guidelines while doing that. So let me start off with a couple of real life case scenarios which I faced in my life. So one is in all the things, the guideline, the thing that is sure is a high HBV DNA viral load. So some people say it's the cutoff is 10 to the power 6. But the first patient, as you see, had a viral load of 10 to the power 8. All are E antigen positive, ALT normal, measured repeatedly, at least over a year. In the first patient, the mother was inactive hepatitis B virus infection and the patient was a child. The parents were anxious, they had cancer phobia because everybody goes to Google these days and get to see that chronic HBV, getting HBV is equivalent to getting HCC. That's almost mathematical projections are being given. And in the school, there are social pressures to put the child out of the school. And this has happened to this child. Case 2 is a 24-year-old female who was recently married, was E positive with high DNA load, and ALT again 20 over a year period of time, and wants to get pregnant. And everybody gets a LSM value done these days. In India at least, fatty liver and or assessment, trying to assess fatty liver by means of a fibroscan is one of the common threads for a patient presenting to a liver physician. So this lady came with LSM which showed 5 kPa value. The third case was a 31-year-old male who tried to go to Middle East. A visa was denied. Gave us a history of surgery at 18 years of age, was E antigen positive, DNA load high, ALT normal, LSM is 12 kPa. And this young adult or the person who wants to get a visa wants me to show him the way how to get rid of the virus. So these are the circumstances, and let me tell you at the very outset that science out here does not allow us, so we need to talk very closely with the patient to come to conclusion. So what is the science, that the evidence that tells us? So it's immune tolerant phase, as we know, is HBV infected, E antigen positive, high HBV DNA load, and ALT, and we had debated several discussions in this meeting also, where the upper limit of normal is still confusing. But if we set this as 30 against 19, male and female, then it should be normal measured less than upper limit of normal measured 2 times over 6 to 12 months, and persistent. So persistent ALT normalization, there lies the clue to immune tolerance. So it's like we are trying to assess a house which is burning, by measuring using ALT as the smoke that comes out of that house. So the big question that remains, I will go to some detail, that whether ALT is a good biomarker to do that, and whether that really depicts the circumstances of immune turbulence that goes on within. So we all know that we have divided this chronic HBV infection into phases. And the first phase in neonatally acquired is the HBV tolerant phase, which I just depicted. But there are subsequent phases. The most common and the one that get the body rid of the virus is the immune active phase, but there are other phases. So turbulences of ALT are correlated very well with the immune pressure and the immune response, cell-mediated immune response that happens within the body. So the very important question that remains is, what is the immune phenomena that occurs in this phase? The very first study that brought us this into picture was a study from Taiwan, which had shown that these people who have got high HBV DNA, persistently normal ALT, have got a mild disease in the liver if we do liver biopsy. Although they transition to spontaneous seroconversion or an immune active phase at a fairly high rate, this study was done over a period of 5 years follow-up, biopsied at baseline. They could find that the transition rate in 5 years was almost 15% to a different phase. So this is not a stable phase. We need to remember that. But those people who remain within the immune tolerant phase with very normal, persistently normal ALT really have got a good liver histology. And that, subsequently gave us to coin this term based on immune responses also, as these people are good in terms of liver disease progression. So guidelines on the mainstream view has put them on a black box and handcuffed them on a corner virtually, and possibly depriving them of the right of benefit of doubts of therapy. So we call it a bland phase, no or minimal disease progression, histology, immune events and outcomes are good. So ALT is the most important arbiter of therapy outcomes. We all know that. Normal ALT is still rock to move. We really cannot do good. Most of the studies have shown that the therapy responses with all available drugs is low in people who have got normal, that means less than upper limit of normal ALT. So it's disappointing results. Any intervention, a concern had been that any intervention out at this phase where immune phenomena could occur leading to spontaneous seroconversion. And people thought that some intervention at this phase might destabilize the spontaneous immune events that tries to get the body rid of the virus. So the concern is that don't treat, don't tamper the phenomena that is spontaneously occurring and might foster drug resistance. So hence, don't treat except under protocols. That's the mainstream dictum as of now. But the concern thing is, the view is that, this most important concern is that high HBV DNA load, as brought out by the REVEAL study, the famous REVEAL study, has shown us that even normal ALT high HBV DNA load have got a bad outcome. Although other people, elevated ALT had got the worst outcome, but normal ALT and HBV DNA load high have still developed HCC and liver-related mortality. And also, there are data which I'll discuss that immune tolerance is fortuitous, the way we look at this. And immune turbulence smolders at this phase. Histology is not as benign. I'll come to that. Significant outcomes are engrafted in this niche area of chronic HBV. Drug resistance is virtually non-existent. Better drugs needed though, and personalized care individual choices are needed. So we need to treat. That's the other upstream view, at least in a subset. So let's come to evidence that is available against the mainstream thought. So this is a meta-analysis of available studies on histology, and this has been of 319 studies, fairly big meta-analysis which has just come, and had shown that significant liver fibrosis, almost 10% pool ratio. This is a forest plot on fibrosis and inflammation on the right side. Significant liver fibrosis and inflammation, in some studies up to 30%, might be there even in the immune tolerant phase. But more important is, are the outcomes as bland as we presume it to be? No, it's not. There are data against this. So this is the most eyebrow-raising Korean study which has shown 13 years follow-up. 413 IT patients from Korea had shown that immune tolerant people have got twice as more chances of developing HCC on a follow-up of up to 10 years time of follow-up, and have got a higher mortality, liver-related mortality, death or transplantation, as compared to people who have got immune active and who are treated, telling that not always is as green scenario as we presume it to be. But a very recent study, again a meta-analysis, has shown at least comparable outcomes between the two. The lower part in each of these curves says 5-year HCC incidence and 10-year HCC incidence, and you can see that immune tolerant and immune active phase have comparable outcomes in terms of HCC development, 5-year mortality. On the lower right panel, you can see that the 5-year phase change rate is fairly high, again implying that immune tolerant once does not mean immune tolerant ever. So we need to follow them up, but at the same time not be complacent that everything is good here. But more important thing is the data that showed this was, raised the most important alarm bell to the fact that the worst of the things that we are frightened of in chronic HBV is development of HCC. We all know that despite our treatment attempts, we often land up in people getting HCC. So they found in this interesting study by Masson and Bartoletti and all this group, that there was significant amount of HBV integration in the chromosomes. All the chromosomes were studded with bullets almost with HBV sites that were integrated. Again, there was clonal expansion of the hepatocyte clones. Why does clonal expansion happen? Only when there is immune pressure. Otherwise, the hepatocytes don't respond by expansion. So the clonal expansion was as big in the immune active phase as was in the immune tolerant phase. The same study had also shown that on the left-hand side, you can see that there was significant, in the peripheral blood, there was significant cell-mediated immune response going on, although we often fail to measure that against both the core, envelope, and the polymerase proteins of the hepatitis B virus infection. And that was fairly widely directed. So the length as well as the breadth of immune response was fairly high, telling us that it's not sullen gray scenario, and there is significant turbulence which we don't perceive on the surface of it as we try to measure with ALT. So immune phenomena keeps on occurring. Another very interesting study published in Journal of Viral Hepatitis from Taiwan had shown that by next generation sequencing, they found that the viral Quashi species and variants were fairly big in number, even in this phase. Again, telling this happens only under immune pressure, that what we conceive as immune tolerant is really not all silent, not inert phenomena. So, there had been suggestion that this is possibly a phenomenon of immune ignorance or inert immune inertness, and it's a perceptual silence. It's our inability to assess whether things are good there or not. So there had been suggested that instead of labeling this as the immune tolerant phase, let's recoin these as high replicative low inflammatory phase, though this is not overall accepted, wherein you have got substantial histological lesion, HBV-specific T-cell responses, DNA integration, and clonal hepatocyte expansion. So these are all harbingers of bad things that can happen in the long term. So let's consider this for consideration of treatment. But what's most important is we need to understand, the tolerance in a broad way. This is a paradigm. So we are in the paradigm shift area. On the left-hand side, you see a high affinity T-cell clones. It's not an all or none phenomena. It's all because of deletion or exhaustion of the immune system. So when there is the activation of the immune system, you get those highly active T lymphocytes which come into the picture. On the right-hand side, you get immune-regulated, down-regulated cells which are active. So you measure this only by counting some of the cells and not measuring others. So what happens possibly in immune-tolerant phase, the way we measure is, we don't fail to measure those low-affinity cells which are still present and mounting immune response. So we need to do that. We need to improve our understanding of the immune phenomena to better delineate these things. What are the treatment results? I think Ujjwal is sitting here, and Ujjwal had shown very promising and exciting results from India in children treated in this phase. But the overall results are really not very exciting. So long-term nucleotide analog therapy leads to prompt DNA suppression, but this is a whitewash phenomena in a still rock house. So there is prompt DNA suppression, but very low reduction. So mostly a feel-good phenomena, because E antigen loss is very low. Similar thing of these two very similar studies, wherein leading entecavir followed by pegylated interferon, and Nora is sitting here. She had been one of the lead authors in one of the studies in the adult study, had shown that once you stop therapy, relapses are almost certain. Again, telling that our current therapy is really fortuitous. So how do we come to the conclude in immune tolerant HBV while we decide on therapy? What can you do? So mostly we need to follow them up, keeping the guidelines, and look for transformation of these, because the ALT is still there. But in a group of people whose age is more than 30 or 40 years, who are male, who have got a family history, have got liver stiffness, which you can measure, and if we do biopsies, have got inflammation, we can still treat them with the whatever lame therapy we have got in our hand right now, with the anticipation that whatever DNA suppression we get might lead to disease stabilization and possibly not worsening. But the real life scenarios are even more compelling for the treating doctors. So for anxious, depressed patients, like the one that I shared with you in the beginning, people who are discriminated in job placements and want to be treated, and comes to you telling, hey doctor, you don't deprive me of the available therapy. You possibly don't have any ethical right to deprive them of the rights of available therapy, whatever drugs you have got right in hand, with the anticipation that exciting molecules that are being developed, particularly the immune modulators, and the new biomarkers are coming up, particularly immune biomarkers, would lead us the way to assess the disease, particularly the immune tolerant, and a lot of new stories can build up around this. Thank you all for your patient hearing.
Thank you very much, Professor Chaudhary. Please have a seat, and then the discussion will be at the end. Now it's my extreme pleasure to introduce Professor Nora Terrot. She doesn't need any presentation, and she is at the moment the president of the ASLD, and she will talk about the HBV reactivation, the challenge with new classes of immunosuppressants and immunomodulators. Please, Professor Terrot.
Great. Thank you so much. Delighted to be back talking about hepatitis B today. And the topic I was asked to address is the challenge of new classes of immunosuppressive immune modulatory therapy. So I think when we consider the wide use of these drugs, whether we're talking about immune modulatory, cytotoxic, immune suppressive therapy, is that we have to understand that they're across a wide variety of settings. In the past, this was largely restricted to oncology and transplantation, but now it's used across many other subspecialties. Even the emergency room and in primary care, we're now seeing that these, especially immune modulatory therapies, are being very broadly prescribed. So really the most important thing is that there has to be an awareness of the importance of screening for hepatitis B surface antigen and anti-HB core in helping to manage the risk of HBV reactivation. And a very recent study that was published in the Netherlands looks and highlights that our screening practices have improved. There is more awareness around this, but we still have a long way to go. And this is in the Netherlands. And you can see on the left, they characterize the screening as being correct meaning that they tested for both the surface antigen and anti-HB core. And overall, only about half of the patients were appropriately screened. And you can see on the right that a screening is more likely to happen in the correct way in an academic setting compared to non-academic settings, and that there is variability in screening depending upon whether it's a specialist, say, versus a primary care office. So just highlighting the importance that we can't prevent HBV reactivation unless we test and know that the person is at risk. And then the other thing to emphasize is just the very wide expanse in terms of the drugs that are being developed to treat immune-based conditions. This is a very nice diagram showing the drugs in development. This is from the US, but it shows you the targets of therapies that are being developed that are targeting B cells, T cells, complement, cytokines, the whole gamut of really things that are influencing immune-based conditions. And so you can see this is a very rapidly evolving field. So keeping ahead of it in terms of trying to understand the effects of these drugs on the risk for HBV reactivation is clear. And in the field of oncology in particular, we've seen really a transformative time with the use of a lot of immune modulatory therapies here, or immune oncological therapies. Anti-PD-1, PDL, and CTL4 therapies, for example, have really become very, very much part of therapeutics. And there's more than 5,000 agents that are currently in the clinical development pipeline for oncology on a global scale. So it's the number of drugs that are coming forward is really rapid. And so I think it's challenging for us to sort of stay ahead of the data in terms of understanding when we should be doing prophylaxis for prevention of reactivation. Oh, I think this is out of order. All right, I think it just went to the end for some reason. Can you just pull up my slides again? Do you mind? Somehow it went to the end. Okay, I'll go back. I'm not sure what happened there. Okay. So I'm going to take you through sort of an update on where we are with the drug therapies, and I'll just highlight a few things about the published literature before I do that. One is that there's variability in the studies about HBV reactivation in terms of how it's defined and how they define hepatitis flares. You will see from the meta-analyses that I'll show you that there are relatively small sample sizes, and so that means that the estimates in terms of the risk for reactivation have very wide confidence intervals. Increasingly, what we're seeing in therapeutics that there's either concurrent, so more than one drug being given, or quick in succession immune modulatory therapies. So sometimes it can be difficult to parse out exactly what drug is the culprit in terms of HBV reactivation. And then, as I've already highlighted, so many new drugs, rapidly evolving fields, it makes it difficult for the guidelines to keep up with the new drugs that are being approved. Just to remind us all about how HBV reactivation is defined, it's defined differently in patients who are surface antigen positive at baseline versus those that are core antibody positive alone. So those that have surface antigen, it's either a 2-log increase in HBV DNA from baseline, an HBV DNA level greater than 1,000 if it was previously undetectable, or a level greater than 10,000 if the baseline's not available. But for surface antigen negative anti-HB core patients, reactivation is defined by any detection of HBV DNA or reverse seroconversion, meaning that they become surface antigen positive. Now, you can have reactivation, but not necessarily get hepatitis. So hepatitis B associated flares are defined by having an ALT level greater than 3 times upper limit of normal in the setting of having the HBV reactivation. So the point being that not all reactivation leads to ALT elevations. And of course, ALT elevations can happen in patients on immune modulatory therapy that's unrelated to the HBV. So we always have to look at two things together. Now, this was probably the most widely quoted guideline up until quite recently. This is the AGA's guideline on how to prevent HBV reactivation. It was published in 2015, and Dr. Raj Reddy was leader author on this. There's really two things that I want to emphasize related to guidelines. So the first is they define the risk of reactivation in 3 broad categories. Low risk, meaning a risk of reactivation less than 1%. Intermediate, 1 to 10%, and high, meaning a greater than 10% risk of reactivation. And that is still used when recommendations are being made, and we'll continue to use that in the data that I show you. The second is that you'll see that the recommendations are divided into those that are surface antigen positive versus those that are anti-HB core positive. And you can see that kind of the drugs that fall into the low, intermediate, or high levels differ by whether the patient is surface antigen positive versus core positive. And then the final thing to emphasize on this slide is the strategy in terms of what to do to prevent reactivation is influenced by whether they're low, intermediate, or high. If they're in the low risk group, it's a monitor and treat on demand approach. If it's a high risk group, it's recommended to get antiviral prophylaxis with a nucleoside analog. And the intermediate group, it's suggested that antivirals be used, but you can consider a monitoring on demand treatment approach. Okay, so what I'm going to go through briefly is updated information from a recent meta-analysis on new drug classes. Now, some of these are not so new, but there's kind of new data around them. So I'm going to cover anti-TNF agents, cytokine inhibitors, TK inhibitors, immune checkpoint inhibitors, T-cell depleting drugs, and CAR T therapy. And I'm drawing the data from the most recent analysis that was published in JHEP just toward the end of last year. And I was part of this analysis that was really done to update it on many of the new drug classes. So this is a pretty busy slide, and I'll come back to it again at the end of my talk, but just to orientate you to the slide. So on the left, if you read downwards, that's the surface antigen positive group. The middle column is the anti-HB core group, so the two different serological profiles of patients who are at risk for reactivation. And then shown on the far right is the high risk, intermediate risk, and low risk groups, color-coded. Now, why this is a nice slide is it also highlights for you that the data that informs this recommendation varies. So the little circles that come after the name of the drug highlight the quality of the data. So a green circle is where we have the highest level data, whereas an orange or a red circle indicates a lower level of evidence. So it's not that we can't make recommendations, but you can see that for some drugs we have high quality data, green dots, but in others, the quality of the data is much less. Okay, so let's start with the anti-TNF agents. So in this recent analysis, they focused only on the anti-HB core group because prior meta-analyses had already looked at the surface antigen positive group. But just to summarize what to do in terms of what the risk is for surface antigen positive patients, it's intermediate if it's a low potency anti-TNF drug, and high risk if it's a high potency anti-TNF drug. So that's for surface antigen positive patients. For those that are core antibody positive, as shown in the bottom half of the slide, is in the 18 studies that were included in this meta-analysis, the summary estimate for the risk of reactivation is 1%, which is right on the cusp of being low versus intermediate in terms of risk. But when they looked at hepatitis B related hepatitis, so the flares, that was only less than 0.1% in all of the patients that were evaluated in this meta-analysis. And so they concluded overall for the patient who's anti-HB core that the risk is low. What about cytokine inhibitors? So shown at the top of the slide is the outcomes in surface antigen positive patients, 5 studies. The summary estimate in terms of risk for reactivation was 36%, which put it in the high risk category for reactivation. In the anti-HB core studies, which are shown at the bottom, there were a total of 8. The risk for reactivation was 3% as a summary estimate. That puts it in the intermediate risk group. What about for TK inhibitors? Here, most of the data is in surface antigen positive patients. You can see that there's only 3 studies. They found a summary estimate of 11% risk of reactivation. That falls into the high risk group. They had 3 studies that were also looked at core positive only, and none of them received prophylaxis, and there was no reports of HBV reactivation in the 72 patients total. That puts it into the low risk group. And what about immune checkpoint inhibitors? Really become very, very prominent in the oncological sphere. So shown here is at the top, the surface antigen positive patients. This is 4 studies, total of 56 patients, as you can see, 11% risk of reactivation, high risk group. In the core positive patients, 7 studies, more than 1,000 patients, and essentially no risk for reactivation. So it's in the low risk category. T-cell depleting drugs, there's very limited data here, only 2 studies that looked at surface antigen positive patients and 3 looking at core positive. You can see that the risk in the surface antigen positive group was 6.8%, that's intermediate risk, and the core positive, 0, so it's low risk. And then finally, for T-cell or CAR therapy here, in the surface antigen positive group, 11% risk of reactivation among 5 studies as a summary estimate. That's high risk. For the core positive, it's 4% risk of reactivation, puts it in the intermediate risk group. So then coming back to this table, because I've just shared with you all of these data, let's walk our way through the table to summarize these new drug classes. So this table, focusing first on the surface antigen positive group, basically all of the new drug classes fall into the high-risk group, with the exception of anti-TNF agents that have low potency and the T-cell depleting agents. So the very easy thing to remember about basically a patient who's surface antigen is with any of the new drug classes as well as the old classes, the appropriate approach to this patient would be prophylaxis, right? Because they're high or intermediate, and in that recommendation, it's to go with prophylaxis. Now, on the core antibody positive, one of the data that I didn't share again, because I think it's very well established, is that the anti-CD20 monoclonal antibodies have the highest risk for reactivation among all drug classes, of all the drugs being used in core positive. That's a high-risk group. In this analysis, they also looked at the JK inhibitors, the JAK inhibitors, and there was one study in core positives where the risk for reactivation was more than 30%. So that now is also in the high-risk category group for patients who are core positive. You'll see in the intermediate group for core positive patients are cytokines, the CAR T therapy, and then previously there was corticosteroids and calcineurin inhibitors. Everything else in the core positive group is low risk and would be a recommendation to just do monitoring and on-demand therapy. So just a few sentences about how do you do prophylaxis. That hasn't changed. The recommendation is if you're going to do prophylaxis, you start it at the same time or 1 week prior to starting your immune modulatory therapy. The recommendation is to use a preferred drug, entecavir, TAF, or TDF, and you continue that therapy for 6 months beyond the last dose of the immune modulatory therapy. The two exceptions to that rule are anti-CD20 drugs, and there's also a recommendation to also consider this for CAR T, where the treatment should be extended to 12 months because there's a sort of a delayed risk for reactivation with those drugs. So just to summarize then in terms of these newer immunosuppressive immune modulatory therapy, in general for the surface antigen positive patient, most new drug classes have a high risk of reactivation. You're going to do NA prophylaxis. In the core positive group, most of the time it's a monitoring with an on-demand use of nucleoside analogs, with the exception of anti-CD20 and the JAK inhibitors. And then the other thing that I should just comment on as we close is the additional reasons to consider doing prophylaxis, even if they're at moderate or low risk, is if you have concerns about the patient's willingness to adhere to monitoring, or if they have underlying advanced fibrosis. In that setting, prophylaxis is probably the safer strategy. Thank you very much.
Thank you very much, Nora. Really great presentation. And now it's my pleasure to call the last presentation of the session is Professor Kuma, who is giving a talk on managing dual and triple co-infection in clinical practice. Please, Professor Kuma.
I'm thankful to the organizers of INASL for giving me this opportunity. And today we'll discuss some of the clinical issues that we face while managing doing dual and triple infections in clinical practice. So this will be the outline. First we will discuss what is the burden, then how liver disease differs between mono and co-infected patients, what are the various drug categories, when to treat HIV and how to treat triple and dual co-infections. So this is the global burden of the co-infections, and as we can see 2 to 15% of HIV positive are HCV infected, whereas 0.5 to 1% of HCV are HIV infected. 5 to 20% of HIV are HBV infected, whereas 0.2 to 0.3% of HBV are HIV infected. Similarly, 5 to 20% of chronic hepatitis B are HCV infected, whereas 2 to 10% is the reverse. This is the Indian data of all HIV infected patients. From 2 to 30% has been HBsAg positive, whereas about 2 to 10% NTSCV positive, and various studies have shown 2.5 to 0.16% as having both the infections. And this was a meta-analysis of Indian studies which show that varying from about 2 to 3%, this is the pooled HBV HCV co-infection in various groups of patients. So it is around 2 to 3%. So we have to understand that HIV per se can lead to accelerated fibrosis through various mechanisms, which I will not go into the details. But HIV can lead to accelerated fibrosis through various mechanisms. And if we look at the independent predictors of liver-related death in HIV, then besides the CD4 count, HCV status and HBV status, they both are independent predictors of liver-related mortality in HIV-infected patients. And this is one of the largest studies which showed that the risk of end-stage liver disease, if we consider HIV as baseline, then HIV HCV it is about 7 times, HIV HBV 7.5 times, and about 17 times if all the 3 viruses are present. So if we look at the interactions between HBV and HCV viruses, it is a generally we will see that HCV will inhibit the HBV virus, but there can be various clinical scenarios. For example, the first scenario will be simultaneous acute infection by both HBV and HCV, and in such cases there is delayed HBS appearance, shorter antigenemia time, lower ALT, and chronicity rates are however comparable. This means that HCV is inhibiting the HBV. The second scenario could be a patient who is chronically HBV infected gets a super infection by HCV. So again, HCV is inhibiting, more HB antigen seroconversion is occurring, HbA/Ag loss is more. However, fulminant hepatic failure is more as compared to patients with no chronic hepatitis B infection, and they have a higher cirrhosis and HCC as compared to patients who have chronic HBV alone. The third scenario could be super infection of HBV by a patient who is chronic HCV infected. Again here acute HBV is more severe, more fulminant hepatitis is occurring, and in such cases HBV is inhibiting HCV as seen. HCV RNA is lower, higher HCV clearance can occur, and also HCV is inhibiting HBV also, for example by showing that HBV DNA is lower as compared to monoinfection with HBV. Another scenario is occult HBV in a chronic HCV patient. Again, there is some evidence, although controversial, that higher cirrhosis and HCC incidence can occur in chronic HCV patients who are not infected with occult HBV. And the last scenario is both chronically detected HBV and HCV, and in such cases there is higher cirrhosis and HCC incidence versus the monoinfection as shown in various studies. There is a higher risk of cirrhosis in HBV HCV co-infected versus the HBV alone in this case, and whereas in HCV alone as compared to HBV plus HCV there is higher risk of cirrhosis, and also there is a higher risk of HCC in patients who have co-infection. For example, in this study, if in HbA/Ag positive, HCC incidence per 100 was 2, for HCV 3.7, and when both it was 6.4. So we know for HCV we have NS5A inhibitors and NS5B and A inhibitors. These are the two most commonly used drugs, and these two drugs are also available in India. And for HIV, most commonly used drugs are integrase inhibitors and reverse transcriptase inhibitors that can be of various types, as we will see. So these are the red available drugs which are highlighted, that they are available in India: SOF, Dacla, Ladi and Belptasvir. Others are not available. And these are the categories of HIV, anti-HIV drugs, and the highlighted ones are the first line agents. As if we look at the classes, then nucleoside reverse transcriptase inhibitors, amtricitabine and lamivudine are the first line agents. Nucleotide inhibitors, tenofovir, TAF and TDF are the first line agents. Integrase inhibitors like bictegravir and dolutegravir are also first line agents. So one from each category is used, 1, 2 and 3. And sometimes when this category of drugs cannot be used, then efavirenz is also used. So these are the guidelines for DHHS 2021 as an integrase inhibitors plus 2 reverse transcriptase inhibitors. These are the first line agents, and this is the most commonly used regimen, dolutegravir with TAF or TDF and emtricitabine or lamivudine. This is the most commonly used, and this is the NACO guidelines from the India, and we can see that again TLD regime, tenofovir, lamivudine and dolutegravir, these are the first line agents for body weight more than 30. For less than 30, you have to avoid tenofovir and continue with lamivudine and dolutegravir. If there is high creatinine, then again avoid tenofovir. For pregnant women also the same regimen is recommended, but dolutegravir can have some fetal toxicity, so patients should be sounded about this possibility, and if we decide not to use DTG based therapy, then tenofovir, lamivudine and efavirenz can be used. Now, when to treat HCV, there is no doubt that liver disease does not affect the decision when HIV is treated, and we have to treat HIV irrespective of HIV RNA and CD4 counts, as shown in this study. If immediate initiation, then serious adverse related AIDS related events are very less as compared to the deferred initiation. And how do we manage? So we have to first consider HCV workup. We all know genotype, RNA levels, what is the staging of liver disease, endoscopy, SCC screening as required. For HBV, we have to do all these tests, including HBV DNA. For HIV workup, CD4 count, HIV RNA levels, and these tests as needed. And for all patients, creatinine clearance, comorbidities, alcohol use, fatty liver, and these are all things that we have to work up. And as far as HCV and HIV infection is concerned, treat all, and all HIV HCV infected patients should be treated and retreated as the same as persons who do not have HIV infection. And because it has been shown that HCV DAs have the similar efficacy in persons with and without HCV co-infection, there have been multitude of studies, and SVRs are comparable whether HCV monoinfection is present or HIV co-infection is present. And these are the first line HCV treatment for most of the genotypes. Sof-Velpa, which is available in India, has been used for genotype 1, 2, 4, 5 and 6. And for Geno 3 also, Sof-Velpa is 12 weeks recommended. And for compensated cirrhotics, although it is recommended to do baseline resistance associated variants, but in clinical practice, mostly we do not do this. But one important thing to remember is there could be drug interactions between DAs and antiretroviral drugs, then this we need to keep in mind. Although most of the combinations are safe and they can be used, but tenofovir should be avoided in patients who have estimated GFR less than 60 when used with Sof-Well or Sof-Lady, and in combination with ritonavir and Cobistat containing regimes. Otherwise, all the drugs can be used and they are safe. One important drug that we should avoid is Sof-Velpa should be avoided when efavirenz based therapy is being used. So this we have to remember. Otherwise, whenever in confusion, you go back to the charts and see whether if there is any drug interactions between the drugs that you are using. So when starting HCV HIV co-infection treatment, 3 scenarios are possible. We can have persons who are not taking ART and who plan to initiate HCV DAs. There is no requirement that HIV RNA should be suppressed before starting DAs, but usually ART is initiated first to give some time to see the HIV response and tolerability. Now, second scenario could be persons taking ART with HIV RNA suppression, start DAs right away. And third scenario could be patients who have inadequately HIV RNA suppressed and they plan to switch ART and also start HCV. Then again, as we should wait for about 3 to 4 weeks for the adjustment of HIV regimes. Now for HIV, HBV co-infection, again, the dictum is treat all. HBV treatment should be initiated in all patients. And most of the patients would be receiving regimes which contain TAF or TDF or emtricitabine or lamivudine, which is a part of fully suppressive antiretroviral regime. If these two drugs cannot be used, entecavir can also be used. Interferon rarely can also be used if needed. Now, it is important to remember that incomplete HBV DNA suppression is associated with HCC in patients with HIV HBV co-infection, and when both HIV and HBV DNA are detectable, the risk of HCC is about 16 times as compared to when none is detectable. And also it depends on the level of HBV DNA. If DNA is more than 2000 IU per ml, the risk is about 3 times when DNA is negative. So if HBV DNA is not getting negative after a reasonable time period, then we can use entecavir. And entecavir, this study has shown that entecavir can result in HBV DNA negativity in such patients. Now, weight gain is an almost universal phenomena, and we have to remember that highest weight gain is with the integrase inhibitors, and among integrase inhibitors, it is the bictegravir which is the most, and TAF is also associated with higher weight gain. We have to remember this. And switching from tenofovir TDF to TAF based regimes is universally associated with rapid weight gain, regardless which type of the drug category used. We can see this. And there has been some evidence emerging that shifting from TDF to TAF based regimes can result in higher risk of cardiac events, as has been shown in this study, but it needs to be replicated. But however, there are currently no recommendation whether to avoid TAF due to its potential for weight gain. So this is a gray area. Now there have been some evidence that TAF, this was an alliance study which was interim analysis was done and shown that TAF was superior to TDF for HBV DNA suppression at week 48, as can be seen, but this needs to be confirmed in further trials. So as far as HIV, HCV, HBV co-infection is concerned, if patient is HBsAg positive, they will already be receiving treatment with TAF and TDF or lamivudine and emtricitabine. So they can straight away start it with DAs because the risk of reactivation is there, but they have been already on these medications. If anti-core positive is there, then the risk is very low, and most of the patients will be receiving anti-HBV drugs already. But if they are not receiving, then carefully we should monitor these patients for reactivation without starting antiviral drugs. Now, management of HBV HCV co-infection, and we can see that if HBsAg positive patients are there, then the risk of reactivation is about 41.4%, quite high. If HBsAg negative and core positive only, the risk is very low, 0.9%. So this is the suggested approach. This is modified from APASL guidelines. So HCV patient who is to be started on DAs, if HBsAg positive, start preemptive therapy and continue till 24 weeks post DA. If total core positive only, DNA negative, close monitoring till 24 weeks. If DNA positive, treat like HBsAg positive, and for HBsAg positive, follow the APASL guidelines later on. So to conclude, ladies and gentlemen, always test for co-infections in appropriate settings. Co-infections lead to higher liver-related complications. All persons with HIV should be treated. HIV, HCV co-infected persons should be treated and retreated as persons without infection. And complex drug interactions should be kept in mind. Treat all HBV. Incomplete DNA suppression will lead to higher HCC, and switching from TAF to TDF to TAF may have adverse metabolic consequences. And we should always keep in mind the risk of HBV reactivation in cases of HCV HBV and HIV HCV HBV co-infections. Thank you very much for listening.
Thank you very much, Professor Kuma. Now the session and the speakers are ready to answer to the question. Any question from the...
I have two questions. First is to Professor Nora. A young lady with the anti-HBS antibody positive, DNA negative, HBsAg negative on maintenance therapy with rituximab. Does she need a prophylaxis? DNA negative, anti-HBs, AG more than 1000.
But this is not an antibody acquired through vaccination. You're talking about somebody who's also core positive,
Core
correct?
positive,
Yeah,
HBs AG negative, anti-HBs antibody more than 1000, and DNA negative.
Yes.
Still needs it?
Yes. So in the studies that were done looking at the anti-CD20 drugs, the antibody, even at high titer, is not protective against reactivation.
Okay.
So it's still recommended because it's a very high risk, like 20%, in a core positive it's a very high rate of reactivation. So it's still recommended. Presence of antibody doesn't influence the decision.
Okay. My question is Dr. Abhijit. Dr. Abhijit, there is a good data to show that persistent suppression of the DNA will also lead to less replenishment of the cccDNA and hence less production of HBsAg. So the lesser the DNA, the lesser the HBsAg, the lesser the chances of HCC. So young 3-year-old boy who has a full life to go, you have a persistent suppression of both HBsAg and DNA. Won't that prevent the occurrence of HCC in the long run? So does that make a case for early initiation of antiviral therapy, number one? And there is now increasing data to show that higher the level of the DNA, the more chances that it will get integrated into the human genome and also lead to chromosomal instability. So these two strong points should make an early case for starting antiviral therapy with whatever we have.
No, I fully agree. These are points in favor of initiation of therapy. But as I was discussing that, while there are very strong pointers, first of all, there is no therapy that can predictably prevent HCC development. Although there are data to show that people who are treated have got, lesser chances of HCC development. So these are gray areas. But, it would depend on the physician as well as patients or for the child, the parent, discussion with the patient. So I think there is no clear-cut guidelines. We should take this on a case-to-case basis.
In HIV and hepatitis B co-infected patients, what therapy should be started first? HIV and hepatitis B co-infected.
Because the HIV regimen itself contains two drugs which are active against HBV, either TAF or TDF, and emtricitabine or lamivudine. So,
but if the patient comes to me, I have to refer the patient to ART center. So should I start straight away with tenofovir and then refer the patient to ART center, or should I wait the ART center to initiate HIV?
I think you should refer to the ART center because they will give the anti-HPV drugs along with that.
So need not to start tenofovir.
Not at all.
This is a follow-up to Dr. Anil Arora's question. Would it make a difference if the antibodies is formed after natural infection or after vaccination? But in our transplant practice, if they have antibodies spontaneously, then we would not give them antiviral prophylaxis.
No, absolutely. That's why, while there are strong pointers to support, but it's not very confident to say that you need to treat these people. Personally, I would like to treat these people, but that does not mean that everybody would have, arguments against that also.
Very nice talk. I don't know whether I was missed in between. If I missed that, if you covered that. But these days the ART regimen now would include the integrase inhibitor, which is the dolutegravir. So we do have data of other drugs and the interaction with the DAAs, but there was no data, large data about the interaction of dolutegravir with the DAAs. So we recently published, I don't know if today is here or not, data on the 45 patients of HIV and HCV co-infection, where we looked at the safety and efficacy of SOF and WELL, those HIV patients on ART taking dolutegravir, and we found that there were nothing, no interactions, no counts problem, no adverse events, and we had an SVR rate close to 95%.
Yeah. For dolutegravir, there is no interaction with SOF-WELL, but for it is with efavirenz that it should be avoided. But with dolutegravir, you can use all the drugs.
Can I ask you a question about this weight gain with TAF? I still don't understand that. I mean, it's very compelling in the data, but does anybody have insights into the mechanism?
So it has been suggested that TDF per se has some anti-obesity or lipid lowering activity, TDF per se. So when you shift from TDF to TAF, that effect is gone. So patients tend to gain weight. So this is the hypothesis, but we don't know anybody.
Yeah. The question, Professor Nora. So when you give HBV positive patient immune checkpoint inhibitors and the DNA is high, do you wait for the DNA to come down with antivirals before starting ICIs? Or you start simultaneously? Or is there a DNA cutoff?
No. So the answer is you should just start them simultaneously. I mean, if you want to start them a little ahead, we never want to delay their oncologic therapy, really, right? Because it's usually their most pressing problem. And the data suggests that if you've got them on suppressive therapy with a highly effective drug like entecavir or tenofovir-based drug, that drug will work. It will maybe take some time for the viral load to come down, but they will not experience a flare. So you can be confident about that. So start simultaneously.
So the problem happens when after first or second cycle, they develop hepatitis, and it's difficult to differentiate whether that was reactivation induced or, B getting killed by increased immunity or autoimmune hepatitis induced by ICIs.
Yeah, I appreciate that. So I think it's a decision you're going to have to make. But, I almost never delay the start of checkpoint inhibitor therapy because their cancer is the most pressing issue. And I think that if their viral load is coming down concurrent with a flare, yes, I guess it could be a Hep B flare, but I think more likely, you just have to look at the time course versus the drug. And in the end, I think, you could do a biopsy to sort it out if you had to, but I wouldn't delay, right? Because the benefit usually of the oncological therapy is very high.
Thank you.
So Nora, thanks again for your talk. Can you say goodbye to lamivudine forever? Like we will not use anymore in any possibility transplant setting, non-transplant setting?
Yes. I mean, I used to reserve lamivudine for NEHB core settings because, the viral level is undetectable usually when you start, and so the risk for resistance is actually incredibly low. And so lamivudine was a perfectly acceptable drug to use, but now we have entecavir, and at least in the US, it's generic. So the cost is trivial. So I'd rather go with a drug that I don't have to think about that.
I totally agree with this. And to Professor Charlie, just a comment regarding the dynamics expansion, clonal expansion that you mentioned, because we just published the paper in JEP in this month in August regarding that actually also in the normal liver, we can have even very slow clonal expansion starting by periportal part of the liver. So it's just a comment. We did in collaboration with the UK groups. And the last thing was regarding DAA. You both mentioned about the possibility of using it prophylaxis in DAA patients. So in your clinical practice, in co-infected HCV, HIV, or HCV, HBV, do you always make prophylaxis? I mean, do you always, I was thinking about Nora, do you always make prophylaxis for HBV in patients that you treat for HCV with DAA?
If patient is HBsAg positive, then yes.
Always?
Always, even if DNA is negative. But if patient is only total core positive, then we do DNA. If DNA negative, then we can wait. But if HBsAg positive, we always use.
Okay.
Yeah, I know what the guidance says. It says you should treat, but we have glucocorticoid preventative, which is 8 weeks of treatment, right? So I think if I have a patient who's got inactive hepatitis B, so their surface antigen positive viral load is undetectable, we have, with informed consent and close monitoring, just done it with monitoring.
I agree. And last question is regarding how long do you take the prophylaxis? Like you showed the last paper by Papadoulidis, maybe 6-12 months in your clinical practice, because we had really bad case recently.
So we all probably have a case, right? but the data would say that the real risk is in the first 6 months, except with the anti-CD20. There's been reports of it beyond 6 months, and there's a suggestion also with CAR T therapy that also may be somewhat delayed or later. So I think those two therapies I would treat for a year.
Any other question? Okay, so thank you very much again, and I give the talk to next session.
Thank you so much to the chairperson and the speakers. Now we move ahead with the session 5, Healthy Liver, Healthy Lives. The chairperson for the same are Dr. Nora Terrault, Chief of Gastroenterology Division, University of Southern California, President ASL, Professor Dr. S.P. Singh, President of INASL, Chairman of Kalinga Gastroenterology Foundation, Dr. Jeff Lazarus, Barcelona Institute of Global Health, Spain, Professor Dr. Ajay Duseja, Secretary General INASL, Professor and Head of PGIMER Chandigarh, Professor Dr. Manoj K. Sahu, Organizing Secretary INASL. And we'll be requesting Dr. Jeff Lazarus and Dr. Ajay Duseja for the introduction.
Good afternoon, everyone. So I think it's a very important session. Professor Nora, you need to be on the dais. Yeah. So very important session on healthy liver, healthy lives. I think this is one program actually which has been led by Professor Jeff Lazarus, as I mentioned in my presentation yesterday as well. So I'll request him now to please come and tell us about the program, and then we move on to
Thank you very much, Dr. Duseja. I'll make one small correction. This has really been a collaborative effort. This is an effort that started originally in the EASL International Liver Foundation, was taken over by EASL, and now is a full partnership with AASLD, Apostle, ALE, INASL is involved, and other organizations. We want the leading liver organizations to be working together, not just on clinical aspects of steatotic liver disease, but also on how we can build awareness, how we can engage with the World Health Organization, our clinical colleagues, and so on. So really, it's about a united voice being the strongest voice to push this platform forward. And this is indeed the first time we've had a session like this where the associations have joined together, in this case, AASLD, EASL, and INASL, to share priorities in the field of steatotic liver disease, a landscape that will be presented shortly, and then specifically the situation in India related to steatotic liver disease. So I'll just acknowledge that we've had many supporters to make this possible. We have this large collaboration, and I'll call the first speaker to the stage. If he's here, Dr. Arun Sanyal, you're invited to present an overview of steatotic liver disease, the opportunities and challenges in the field. If he is still in another session. I think in the interest of time, and since everyone is here, I can start with my presentation, and I was just told that Dr. Sanyal is about to arrive. So I'll ask the technicians to go to number 3 on that screen. Perfect. And I will present the Global Research and Action Agenda that more than 300 experts from around the world have worked on to launch. And actually, while the research agenda published in the Journal of Hepatology was launched at the EASL Congress last month. The action agenda published in Hepatology, the AASLD journal, came live yesterday in time for the INASL Congress. So we're very pleased that we were able to launch the first global action agenda in our field here today. And I'm going to take you briefly through that if I can get the clicker to work. There we go. So I think we're all aware of the serious impact of steatotic liver disease. Dr. Sanyal, I've leapfrogged you, and you will come right after me in about 10 minutes. Not a problem. So yes, the rain has come that we were spared the last couple of days. And we're well aware that this is a complex challenge, and it's a relatively silent condition, not just asymptomatic, but it's received very little attention from policymakers, although that may be different here in India, but globally the public health community and the NCD community has been silent on this issue, which is why we've created this global collaboration through the leading societies. A few years ago, we carried out a policy review of then what we were calling NAFLD and NASH-related policies, now MASLD and MASH, as you all know. We reviewed 102 countries, found that none were well prepared to address NAFLD. In fact, a third scored 0 on a 0 to 100 score, and the country that did score the best was in fact where we are now here in India. India could be doing much better, as we know, and having policies in place doesn't always mean they're well implemented. We'll hear about that from Dr. Duseja, but India scored the top score in the world based on this index, this policy preparedness index to address MASLD and MASH. We follow that up by trying to build consensus within the field that this is indeed a public health issue, and to address it as a public health issue, we need better leadership in the field. We need to better characterize the human and economic burden. And we know that there have been recent meta-analyses published, including by Dr. Yunasi in February in Hepatology, estimating that 38% of adults around the world, with great variation between and within countries, have MASLD. We need to increase our awareness. That's what this session is about, and is so important for our work. We've had sessions about treatment and care, including from Dr. Sanyal, but we need policy strategies. We need to take a whole of society approach to address NCDs holistically, and that means including steatotic liver disease among them. We need to better engage with the patient and communities, the affected and at-risk communities, and we need to better define and implement multidisciplinary, multi-stakeholder models of care. So we were able to reach a global consensus on these priority domains to address MASLD and MASH as a public health issue. We then took it up one step higher and said that if all countries, all member states of the United Nations have adopted the Sustainable Development Goals, and that includes India, then we need to try and put the liver in the center of the Sustainable Development Goals. This is also out in the last couple of weeks in hepatology. And what we did, a large global group, was to review all of the relevant indicators, the 17 goals that make up the SDGs, and figure out and agree on which ones we could monitor over time to see how countries are progressing on a fatty liver disease or steatotic liver disease Sustainable Development Goal Index developed with the Institute for Health Metrics and Evaluation, who lead the global burden of disease studies. And as you can see here, there are very low scores in countries like Niger, which will probably go down given the situation there right now, and very high in Japan. But South Asia had the lowest score as a region at 44.1, with great variation, again, between the countries. The collaboration really kicked off, I'll just go back a little bit in time since it's the first time we're presenting it in this format, at the Wilton Park think tank in the United Kingdom last October. We had been meeting online, but 50 people from around the world were able to meet at this think tank and discuss for 3 days how we can develop this roadmap, as you see in the image here, to turn the tide on steatotic liver disease. And this led to the global collaboration of over 300 people to develop this research and action agenda. So very briefly, we held a Delphi methodology over just 2 rounds, as there were high levels of consensus. It was a multidisciplinary panel that included 344 people in the first round from 94 countries, addressing those domains you see on the right that I already mentioned, emerging from the public health consensus across the rounds. The consensus increased, and finally we agreed on 28 research priorities to tackle fatty liver disease and 29 action priorities. So really what we're doing is filling the gap. This is what the World Health Organization should be doing. This is what they've done for viral hepatitis. This is what they've done for diabetes, cardiovascular disease, and many other diseases and conditions, yet nary a mention of fatty liver disease when looking at their work across the disease spectrum. So I won't go through all of these consensus statements, but regarding the research priorities, you can see here in bold the 2 priorities that had unanimous agreement. We also ranked the priorities, so we both reported where there's agreement, the level of disagreement, and then had this ranking exercise to try and set a global research agenda that people are welcome to address, that societies are welcome to adopt. Models of care, patient and community perspectives, that needs further research, both quantitative and qualitative, more education and awareness, more population-based surveys, treatment and care where our attention is often focused, but also research around the leadership and policies like the Policy Preparedness Index I presented, and others that break it down at the national and subnational level. In terms of let me go through, that should be the action priorities. We have the same 6 categories: models of care, education and awareness, leadership, human and economic burden, treatment and care, and the patient and community perspectives. These were the highest ranking actions within these 6 domains. Again, I won't go through them all now that the article was made available online just last night. So where do we go from here in this collaboration? We have a strong body of work from which to build, but now is the time to really accelerate our efforts. In Europe, we're looking at how to make concerted policy change, but we need to grow our community to engage policymakers, policy influencers, and patients as stewards of change. And we need to be thinking globally, we need to be collaborating globally to bring a common voice for more awareness and action on steatotic liver disease. So that means growing the community of practice. That means thinking not just of the liver disease experts, but also endocrinologists, obesity specialists, other clinical specialties in primary care, but also if we, since it was mentioned in the last session where we were looking at HIV and hepatitis B, look at the HIV community of practice. Look at how many different stakeholders are involved in that disease area, then compare it to steatotic liver disease where it's so much smaller. So we need to think about how to grow that community of practice, and we need to work together to have really constructive conversations around healthy livers, healthy lives, not just steatotic liver disease, but we will grow this to address other issues as well. This was already mentioned by Dr. Duseja last night, but in May, we held an event on the sidelines of the World Health Assembly. That's the highest governing body overseeing the work of the World Health Organization. And as I'll show in a moment, leading representatives, including the head of the NCD unit of the World Health Organization, joined us at the INASL headquarters to talk about our vision to end now steatotic liver disease as a global public health threat. This was done just before the nomenclature articles were published, and to mobilize action for steatotic liver disease. You can see INASL has endorsed this process, as have other leading liver organizations around the world. The Minister of Health of Egypt joined us. This was particularly important because Egypt has played such a leading role globally in eliminating hepatitis C, addressing it at the highest level at the Ministry of Health and testing millions of people across that country. He called for better planning, preparedness, and political will to address MASL D. The new INASL Secretary General, Dr. Alexander Krag, presented an action statement on steatotic liver disease called Together for Better Liver Health. You'll see again the logos are there and the language of our call to action, calling on all stakeholders, professional societies representing the fields of hepatology, obesity, nutrition, people living with liver disease, NCD civil societies, ministries of health, and others to address this. Our co-chair here, Dr. Singh, signed it, as did Dr. Maru Ranella, who's leading the special interest group at ASLD on this topic, Sven Frank, and dozens of other people who were at that landmark event in May, and that we hope to follow up with again next year and start to see real change at WHO. We can exert pressure on WHO best when we do it as a community. We can do it at the global level, but we can also do it at the regional level, and you have a regional office here in India, so you should be engaging with them about making sure steatotic liver disease is addressed in their action plans, programs, policies, and strategies. And here are just a few more images from that event. And let me just end there and thank INASL. Thank you, Dr. Singh. Thank you, Dr. Duseja, for the opportunity to have this inaugural session on healthy livers, healthy lives at your Congress. Apologies, I've already introduced you once, but welcome, welcome, Dr. Sanyal, and thank you so much for coming through the weather to get here and share your view on steatotic liver disease opportunities, challenges, and the landscape as we stand here today. I can't think of anyone better, so the floor is yours.
Thank you so much, Jeff. Can we have the slide up, please? Okay, here are my disclosures. So I want to start, I'll take a little different approach from Jeff, who took this high-level public health approach, and I'll actually try to put a human face on the problem. So we talk about a 55-year-old asymptomatic person with type 2 diabetes, hypertension, who was incidentally identified to have abnormal liver enzymes. He was told, don't worry about it. And that was 15 years ago. Now, 15 years later, he feels more tired, attributes it to getting older, but then he had a little nosebleed and was noted to be thrombocytopenic. And as you can see, hepatic functions were pretty good. But then at that point, somebody started doing a workup for thrombocytopenia. They wanted to look at his spleen. They weren't even looking at his liver. And they imaged him, and they found a 4-centimeter HCC. And at that time, his EGFR was 55. They did an echo, and they started working him up. They found he had some diastolic dysfunction as well. Another 2 years go by, and he was not listed for liver transplant because of comorbidities, age, et cetera, and he got various therapies for his HCC, eventually recurred portal vein thrombosis, progressively bed-bound, frail, got ascites, encephalopathy. Sound familiar? Anybody who takes care of liver disease who has not seen this? Probably, I don't know what specialty you're practicing. His son reduced his work hours, increased home care, there were costs, and eventually there was a terminal event with GI bleeding, brought him into the hospital, kidneys shut down, and then he died. But you know what? This is not an anonymous person. This is my uncle, my own mother's brother, who died earlier this year in this country. And so the question then really is, how in hell did this happen? Why could this not have been avoided? And that is what we're here to talk about. So we need to start, and this gave me pause to think about what really is the problem. So with any problem, we often start with what we call a SWOT analysis, where we look at strengths, weaknesses, opportunities, and threats. And I won't bore you by reading each and every one of these. We'll make these slides available for everybody. But basically, we've learned a lot about the disease. Therapeutics are getting better, although we're not quite there. And there are opportunities to increase disease awareness. We already have large cohorts in Europe, in the US, in Asia, et cetera, et cetera. NIT science is improving, surrogate outcomes, we're on their way, and we are looking at precision medicine. There are a lot of opportunities but there are also problems. And the threats are there's a low awareness among policymakers, competing health priorities for the nation, social threats, such as lifestyle, food industry, TV ads, alcohol, long, relatively silent clinical course, so it hides while it is progressing. And the business model for healthcare really requires a return on investment within 2 to 3 years. Many people, how many of you knew that? That for affecting policy change, you really need to show ROI within 2 to 3 years. So this is all important stuff. So now backing away from this, how do we work our way through it? And personally, I'm a great believer of translational science. So we start with discovery, working our way to preclinical, clinical, implementation science, and then policy and macro changes at a societal level. And we need to hit it at each and every one of these nodal points. So I'm going to start from the left, work our way to the right. So we already know that in people, there's a certain background level of predisposition. Some are more predisposed, some are less predisposed. But then you have a disease initiator, which is typically diet-induced obesity, which triggers disease perpetuating versus tissue healing mechanisms. And the balance between the two determines how aggressive or active your phenotype is, and whether you progress over time or your disease remains stable over time. So there's already a lot of work that has started on identifying the polygenic basis for the disease and for its progression. But I think the field is still very nascent over here, and there's a lot of opportunities looking forward to identifying polygenic scores, not only for development, but for progression of the disease. We're learning a lot about the transgenerational implications of having fatty liver disease, where babies born of mothers are much more prone to developing fatty liver disease. And there are now longitudinal cohorts of these babies that are being followed to see what the long-term health implications of these are. Fatty liver disease is also a major risk factor now for preeclampsia. The role of the microbiome is emerging. There are a lot of papers already out there, but they are correlational, and I would go out on a limb and say most of it eventually is going to fade away in the midst of time because they are overfitted models, and most of them will not survive over time. They are underpowered and overfitted, which is a deadly combination for getting to the truth. I think there's a very high level of false discovery in our current microbiome literature, and we really need to understand disease microbial function to understand the mechanisms by which the microbiota actually lead to disease and disease progression. We're learning that NASH is really a disease of accelerated aging with alteration in the gut-liver axis, gut-brain axis, gut-adipose tissue axis. And in the NASH population, there's a clear linkage to the P21, which is a marker of senescence, with the severity of the disease. So there are a lot of priorities in discovery science, from genetic complexity, epigenetic, microbiome, identifying which factors are passenger factors, which true and unrelated but associated with progression, versus causal modifiers of disease. We really need to focus in mechanistically on the causal drivers of disease progression and the factors that determine the waxing and waning of disease activity that you've heard about previously. And based on this, find the right therapeutic targets and subcategorize fatty liver disease, which is really a histological syndrome historically, and find subpopulations that behave in unique ways. And this is already happening in the diabetes field. The fatty liver disease field is really way behind in moving in this space. And that's really an important step for the field. Preclinical science is important to translate that discovery into things we can do in humans. So the basic science has given us many targets because fatty liver disease involves metabolism, which drives injury, inflammation, fibrosis, regeneration, oncogenesis. There isn't much biology that is left. So there is a plethora of targets, but we need in vitro and animal models to narrow down the lens, to focus down on targets and find the appropriate target. And good models must reflect human biology. They must have the kind of outcomes that you see in humans, must have the histology, the pathophysiology, the molecular, the transcriptomic, the proteomic, the lipidomic profile that you see in humans, and should be inducible by the same inducers as seen in humans, and not by crazy diets like 2% cholesterol, which is like eating 200 eggs a day. So that brings us to clinical science. So we're learning about the multi-system nature of the disease. It is not a primary liver disease. It is where the liver disease is part of a larger systemic problem, where the root cause is metabolic stress, causing systemic inflammation, fibrosis, and an accelerated immunoinflammatory senescence program. And so what is missing over here is the importance of behavior. Behavior is important because the impulsivity, motivation, avoidance tendencies determine your ability to change. These are further modulated by social support economics that determine whether you can engage in healthy lifestyle or not. And really, there's such a paucity of good science related to the behavioral basis. And this has implications for diabetes, cardiovascular medicine. But physicians just want to write a pill, the patients just want a pill. So we don't study and we don't invest in it. And I think this is a very lost opportunity and an important area for the future. We're learning about sexual dimorphism. And we've recently published data showing that males exhibit a much more inflammatory pattern in the liver as they age on just normal diet. And this has implications also for sexual dimorphism with hepatocellular carcinoma. So just have a paper accepted yesterday in Scientific Reports on this. This is a slide I stole from Dr. Nora Terreau. This was part of our NASH CRN renewal process, but it focuses on midstream social and economic determinants of health, and essentially divides this into what certain factors that are upstream, certain factors that are downstream, but we really need to pay more attention because one size does not fit all. Different types of patients have different things that are driving their disease progression and their ability to respond to therapy, having access to therapy, etc. And we're moving towards a more holistic view of the disease, where we know genetics, nutrition, environmental pollutants, lifestyle integrate, lead to this disease cascade from steatosis, steatohepatitis, to cirrhosis outcomes and death. But at the same time, there are competing threats to life from neurocognitive decline, vascular and cardiac disease, microangiopathies, chronic kidney disease, and cancers. So we need more holistic risk assessment paradigms and stop thinking about a liver-related approach to this disease alone. We further need to define within a larger population, from the literally millions of people who have excess fat in their liver, how do you identify the subset of people who are actually going to get in trouble from the liver, and how close is an individual to that trouble at a given point in time? And when you follow these people over time, can you actually understand proximity to the outcome? As you follow people, can you actually say your risk of having an outcome went from 20 to 40% or 50%, and so I'm going to do something different? So these are all opportunities. And we really need high-quality, non-invasive tools to do that. And 99% of the biomarker literature is suboptimal and substandard, and is a huge deterrent to progress in the field because people mix and match things, and we really need to have focused studies depending on the context of use, whether it is diagnostic, prognostic, disease monitoring, treatment response, all of which are needed to eventually develop surrogate endpoints that we can use to then really look at the population in a non-invasive way. Because currently, the need for a liver biopsy is a major deterrent to access to care. So the goal is to identify what we call at-risk NASH, and those with advanced fibrosis and cirrhosis. And drug development is a long journey. We heard earlier in the meeting that, oh, you come every year and tell us nothing is working. But This is not television that you're just looking for a magic solution. This is a long and a very serious process, because when we release a drug and approve it, millions of people will get the drug, and the safety has to be established, the efficacy has to be established, the boundaries within which the drug has to be used has to be established. So making blunderbuss statements doesn't really help. This is a long journey, and we are going to move through it step by step, but we need to understand the roadmap so the science that is done contributes to this rather than deters it. Now, even when you have drugs, if it's too expensive, cannot, or not available in certain countries, it's useless for that country. So this brings us to implementation. And what we currently do, our entire approach, and you've seen for the last 3 days, everybody loves to know, how do we identify the advanced cirrhosis or this and prevent decompensation? We're waiting for clinically obvious disease. And when we think about the course of the disease, where you go from healthy to metabolically unhealthy, increased adiposity, silent disease, clinically obvious disease, our entire health system around the world and our education is based on identifying clinically obvious disease and not inapparent early disease. And the numbers you see are just US data on how much we are currently spending. We need to shift our approach upstream, and that requires education and change in our thinking of how we're going to do this and link it to financial policy and outcomes. So we really need to move more into prevention mode for the long term and generate integrated, coordinated care models to enhance the patient's journey and to improve outcomes. It is not about you and me, it's about the patients. And we really need to put the patient in the center of this story. And so we need tailored, culturally appropriate patient education and counseling, and not come out with these one-size-fits-all and me-too approaches, which is the current paradigm, which finally brings me to health policy. And we've already heard there's a lack of acknowledgement of fatty liver disease as part of this metabolic syndrome. And I think I could not agree more with Jeff that we all have to join together and speak with one voice, so that we don't give mixed messaging to policymakers. They get a clear message that this is important, this needs to be on the table, and this needs to be addressed. So the last slide is that when you think about health, this is what I call the circle of health. So you start with burden of disease, which triggers our study of disease biology, which gives us druggable targets and preclinical studies. When we find the right target and the right patient with the right study design, right endpoints to demonstrate right safety and efficacy through human trials, we then get into access, and through use NITs, we increase awareness, access, and change policy. And then, and only then, we come full circle to reduce the burden of disease. And I will finish with this quote from an ancient text, which says, "Superior doctors prevent disease, mediocre doctors treat disease before it is evident, and inferior doctors treat full-blown disease." Thank you.
Thank you, Arun. That was terrific. It's my great honor to invite Professor AJ to present on the topic of India, the opportunity to lead in the arena of fatty liver disease. I really don't have to introduce you, you're so well known, but just to say he's Secretary General of INASL, but also a leader in the field, and really has shaped a lot of our thinking around NAFLD, now MASLD, and really been such an important part of how we're moving this disease forward and making this particular initiative. So we're really delighted to have you give this talk. Thank you.
Thank you very much, Professor Nora, for that very kind words and introduction. At the outset, let me thank first the INASL governing board. I think I can see Professor Thomas Berg, Russo, everybody in here, Jeff and all, and the ASLD governing board, for agreeing for this. This is, if you've seen, this is a INASL, INASL, and ASLD combined symposium. Thanks for agreeing for that, number one. Secondly, my special thanks to INASL and the INASL International Liver Foundation for incorporating and allowing INASL to be part of this healthy liver and healthy life program. So in last few years, I think there have been some initiatives which have happened in this country, India. So that's this question being asked, that do we have this opportunity to be the global leader? So I'll show you some of those initiatives, and then we see whether do we have this opportunity to be the global leader or not. So I'll start from where Jeff left and showed us this figure where he spoke about the research priorities and the action priorities. So I'll focus on these 6 research priorities and action priorities to see what all has been done in India in all these 6 areas. So let me start with the human and economic burden. I think the burden of fatty liver disease in this country is huge. And I think that's evident by some of these compiled data which we had done, about this variable prevalence as high as 53% in our part of the country. But this is one meta-analysis from our country of 50 studies involving 23,000 adults and around 3,000 children, which actually says that the prevalence in adults is close to 38.6 and not less in children, which is 35.4. So it's a huge prevalence. And not only it's fatty liver disease, we also, I told you yesterday, we have a consortium in India called Indian Consortium on NAFLD. I think somebody was asking me yesterday, do we need to change its acronym now? So what do we call ICON D? So whatever it is, but then this is our huge data. We have collected close to around 8,000 patient data, and this is our 4,000 patient interim analysis. And you can see Professor Sanyal here also, who has been mentoring us for this. So this is, to say that when these patients of fatty liver disease, when they come to the different clinics, around 20% of them actually already have, what we call significant fibrosis as defined by the serum biomarkers. And if you look at the elastography, 30% already have, significant fibrosis as defined by LSM more than 8 kilopascal, and 10% of them are already, having cirrhosis or cackled with an LSM of more than 13. Yes, there is a problem in India, but then we have really not looked into the economic burden for this. And this is one area I think which we need to define. Education and awareness, again INASL has been kind of doing some work on this. 2015 we had come out with a position paper giving some guidance, but this is a recent guidance paper published this year where we came out with some of the guidance strategies, what needs to be done about, especially about the risk stratification, about this huge number of patients with fatty liver disease. And the healthcare in India is little diversified, different at primary care level, at secondary care level. So what needs to be done at a primary care level? Who are the patients who need to be referred to the secondary and tertiary care level? What kind of strategies need to be followed? That's all this, we did that. The other thing, which is again a survey or a study which was done by the Global NASH Council, which was led by Zubair Yunusi, and we were again part of this. So this actually looked at the kind of global survey about the knowledge of physicians, which actually included gastroenterologists, hepatologists, endocrinologists, internists, to look at their knowledge about NAFLD. And to tell you, even though the representation from Asia was not large, but then what we found was that yes, physicians actually had poorer knowledge in comparison to obviously gastroenterologists, who had lesser knowledge in comparison to hepatologists. So we thought that we also need to focus on our physician colleagues. And I told you yesterday in my secretary's presentation that these guidelines which have been prepared by INASL, now we are taking at the physician level, and we've started a series of 6 different CME programs, which one we have already held, and we will now be holding these physical meetings and making our physicians aware about this. About the patient and community perspectives, again, I think I mentioned about this very important initiative which INASL has taken in collaboration with Rotary International, and this is known as the ROCO program. ROCO in Hindi, as I said, is basically ROCO means to stop. So this is the INASL and Rotary Combating Childhood Obesity and Fatty Liver program, and this was launched last month. And now we have a website where 2 states in the southern India are actually kind of collating data in the school children with the help of school teachers, looking at their anthropometry, and those who will be found to be overweight and obese will then be advised, maybe ultrasonography to look for fatty liver disease. And obviously they also need to be taught, not only children, their parents would be taught about the healthy lifestyle, and as a goal towards a healthy life and healthy liver. So this is one area, I think, initiative which we have taken, and I'm sure once it is successful in these 2 states, I think we are going to make it maybe an all India implementation for this. And special thanks, as I mentioned yesterday, to Dr. VG Mohan Prasad, Rotary International, and our academic partner Zydus for this. Treatment and care, I think the only advantage I feel in India, what we have is this one drug which has been approved by DCGI, though the data too is not very large, and this is one of the phase 3 data which is still only in the abstract form, has not been published in the full paper. But in this particular data, which was in histology, proven fatty liver disease NASH with NAS more than 4, where we had shown that the SARO patients had around 53% of them had significant reduction in NAS score of 2 or more in comparison to 23% placebo. And based on this study and some of the other evidence, the DCGI 2 years back had approved this drug, and so we are at an advantage. But then we also need to be very, very sure about the clinical indications, that how do we use this drug in combination with lifestyle interventions, and what are and all those guidance, as I said, we had given in our guidance paper. Leadership and the policies for fatty liver disease, I think Jeff showed you this study of his, where this NAFLD policy review and the preparedness index was looked at this, and to see whether the countries were ready to this. He said that out of 102 countries, around a third scored 0, and no country scored more than 50, but India scored the highest. So this is close to, I think, 50-50 score the India had, and the scoring was based on various things, which included policies, guidelines, civil awareness, detection, management, and all these scores. And the reason why India topped this particular policy review and preparedness index was this, because in India, again 3 years back, NAFLD has been included in one of its national programs, and the program which is already ongoing is called National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke. This is NPCDCS program, and NAFLD has now been included in this now, but it is time for us now to see that how this program actually gets implemented at the ground level. This is going to happen at a primary healthcare level, where we know the health. We have the ASHA workers who will be again looking at the anthropometry of these patients and some of the basic tests, blood tests, and accordingly looking at the history of diabetes, hypertension, and all that, dyslipidemia, and then they will see that how the fatty liver can be screened and what best can be done. And the risk stratification, again, this program gives us that who are the patients who can be managed at the primary care level, and who are the patients who need to be referred to a secondary and a tertiary care level. So, ladies and gentlemen, I'll summarize here what I said in last 10-12 minutes is that yes, India has a high prevalence of MASLD, and yes, we do have the opportunity to be leader in MASLD. And the reasons for this is that yes, we have been working towards the education and awareness about fatty liver disease in this country. We have also taken some patient and community initiatives, and the important one which I showed you is the ROCO campaign, which is in collaboration with Rotary International and INASL, has taken to look at the childhood obesity and fatty liver disease. We are at an advantage of having one drug which is approved with us, but then, as I said, we need to follow a certain guidance about its usage, with or without lifestyle, and the lifestyle interventions obviously would say whether we need to add this particular drug. I think that we need to see. most important is, inclusion of fatty liver disease in one of our national programs, that is the NPCDCS, and that has given real edge to us in India to become the global leader in MESLT. Thank you very much for your kind attention.
Thank you very much, AJ. I mean, that was a perfect presentation. Thank you so much. I hope every country around the world will do something like that. I don't think many will be able to present the kind of success you have, but it'll give us an opportunity to benchmark where we are in 2023 and then compare over time against these priorities that we've all set. We have about 20 minutes now for questions and comments from the audience to any of the speakers or any of the chairs, please.
So Jeff, a question like India is integrating NAFLD into the non-communicable disease program. And you are also putting so much of efforts that it should be taken care of, that there should be some priorities for action, there should be some priorities for research. So why we can't have this integration into the WHO's global NCD action plan? So have you had any dialogue with WHO? And because in 2013, when they had the first global NCD action plan, at that time, also I was working with Dr. Sareen, and we have written to WHO that non-alcoholic fatty liver disease related cirrhosis, cancer, even NASH, alcoholic liver disease should also be, talked about somewhere in the global NCD action plan also. So it was not done in the recent the plan also. So what's your view on that?
Well, my view, and it's a great comment, is that it's completely incomprehensible. I mean, we all know, we also saw Dr. Sanyal present it. Why would you not mention the liver when you're talking about NCDs? I often say that when you search for the word liver in the WHO report, it does come up a couple of times, but only as a part of the word deliver, to deliver on diabetes and to deliver on cancer and other NCDs, but you'll never see MASLD or NAFLD or steatosis mentioned in the NCD, the WHO NCD programs of action, even their last publication, which are technical guidance, which I thought was so important, which was the meaningful involvement of people living with non-communicable diseases, did not include anyone living with any liver disease. So I think the event in May, I do honestly believe really will initiate a change, and they're realizing that they have to address it. But we need pressure from countries, we need pressure at the WHO national level, but also at the regional level. And we can learn a lot from the viral hepatitis playbook, where India, Indonesia, Brazil, and other countries, raised awareness at the executive board of the World Health Assembly, and eventually a WHO strategy on viral hepatitis came. But remember, that strategy came in 2016. We had been dealing with hepatitis C for a long time. We had DAAs available, and we still didn't have a WHO strategy. So, I worked 11 years there. We often joked that there were two speeds at WHO, slow and stop. But I think we need to really work with WHO to accelerate and include this. Thank you. Please.
Thank you.
I have a slightly different perspective on how to prioritize for NASH. I think the foremost is we understand that lifestyle modification is very important and practical. However, in many places, we don't have the environment in which lifestyle modification can take place. And I think, as far as the large public is concerned, that's the primary place where we need to work. And that means you need a place where you can safely walk, which in many parts of India you can't, especially in the urban areas. Not even a pavement is there next to the road. So creating an environment where you can change lifestyle, have walking space or exercise, and changing your diet, where healthy diet is given certain incentives, certain priorities, certain benefit. So the ability to change the lifestyle on a national scale should be the number one priority as far as I am concerned. And the number two is to identify the people who are at risk, greater risk, and then give targeted guidance evaluation, treatment for them.
I'll be happy to. Okay.
Yeah, Abe, I agree with you. I think, and I had in one of my slides that for you have a macro, view, and then there's the individual patient. Certainly, at an individual patient level, you have to understand all the barriers and find the solution. And if you know one patient, then you know one patient because everybody's life story is different. The guy who has to sit in his shop from 8 a.m. to 8 p.m. and he's afraid that if he leaves, he cannot trust anybody. You have to figure out a different solution for that. But I think having green spaces and areas where people can safely walk and exercise or do other things are an important. But it alone will not fix the problem. It's one of many things that have to be fixed.
I'll just add, I mean, you've raised really what I think is going to be one of the fundamental barriers and obstacles moving forward. Because, at the clinical level, you can make the recommendation to change your lifestyle, but you really put the onus on the individual. And as you mentioned, thinking of the social determinants of health, so many individuals, maybe even a majority in the world, won't be able to make those changes. So we need to look at what kinds of structural changes we can make. We also need to look at the commercial determinants of health that make it so hard for an individual to make that healthy lifestyle decision, if they're even able to make it at all, because they may not have those kinds of healthy options or urban green spaces. In the SDG fatty liver disease index I presented, we included an indicator from the Sustainable Development Goals called urban green spaces. There was only data available from 60 countries, and one of our co-authors, Shiraz Elbersagi, who's well known for her work on lifestyles and inequities, said, well, you can't just say it's positive to have UGS, because in many places it's actually not safe to walk in those urban green spaces. So you need to break it down another level, because I said if you have a lot of urban green space in your built environment, you kind of get more points. And she said, well, many people will be avoiding those places. So it's very complex, but you're absolutely right. No one's going to be able to bike or walk if it's not safe on the roads or those spaces aren't available. Thank you for bringing that up. Over.
Can I just kind of follow up on another aspect, and that is around the policy and how to use policy to get, like I think about alcohol and how alcohol policy, how late your pubs stay open, the tax on the alcohol has actually led to decreased alcohol use in certain countries. So can we use policy in the same way around healthy food? If I think about the fast food industry, the soft drinks, is there a place for policy change that could really be on a global basis more powerful? Do you want to maybe speak to that, Ajay?
I think your points are well taken. Yeah, it needs a lot of other inputs and a lot of other efforts, and one of them I think we have been discussing on is to fight the fast food industry and the soft drinks. It's a huge thing. So how we do this, I think that's a mega effort. I think, but then yes, this needs to be done. Yeah.
I think it's really complicated because in Mexico City, where we are doing a lot of work, what we found out is that people who have reached a certain level of affluence, one of the ways they celebrate their newfound affluence is by waking up in the morning and drinking a soda, whereas historically, they would just have whatever they normally eat. And so it is changing the way people think. So there has to be linkage to education and awareness efforts. And it's really important to start right in school and somehow figure out how we integrate healthy living practices related education very early in life. One thing that we have not leveraged as a medical community is the power of children to change the behavior of the parents.
So that's being maybe done in the ROCO program. We are looking at that. Yes, Professor Arora, please.
Yeah, I think as much as it is a good initiative to start the program, I think it has to be region and the area specific. In country like India, where 70% of the medical services are rendered by the private people in the private practice, I'm surprised and sad to know, even in an integrated program like National Viral Hepatitis Control Program, private sector is never involved. And you'll be surprised to know that 50 to 60% of the hepatologists in practice may not be aware of it. So that dichotomy has to go. In case we are integrating national fatty liver disease program in the Indian scenarios, I think you have to have the private sector in mind. My question is to Dr. Arun. So that is just a comment. And Arun, is it possible to incentivize, say, in a employment area, in entrance to the school, in your promotion, that if you're able to maintain your BMI, there will be some incentive. Because if you take care of single factor, I think you can prevent the cascades of the incoming event at some level. It may be barbaric, it may be dictatorial, but possibly that is what is needed.
Well, I don't know about making that a criteria for entry into college or a specific type of job, but what you can do is, particularly in areas where there's third-party payment, that you can, and where the company is providing the coverage for the third-party payment, the insurance, that there could be incentives if the company can implement time out for people in the middle of the day to exercise. Over the last 50 years, we have incorporated a work culture which is primarily sedentary. And we have, the consequence of that is all this metabolic ill health. So maybe there may be those type of opportunities, and they'll have to be beta tested to see whether it works. Many things sound like a good idea, but when you put it into play, then all kinds of other things happen. But I think those are the kind of, I think we all have to be innovative, think out of the box to find those type of solutions.
Yeah, I would just add to that, where you have private insurance, sometimes those insurance companies will incentivize for healthy lifestyles. It could be BMI, it could be vaccination, and others. And just a comment to Arun, when I lived in Mexico City, the president of Mexico was the former president of Pepsi Cola. So it seems he may have enacted some of his policies in practice. Did you want to comment?
Yeah, Professor Reddy, please.
No, I guess this is a general question to the panelists. I'm wondering whether we're really taking a very telescopic view of the problem. We just, as hepatologists, we're focusing on fatty liver disease, but should the efforts be more broad? If you and then incorporate metabolic syndrome and the education in terms of policy change, because the number one killer is heart disease and diabetes and then cancers. Liver disease is actually number 3 if you look at metabolic syndrome related outcomes. So I'm just wondering whether we should really have a more broader perspective on and I think, Arun, you touched on it a little bit, but you don't hear that often. Fatty liver, fatty liver, fatty liver. Let's talk about other things.
You are absolutely right.
Yeah.
Your clinical sense tells you that we're looking at it the wrong way. This is not a primary liver disease. It's a systemic disease of which the liver is part. And so this is why the push to WHO to say, under this larger umbrella of NCDs and metabolic diseases, liver has to be integrated into that. And we really need to think about identifying people when they're metabolically unhealthy but have not damaged their end organs. Our entire approach is based on finding people with irreversibly damaged or seriously damaged end organs and try to put a Band-Aid on it. So we're spending more and more for small incremental gains, where I really believe that if we can change societal thinking and policy and to bring it earlier and create care pathways mainly in primary care to figure out who's metabolically unhealthy and target them for sort of preventive approaches and keep our advanced therapeutics for the limited number of people where the system fails them for one reason or the other.
Yeah, just to add on to that, that's one of the reasons that in India, the NAFLD was included in that NPCDCS, which is a non-communicable disease program, because you already have the infrastructure and the manpower in place to look after diabetes, obesity, cancer, stroke. So, the NAFLD probably would come in there. But as I said, we have long way to go before we do that. Yeah, Dr. Vici.
Yeah, thank you so much. I think I should thank ICOND and the president and secretary and the entire team for bringing Rotary in, because already Rotary is involved in the NPCDS program of the Government of India. So, and all of them have taken a pledge to take this forward. And we, in Tamil, there is a saying that "Aindil valayadadu, aimbadil valayadu," which means if your body cannot be flexed at the age of 5, you can never do that at 50. So I think we need to take it to the children. So in our project also, INASL ROCO, what we said is each one teach 10. So each child has to take a pamphlet and read it out to at least 10 people. This way, I think the awareness will be spread north, south, east, west. And I think today in India, it's become a problem. The obesity and the fatty liver disease is going to increase multitude over the next 2 decades, because all children in the urban areas eat all junk food. They're completely glued to phones, mobile phones, and computer apps and tabs and whatnot, and they don't do any sort of exercise. I've seen this time and again, even in sports people and people who are into games. Once they quit the sports activity, they just put on tremendously, they become obese and also develop fatty liver disease. So I think the only solution is not to fight the soft drink companies or even the junk food companies, but to educate the children that they have to live a good lifestyle in order to have a safe and healthy living. I think we have initiated, let us hope and pray it goes through very well over the next 2
Thank you,
years.
Dr. VG. And I think yesterday I played your speech when this website, and thank you so much for helping in INASL for all this. Thank you very much. Yeah, please, Dr.
No,
Yeah.
I think you're absolutely right. I do think in tandem, as was recommended in the EASL Lancet Commission a couple of years ago, we do need to stop or full out prohibit the marketing of ultra processed foods and soft drinks to children. I think there are things we can do. There was an interesting initiative some years ago from a former WHO colleague who joined in a company producing beer, and his contribution was to reduce the amount of alcohol in Anheuser-Busch beer. So there are things we can do at that level while we're also educating the children. And just regarding the comment from the last speaker, as we grow the community of practice, and we've been talking about WHO and these higher levels, but also the ministerial level here in India, we could think about having sessions like this, maybe in an Indian endocrinology conference, cardiology conference. You might find the reaction similar to what we've sometimes found at the European level, which is there's very little interest, or one person might be allowed to give one 15-minute talk. But I think that's where we're also going to make the change, when we see this discussion happening outside of Liverfora as well.
Yeah, Dr. Rohit. Yeah, Rohit.
Just adding to the discussion on children. So I think that in India, at least 2 areas where kids have changed parents' behavior. One is use of polythene when you go to market to buy things. So now kids are asking their parents not to carry that plastics. And second is use of crackers during Diwali. So it has really impacted on parents. So I personally believe that focusing on children, and I think that INASL initiative of ROCO will be a good step, and enhancing it further to different areas of the country will really work.
Yes, please.
Yeah. Dr. Sanyal sir, so I want to know about the PCOD and the involvement of NFLD in PCOD females.
Oh, polycystic.
Yeah,
Oh,
polycystic ovarian disease, because the incidence of the PCOS and NFLD are increasing. So
yes. So again, this reminds us that we're talking about a systemic disorder. Different end organs react differently. So the heart becomes stiff, the arteries become stiff, the liver becomes initially fat, then it becomes scarred down and stiff, and the ovaries fail. So, it's what we forget is it's all happening in the same patient. And so patients are seen in different medical silos. And we need to educate all of the different silos where these patients who have this different profile of comorbidities live, so that in each silo, we're looking at all the other end organs. Hepatologists, for example, don't do a great job of looking at the lipid profile or knowing how to manage lipids. for example, or glycemia. With this disease, it's a wake-up call that instead of saying, oh, I will only deal with this, I think we have to learn to come back full circle to internal medicine, just as the OBGYN people or the endocrinologists who are taking care of PCOS have to learn about the liver, cardiologists have to learn about the liver. So we really have to integrate. So there are opportunities at every level for us to do better, because I think what we're currently doing is suboptimal.
So with this, I think, thank you. You want to make any comment? Anybody? No. So thank you very much. I'd like to thank all the speakers, chairpersons, and again, INASL and ASLD for giving us this opportunity and this wonderful effort on healthy liver, healthy life. Thank you very much for all of you for wonderful interaction and questions and insight. Thank you very much.
Well, thank you so much, everybody, for your patient hearing. Now we may disperse for the lunch, which is at the Crystal Hall and the basement, and for the faculties, it's at the faculty lounge. Also, simultaneously, we are having a poster presentation going on in the Mayfair Lagoon side, on the other side of this Mayfair convention. And the next session here, we resume back sharp at 2:30. Thank you. Session 6 on Symposium on Autoimmune Liver Diseases. The chairperson of the same are Dr. Meena B. Bansal, ISM at Mount Sinai, USA. Dr. Sandeep Dhawan, Postgraduate Institute of Medical Education and Research, Chandigarh. Dr. Vandana Midha, Dayanand Medical College and Hospital, Ludhiana.
Okay, we're going to start this session. Our first speaker is Dr. Ashish Goyal, Managing Autoimmune Hepatitis in Special Populations.
At the outset, thank you to the organizing committee for inviting me here. And the topic for me was managing in special situations. I have just taken a few of them: pregnancy, cirrhosis, and ACLF. I'll try and cover some aspects of that. So I'll start directly with the general management of autoimmune hepatitis, and these are the drugs that are used. Can I have a pointer, please? These are the drugs that are used. Either we can use prednisolone alone or prednisolone with azathioprine, and both of them have more or less equivalent effect, and they are used at a tapering dose and a slow taper. If you have a prolonged remission, you can start withdrawing them or thinking about withdrawing them after 2 years of sustained remission. General recommendation is try and have a histological remission as well. As far as the pregnant female is concerned, more or less same regimens, and as we know, azathioprine is considered to be safe use in pregnancy. So immunosuppression really doesn't need too much of changes. Few things. One is budesonide is not very much tested in pregnancy and not an option here, whereas budesonide in a general AIH patient can be tried, though recent data suggests prednisolone being a bit superior. Few things that we need to take care in pregnant female. If it is a planned pregnancy, if the person goes in with a sustained remission, the chances of a good outcome is much better. Whenever we are going in for pregnancy, we will have to explain about the flare, even if there is a remission at the time, and we will have to explain that there may be a maternal and fetal complications thereof. Whatever immunosuppression the person is on at the time of pregnancy needs to be continued if it is in remission, and both steroids and azathioprine can be given. We generally would prefer steroids alone. MMF is contraindicated and should not be used in the pregnancy, and we have to expect postpartum flares, and up to an extent of 6 months after delivery, there can still be postpartum flares. So we will have to have an expectant outlook there. As far as cirrhosis is concerned, again, more or less similar regimens, and azathioprine we would be hesitant to use in decompensated to start with, but we can use prednisolone. And most of us would generally prefer a lower dose of prednisolone to start with in cirrhotic patients. When we will have to start tapering, but even if after sustained remission, whether can we withdraw steroids in a patient who is already a cirrhotic liver is still unclear. There may be a need for a continued immunosuppression. We can try and attempt withdrawal in very well controlled patients as well. The tolerance of immunosuppression, whatever we give prednisolone or prednisolone with azathioprine, decreases as the decompensation increases. As the patient starts developing ascites, these people do not tolerate immunosuppression. More and more infections are known to happen. Again, the probability of responding to medications like steroids is lesser with increasing decompensation. So general dictum, I would say, in autoimmune hepatitis for any cirrhosis, the standard indications for evaluation for and listing for liver transplant do hold good in this situation as well. This is a study way back, recent study, actually 203 odd patients in autoimmune hepatitis and almost 62% 90-day transplant-free survival. What they had shown is that patients who are older, higher MELD, hepatic NKF or developed ascites do not tolerate immunosuppression, and the prolonged therapy in these patients should be avoided if there is a transplant option. So when can we give a steroid trial? Still, most of our patients will not be sort of for liver transplantation, but when are we safe to give a steroid trial in these patients? I would say a lower grade of encephalopathy or a lower MELD score, the patient may still respond to steroid trial with all the caveats. We may have to give a smaller dose to start with and consider on treatment response assessment. What is the MELD score cutoff? Various studies have shown various cutoffs, but around 24 to 27 MELD cutoff is reasonable. A higher MELD score, really steroid trial may be more dangerous than favorable. A recent study from the AARC APASL consortium that we have showed that on treatment response on day 3 with INR and bilirubin response with steroid may also help in predicting response. So we don't have to wait for 1 week, 2 weeks for MELD response. You can assess at day 3 as well. And this is something that can be done in regular practice as well in patients with acute and chronic liver failure. So I'm just going to change the track a bit. What we know is autoimmune hepatitis ACLF is adaptive immune response by the liver. So we know adaptive immune system attacking the liver, and we are very comfortable in calling that autoimmune hepatitis. But when the patient develops ACLF, in addition to the adaptive, there is innate immune activation. So there is innate immune system also attacking our liver, but we do not have a good enough terminology to describe this phenomena, and we call it as a combined ACLF. We have good tests, and we know increased immunoglobulins or antibodies positive suggest an adaptive immune response, but we do not have a well-established armamentarium to assess innate immune activation. Some of these tests that we do in routine clinical practice, von Willebrand factor for reticuloendothelial activation. We also do a soluble CD163 again for macrophage activation. Some of us will be doing ferritin levels again suggesting macrophage activation. So these patients, again in ACLF, we had studied in a different cohort of patients, alcoholic hepatitis, and most of these ACLF patients have either all of these criteria fulfilled. Basically, they have macrophage activation syndrome, increased ferritin levels, increased von Willebrand factors, and von Willebrand factor increased level actually correlates with a short-term outcome over 3 months. So when we incubated the plasma of these alcoholic ACLF patients with normal monocytes, what we found was an exhausted immune reaction. We found there is a liver homing of the chemokine receptors, there is release of inflammatory cytokines, and there was exhaustion of the immune system as well, suggesting that there is a pathogenic role of the plasma in these patients which is driving the reticuloendothelial activation. So the most likely most of us will be working in centers where transplantation may not be a very feasible option for most of our patients in ACLF, and the current most of our centers would be doing plasma exchange in these patients. So we sort of have had a non-systematic review. Now we have data in both acute liver failure and acute on chronic liver failure patients. We have got 2 randomized control trials on both sides, which suggests a significantly better outcome with plasma exchange compared to standard medical therapy. So I'll just summarize this data for us. This is in acute liver failure. There are 2 randomized trials. One is the Larson et al. From European multicentric trial, which showed around 11% survival benefit without transplant in these patients. Again, this is mostly paracetamol overdose. The other study is from ILBS, which showed a 30% short-term survival benefit in viral hepatitis, mostly viral hepatitis related ALF. In acute and chronic liver failure, the data is limited. It is only from the eastern countries, and both of them have hepatitis B related acute and chronic liver failure, which showed a 13% survival benefit in one and around 37% in the other study. Interestingly, the survival benefit was seen only in patients with MELD 30 to 40. So if the MELD goes up very high, more than 40, the survival benefit remains dismal. We looked also at the matched cohorts from India, and we looked at etiology, because we all know that in acute liver failure, at least the etiology is the king, and the etiology will decide the outcome of these patients. So we looked at, there is a study from ILBS which had looked only at Wilson's disease outcomes of high volume plasma exchange, and they had shown a survival benefit in this group. We looked at rodenticide-induced liver failure, which is paracetamol-like illness for us, and we showed a significant survival benefit in this group. Again, in alcohol patients, we had shown a bit of survival benefit over 3 months, but there are 2 studies from AIMS and PGI Chandigarh. They did show a trend, but did not show a significant benefit in ACLF. So ACLF, if we are looking for matched etiologies, the survival benefit is to the tune of 10 to 15% at the most. So how do we choose whether to go in for liver transplant or whether a patient can be sort of offered plasma exchange? That all what we think may be dependent upon what is available at each center. So if the countries where the deceased donor liver transplant program is very active, any acute liver failure patient would be urgently listed for liver transplant at present, and if there are contraindications, they may be considered for plasma exchange. But in countries in India where live donor liver transplant is prevalent, we can list for live donor. We may also think about plasma exchange and see response over next 1 or 2 cycles and see whether it works, and then go in for live donor liver transplant. For most of the centers which cannot, or the reality is that most of our patients do not opt for liver transplant, then we have only option between plasma exchange and standard medical therapy, and that seems to be quite clear that for us that plasma exchange works better than standard medical therapy. Again, it's based on the severity of illness, and if there is acute on chronic liver failure, as and when organ failures start developing, more likely the plasma exchange is not going to be beneficial. Whereas if there is a single or 2 organ failure, you can still consider plasma exchange in this patient with liver transplant as a rescue treatment is. So I'll end with an interesting case that we had seen. One 51-year-old lady with jaundice and followed soon by ascites with no significant alcohol intake, but as is generally the case, there was herbal medications, and initial lab investigations showed a bilirubin of 31 mg/% with a high enzymes, SGOT of 441 and an INR of 2. The usual etiology workup viruses were negative. but IgG was mildly raised with ANA positivity, and von Willebrand factor, as we do in most of our patients, was very high, normal levels being 50 to 150. So it is almost 5 times higher than the normal upper limit. Radiology showed coarse liver with collaterals. So our working diagnosis was acute on chronic liver failure with possible AIH flare, which is triggered by one of the drugs, which is herbal medications. The MELD score here was 29. We suggested liver biopsy, but we thought it was quite difficult currently, and suggested liver transplant evaluation, which again, in most of our patients, not feasible. So this patient underwent 5 cycles of low volume plasma exchange. We do a low volume plasma exchange at our center, which is 0.5 times the estimated plasma volume each cycle every day. So 5 times the low volume plasma exchange. We always combine it with low dose steroids, 10 mg prednisolone as per protocol. And good for us that the patient started improving slowly over the time, and we have a 6-month follow-up where the patient has improved considerably. Most of the centers in India now are offering plasma exchange. We are continuing to offer plasma exchange to our patients with acute liver failure and difficult to treat acute on chronic liver failure patients as well. And this is our data which we had compiled over the years of how many plasma exchange sessions we have done. We follow everybody will be following a different protocol for plasma exchange. Currently, we do not have a standardized protocol as far as how much volume is needed for the plasma exchange to be effective. We follow a low volume plasma exchange protocol where we are sort of exchanging only 0.5 times the estimated plasma volume each session, targeting for 3 sessions at a initial stage, and then going by the clinical decision making. We are cognizant of the fact that there is a risk of infection, so all of them will be on prophylactic antibiotics. We minimize the prophylactic blood product transfusion, so our line placement generally is without products and ultrasound guidance. So to summarize here, I think what we have done is pregnancy and cirrhosis do require a bit of modification in the management protocol of AIH, but more or less remains the same. Liver transplant, again, as I said, remains the mainstay of AIH ACLF, and steroid may not work at that extent, but most of our patients will not tolerate steroid, will not be for liver transplant. So we have to recognize innate immune activation and treatment for that. And one of the treatment will be to consider therapeutic plasma exchange in patients with AIH ACLF. Thank you.
Thank you, Dr. Ashish. You can please join us here. I think we can have the questions at the end of all 3 talks. The next talk is management of non-responders to first-line drugs in autoimmune hepatitis. The speaker is Dr. Vivek Saraswat.
Thank you, Dr. Vandana, chairpersons. Good afternoon, ladies and gentlemen. At the outset, I'd like to thank the organizers of this meeting for giving me the opportunity. And in the next 10-12 minutes, I'd like to take you through management of non-responders to first-line drugs in autoimmune hepatitis. As a word of background, we all know that autoimmune hepatitis is defined by elevated enzymes in total IgG and the presence of one or more characteristic autoantibodies and typical histologic abnormalities that you all know very well. Now, once the diagnosis is established, one starts the first-line treatment, and I'll only spend a couple of words. Dr. Ashish has already referred to first-line treatment, and this consists of an induction and a maintenance schedule, which in those in whom there is non-response, which may be in the form of either intolerance to the first-line drugs, non-response itself, and I'll define all these terms in the subsequent slides, or there may actually be treatment failure to first-line drugs. These are the indications for which second-line therapies are offered. And there are also numerous, taking a leaf out of the IBD book, where a lot of new therapies are being tried in autoimmune hepatitis. So a quick word about first-line treatment. According to the recent Korean guidelines, once a diagnosis of AIH is made, one moves to induction therapy, which by and large is a combination of steroids with azathioprine, and in suitable patients it may be budesonide along with azathioprine. In certain selected situations, for like example in acute severe AIH or AIH like DILI, or where there are contraindications to AZA, one may use steroid monotherapy. Now, once therapy has been initiated, at 4 weeks, one judges the response to this first line therapy, and which is a responder has a 50% or more decrease in baseline transaminase levels to be labeled as, and that's when you start tapering and moving on to the maintenance phase of therapy. While non-response is when there is less than this about 50% decrease in serum transaminases, where then you would proceed down the path of moving to second line drugs. The maintenance phase of AIH, primarily the challenges are related to drug intolerance, which may be intolerance to prednisolone or to azathioprine, and after taking various steps to deal with the intolerance, one has to consider the use of second line drugs like mycophenolate mofetil, and cyclosporin, CNIs, tacrolimus, as well as 6-MP and 6-TG, and I'll come to each one of these in the next slides. Before we move on to that, I think what exactly are the various responses that one expects to first-line therapy, and the lack of these responses is then the reason to move on to second-line therapies. Well, the goal of immunosuppressive therapy in these individuals is to achieve a remission. Clinical remission in this context would be resolution of symptoms. A complete or a biochemical response would be complete normalization of the transaminases and even the serum IgG levels, while a histologic response would be histologic activity index dropping below 4, and this or these things all seen together would constitute a complete response. Generally, on standard first-line therapy, once the diagnosis is correctly made, about 65% are expected to respond in 18 months, while this figure may go up to 80% in a period of 3 years. Now, incomplete response refers to response being there but not achieving these targets when you would call it remission, and about 13% will achieve an incomplete response. Non-response would be that at 4-week assessment, less than 50% decrease in transaminases is noted. That would be termed non-response, while a treatment failure would be actual deterioration in clinical, biochemical, or histologic features after starting first-line therapy, which may be at as early as 3 to 6 weeks after initiating first-line therapy, and is seen in about 10% of these patients. While intolerance obviously would be that any treatment-related adverse events attributable to drugs that are experienced during the course of therapy, and these then form the reasons for moving on to second-line therapy. Now, before one proceeds further, once non-response is observed, which may be incomplete or partial response or non-response or a treatment failure, the first thing to do is to review the diagnosis. Are you sure you've got the diagnosis right? And I think I don't need to go through the simplified diagnostic score of the IAIHG or the revised original diagnostic system. We are all familiar with the characteristics and the scoring systems that are achieved pre-treatment and following treatment. These would help you to review your diagnosis and see that you are on the right track in labeling the patient, and going through this checklist that is part of the recent ASD guidance for all autoimmune hepatitis, I always find useful. You should basically review and make sure that you're not dealing with an overlap syndrome or PBC or PSC. The simultaneous presence of autoimmune hepatitis and fatty liver disease may be another confounder, as may be seronegative autoimmune hepatitis. So once all these things are not there and you have your classical autoimmune hepatitis diagnosis, then we move on to the down the road to second line or salvage therapies, which, as I said earlier, they are primarily indicated either for intolerance to first line drugs or to treatment failure or failure of therapy, or to incomplete or non-response to first line therapies. I'll just spend a bit of time talking to you about intolerance, which is generally to thiopurines could be a major factor, could be the presence of polymorphisms of the TPMT gene or the NUDT15 gene, which is increasingly being picked up. Now, thiopurine S-methyl transferase or TPMT gene is the gene that metabolizes 6-azathioprine and which is undergoes conversion to 6-mercaptopurine, which is the active drug in the body, and there are polymorphisms which will lead to reduced activity of the TPMT gene, resulting in markedly increased levels of 6-thioguanine nucleotides, which are the active molecules exerting the effect of azathioprine. And if these levels increase markedly, there's going to be severe bone marrow suppression. Of these, TPMT2 and 3 are the most common forms of polymorphisms that are seen. And amongst Caucasian populations, homozygous mutations can be seen as often as 1 in 300 individuals, where there is virtually very low or no TPMT activity and resulting in very high levels of 6-thioguanine nucleotides. While in the heterozygous, which may form in 10%, there will be reduction, and which will necessitate reducing the dose of azathioprine, and these could be responsible for toxicity and intolerance of drugs. TPMT gene polymorphisms are uncommon in Asian populations, including South Asian populations, and various strategies for TPMT testing, that is stressed in all before starting azathioprines or thiopurines, or only test once severe leukopenia to standard doses experienced. There is no clear-cut consensus amongst guidelines. And another important gene that polymorphisms of which can lead to toxicity and intolerance is the nucleoside diphosphate linked moiety X15 gene, that is the NUDT15 polymorphisms. And this particular SNP-R139C is the one most often linked to thiopurine toxicity, leading to very severe myelosuppression in homozygous individuals. This is particularly common in Asians, East Asians, and even in South Asian populations. There is a study from PGI Chandigarh documenting the presence of this mutation. And it is commoner than one sees in the TPMT mutations among the Asians. That is up to 1 to 3% may be homozygous, and up to 20% may be heterozygous, necessitating dramatic reductions in the AZA doses in these individuals. Again, although this is found to be more important in Asian populations, we do not have a sufficient body of literature to recommend routine testing for NUDT50 polymorphisms in our population. So now these second line options that we have are most commonly used as mycophenolate mofetil. CNIs, particularly tacrolimus, is the other alternative that is used. And thiopurine metabolites that are downstream products of azathioprine, that is 6-mercaptopurine, 6-thioguanine, and also a small place for allopurinol can be found. Other strategies include B-cell depleting therapy with rituximab, infliximab, and other biologic agents that are being emerging, including some novel strategies that I'll talk about in the later slides. The most commonly used second-line agent is mycophenolate, which acts by decreasing T-cell and B-cell proliferation, suppressing antibody formation, and also affecting cell-mediated immunity. Doses are generally in 1 to 2 grams a day, and in up to 60%, 58 to 61% of people who show a lack of response to the first line therapy, one achieves a response with mycophenolate, particularly if the indication has been intolerance to the drug, while in a lower percentage of non-responders, mycophenolate is also helpful. The adverse events we are familiar with: hematologic, GI symptoms, neurologic toxicity, and particularly in pregnant ladies, this is contraindicated because mycophenolate is teratogenic. Among the CNIs, tacrolimus is the most commonly used second-line agent, and in the dose of 0.5 to 6 mg per day. And the response can be achieved in as many as 59% when it is used as a second-line agent. Roughly similar for intolerance and for incomplete response. And tacrolimus may actually perform better than mycophenolate for when the reason for treatment is incomplete or non-response. Side effects are seen in a quarter of these patients, including nephrotoxicity, diabetes, hypertension, and therapeutic drug monitoring of tacrolimus levels is desirable. 6-mercaptopurine is particularly useful in patients who are intolerant to azathioprine in these doses. And in small studies, in all these second-line studies, there are no large databases to validate one versus the other. They are generally small studies that show the benefit, which may be seen in up to 75%. And the side effects of 6-mercaptopurine are similar to that of azathioprine: leukopenia, GI side effects, skin rashes, and arthralgias. While 6-thioguanine may be also helpful in the similar situation, that is intolerance to AZA, and biochemical response can be seen in up to 58% of these individuals. Particularly with 6-thioguanine, in other situations, the sinusoidal obstruction syndrome has been noted in several of these patients, and one needs to be watch out for that if you choose this option. Allopurinol, which is a xanthine oxidase inhibitor, may be helpful in non-responders by inhibiting the conversion of 6-mercaptopurine to its inactive metabolite thiouric acid, and thus diverting 6-MP to form more 6-thioguanine nucleotides, and thus increasing the immunosuppressive effects of azathioprine. And again, in small studies, adding allopurinol to a low dose of azathioprine has been found to be effective. Rituximab, which is an anti-monoclonal against CD20 and has a B-cell depleting strategy, has been found to be effective in small studies. And recently, a retrospective multi-center data of about 22 patients has been accumulated, where indications were similar to what we have talked about earlier. And 2 infusions of 1,000 milligrams given 2 weeks apart. Patients were followed for 2 years, and a significant decrease in autoimmune hepatitis activity as shown by improvement in serum IgG as well as decrease in OTPT levels, and improvement in albumin, freedom from AIH flares, and a decrease in a dose of steroids was noted in this study. So its safety profile was quite satisfactory, and more studies are needed for licensing this for indication. This table basically summarizes what are the second and the third line therapies for autoimmune hepatitis, something that I've already spoken to you about. Agents in the pipeline include this interesting immunoproteasome inhibitor, that is zitomipzomib, which has a non-immunosuppressive inflammatory action and has a very favorable safety profile, undergoing phase 2 studies for autoimmune hepatitis. Other B-cell depletion strategies, including B-cell activating factor inhibitors, anti-CD40, pro-inflammatory cytokine inhibitors against TNF-alpha, IL-6, and various other interleukins have been studied and being evaluated for autoimmune hepatitis, as well as modulation of the inhibitors of the pro-inhibitory of the same cytokines. So in summary, once you have started patients with a proven diagnosis of AIH on first-line therapy, if there is response, all to the good. But if there is either insufficient response or intolerance, for insufficient response, one should measure azathioprine metabolites like 6-thioguanine nucleotides. If the level is less than 220, it suggests that there is a problem with adherence. Just a minute. Or there may be need to increase the dose or add allopurinol with low dose to increase the efficacy of 6-thioguanine nucleotides. This strategy may work. That would be great. Otherwise, this can be, if the metabolites are more than 220, one should re-look at the diagnosis and make sure that you have the right diagnosis. Intensify the first-line therapy using higher doses, and either you could use 6-mercaptopurine or mycophenolate. Similarly, when there is intolerance, one can use these 2 agents. Either you achieve a response, or if there is insufficient response, one can then think of moving to experimental third-line therapies like the one that I showed to you in the previous slides, that is be part of ongoing studies and trials that may be taking place. Thank you very much for your attention.
Thank you, Professor Saraswat. Kindly join us. Now, coming to the last topic, that's on the recent concepts in the management of PBC and PSC. I'll invite Dr. Amit Goel.
Good afternoon, everyone. I would like to thank the organizer for giving me this opportunity. And also, when I was reviewing the literature for PBC, PSC, I thought there are too much in PBC, so I will restrict myself to PBC only. I apologize for that. I will talk about the diagnostic algorithm, what is new, how to diagnose in AMA positive patient with normal ALP, importance of liver fibrosis at baseline assessment, a score for prediction of outcome in a patient with PBC, and management about the 3 new drugs. So when PBC is suspected with alkaline phosphatase elevation, it's clear cut based on AMA antibody. If it is positive, easily it can be diagnosed. If it is negative, we can take help of other antibodies like ANA, ASMA, or anti-SP100, anti-GP210 antibodies. They are positive, we can diagnose confidently. If it is negative, we can then go to liver biopsy. These 2 antibodies are present overall in 30% of the patient with PBC, but if patient is EMA negative, then 50% of the patients are positive these antibodies, so they are more helpful in the diagnosis in this condition. Now we will come to the where AMA is positive but alkaline phosphatase is normal. That means incidentally detected AMA positivity. We have 3 good studies where almost 70 to 80% of the patients on liver biopsy found to have disease activity. The last study is the largest one, and they have compared those with histologically confirmed PBC versus not confirmed, means those without PBC. And univariate analysis followed by multivariate analysis identified multiple factors, multiple indicators of having PBC in a patient who is having normal alkaline phosphatase in background of AMA positivity. These 2 factors are most strongly predictor of PBC. These are the high serum IgM and higher age. So these can have reasonable sensitivity, specificity, and can be used to predict for plan for liver biopsy. Baseline risk assessment in PBC patient is typically based on bilirubin and alkaline phosphatase. They are not very good predictors. Actually, multiple scoring system has been used, different cutoff for alkaline phosphatase, 1.67 time, 1.5 time, 2 time, or 3 time. But this study, which included more than 1,800 participants, where liver biopsy was done in this patient and fibrosis was assessed, F1 to F4, F1 and 2 given as early stage fibrosis and 3 and 4 as advanced stage fibrosis, using different standard criteria used for the predictor outcome, Toronto and Paris 2 criteria. In both the criteria, you can see those having histological fibrosis of low-grade fibrosis, means F1, F2 fibrosis, their 5-year, 10-year, and 15-year survival was better as compared to responder based on alkaline phosphatase of bilirubin level. So this was true for both the criteria, and difference was significant if you see the based on the hazard ratio. And the standard non-invasive measures of liver fibrosis like APRI index, FIB4, all these were not good performance. Their area under the curve was 0.5 to 0.6. Based on this thing, we can say that liver fibrosis should be included, assessment should be included in baseline assessment for the outcome analysis of the patients. This patient's small cohort of a patient where the MR elastography, transient elastography was done along with the liver biopsy, and have shown that transient elastography more than 10.2 and on MR elastography more than 4.6, 4.3, they are predictor of decompensation. So we can say that liver stiffness shall be assessed at baseline, and transient elastography or MR elastography may be used, and they are more reliable indicator of liver fibrosis in patient with PBC than the standard serum marker. T cutoff of more than 10 kilopascal and MR elastography 4.3 kilopascal are acceptable cutoff to identify advanced liver disease. If we come to the prediction after 1 year of UDCA therapy, multiple scores have been used as we discussed. These are the 2 most recently introduced scores based on large database, multicentric studies, large sample size, and they have included the variable after 1 year of UDCA therapy. These are the age, bilirubin, albumin, alkaline phosphatase, and platelet for global PBC score, and UK PBC score included albumin, platelet, bilirubin, transaminase, etc. I have included data only from the global PBC score, not for the other for the sake of time. And in global PBC score, you can see it has good discriminative ability between the 5 risk group. So it has categorized the population in 5 risk group where the score was less than 10th percentile, 10 to 40th percentile, 40th to 60th, and 60 to 90, and more than 90th percentile. And we can see that this score is very well in differentiating the different risk group. And another important feature which is shown here is that this score has good agreement between derivation cohort and validation cohort. So global PBC score or UK PBC score, its performance is better than the other standard scores and shall be used to predict the outcome. Now coming to the second line drugs, UDCA, which is the first line drug used in dose of 13 to 15 milligram per kg, almost 30 to 40% patient failed to respond with these drugs, and we have 3 most commonly talked about drugs on second line drug. These are the obeticholic acid, fibrate, and sel-delpa. Obeticholic acid is a FXR receptor agonist which acts through cholinergic, anti-inflammatory, and antifibrotic effect. It's the natural ligand is chenodeoxycholic acid, and obeticholic acid 100 times more potent than its natural ligand for the FXR receptor. This entire data of obeticholic is generated from POISE trial cohort, which had 1 year of double-blind trial followed by 5 years of open-label extension period. The first paper of this POISE cohort came in NEGM 2016, where the inclusion criteria of patients were those who have not responded to 1 year of UDCA therapy, and the primary endpoint was alkaline phosphatase less than 1.67 times of upper limit of normal, with absolute reduction of at least 50% of alkaline phosphatase, along with bilirubin normalization at 12 months of therapy. This is the well-known data that the obeticholic acid was found to be effective in 45 to 47% of the patient in 2 different doses groups, but the problem was significant pruritus in drug group. This is the new data, same study, 3-year follow-up data published in Lancet Gastroenterology, when 193 patients from the original 217 cohort entered in this open phase trial, and they were given obeticholic acid of 5 milligram or more. And we can see here that in follow-up up to 48 months, almost 60% of the patient responded, means they achieved the primary endpoint with obeticholic acid. There was normalization of alkaline phosphatase, which was maintained on continuation of drug. There was normalization of bilirubin level and gamma GT and ALT. And all these effects were maintained. This is the data of 5-year follow-up, which is available in form of abstract only, it's not published as full text. In 5-year follow-up plus 1 year randomized blind study means 6 years of follow-up data, and we can see the effect was maintained up to 5 years after in open label phase. Another paper from the same cohort where the 17 patient underwent paired biopsy, and the biopsy were evaluated by 2 pathologists in a blinded randomized fashion. Fibrosis assessment was done with very good technique of 2-photon excitation microscopy. And we can see that almost 2/3 of the patient have either fibrosis stage has regressed or stabilized, at least it was not worsened. Similarly, for the bile duct loss, it was either stabilized or improved. So it was not worsened in 2/3 or 75% of the patients. But the sample size is very small. This is the caveat of the study. Now coming to the second drug, fibrate. This is an agonist for PPAR receptor, and we know there are 3 types of alpha, delta, and gamma. It regulates bile acid synthesis, detoxification, phospholipid secretion, and inflammatory pathways. It is one of the most commonly used drug for bench fibrate. Among all the fibrates, the most commonly used for PBC. This placebo-controlled trial of 24-month duration, double-blind study, where the 50 patients were given benfibrate 400 milligram once in a day as compared to placebo drug, and the primary outcome was complete biological response. This is complete biological response, which was different from the POISE trial. It is defined as normal bilirubin, alkaline phosphatase, ALT, albumin, and prothrombin time index. Here we can see that by the end of 24 months of the follow-up, almost 1/3 of the participants have achieved the primary outcome, which is a good number. This is another large study, double-blind placebo-controlled trial, which has shown similar result. This is the last and the most newest drug, seladelpar, which has which is included, which has been done recent trial. Patients were randomized in 3 groups, 1:1 ratio, 5 milligram, 10 milligram, and placebo group. Primary endpoint was same as it was in POISE trial. And here we can see in 3 months, 10 milligram of seladelpar, 78% of the patient could achieve the primary outcome. And almost 27% of the patient achieved normalization of alkaline phosphatase in 3 months time, which is very short period of time, we can say. Pruritus was also significantly improved in large proportion. So in summary, anti-SP100 and anti-GP210 may be used for the diagnosis in AMA positive, AMA negative people for the diagnosis. In AMA positive, people with normal alkaline phosphatase may have significant disease activity on liver biopsy, which is a difficult thing to do in all the patients. And here serum IgM level and age may help to identify and choose where to do liver biopsy. Liver fibrosis is an important predictor and determinant of the outcome, and it should be included in baseline assessment. Serum marker does not work well in PBC group of the patient, so we should rely on transient elastography or MR elastography. After 1 year response, we should assess with the Globe PBC score or UK PBC score to predict the outcome. Obeticholic acid effectiveness is maintained on long term, and it improves histology as well, whatever limited data we have. So it seems to be at least safe. Pruritus is definitely a side effect. Fibrate could be an alternative to obeticholic acid, and seladelpar is the most likely future drug for the PBC. Thank you.
Thank you, Dr. Amit. Please join us here. The session is open for any questions from the audience.
Can I ask a question? Ashish, this is Dr. Poddar. Often we encounter patients who are already in cirrhotic state and not much of activity. Autoimmune hepatitis has gone into burned out phase. So will you recommend immunosuppressive immune modulator therapy in subset of patients, or straight away send for transplant? And my second question is to Dr. Sarshad sir. In real world, we face cytopenia more often due to hypersplenism rather than AJA-induced toxicity. So we face very difficult situation. How to go about it? Doing splenic artery embolization, or how to tackle this cytopenia?
So I'll go at the first question. The cirrhosis patient, I'm assuming, has decompensated and has developed ascites to merit transplant. This person is anyhow not a very ideal candidate for immunosuppression, especially if there is no activity. So I wouldn't, if the person is suitable for transplant and is an option, then I don't think a prolonged immunosuppression is warranted in that group of patients.
Ujjwal, I think the problem you mentioned is about cytopenias. While the polymorphisms that I referred to are important and one would look for, the kind of situation you are talking about, thrombocytopenia due to big spleens, often is a situation in established cirrhosis. And most of these second line therapies one has to resort to maybe in the non-cirrhotic population who are not showing either treatment failure or incomplete response and are not actually cirrhotic individuals. In the non-cirrhotic cytopenias, that is thrombocytopenia would be uncommon. Mainly we worry about leukopenias as a result of toxicity due to azathioprine. Even in people who do not have mutations, doses adjustments and dose modifications will may be needed. And in fact, when TPMT mutations are not present and you find unexpected cytopenias, one has to think about NUDT15 and other polymorphisms that would need to be looked at. And regardless, when cytopenias appear, one has to reduce the doses of azathioprine being used down to the minimum about 50, say, or
maybe even 75 milligrams. That would be the approach that I would suggest. Thank you.
Dr. Goyle, for you on PBC. Dr. Goyle, I'll ask you a question. Yeah. So for patients who are AMA positive, alkaline phosphatase is normal, IgM is normal, and they have no fibrosis on transient elastography, would you proceed with liver biopsy?
Yeah, this is actually important question. Even the study where they have done liver biopsy, 117 patients, the largest one in the hepatology, the IgM level was within normal limit. It was not elevated more than the normal limit, but it was toward the higher side, means more than the 50% toward other half of the median, you can say. So you have to take a call, and probably we can take help of the factors identified in the univariate analysis like age, high GGT, high ALT, high AST, or other autoimmune conditions. So we can take help of those factors to decide for the liver biopsy, just not based on IgM. Thank you for asking this question and making the things clear for the audience. Yeah.
No, thank you. And then you would start you would start URSO, and then what do you monitor for response to treatment?
Yeah, for responsive therapy with URSO, definitely we have to use same thing, alkaline phosphatase normalization and bilirubin normalization for URSO response. But we must include assessment of liver fibrosis in the baseline data.
Right.
That is important.
Right. That's why
Assessment has to be done with the same criteria.
Yeah.
Like Toronto criteria, Paris criteria. Right. But we have to use liver fibrosis assessment at the baseline because the guideline is not saying so. So this is the new thing which is coming up. And for the fibrosis assessment, we have not to rely on serological markers. We have to rely either on transient elastography, MR elastography, or biopsy.
Right. Okay. Podium one.
Yeah. Dr. Dhiman, this side from Lucknow. My question is Professor Saraswat. You have told us the utility of the TPMT. That is very well accepted that undue myelosuppression you can avoid if you are doing those polymorphism. But if the drugs level, for example, what is the value of the 6-TGN, thioguanine and nucleotide level, actually? So ideally that should be done. If it is low, then you have to increase the dose. And there is also the role of the 6-MMP, that is another metabolite of the azathioprine also. So what is your comment actually, since the levels of these two, I think it was available in in the south in some lab, but it is not widely available. But what is your comment on this, doing the 6-TGN and the 6-MMP level and deciding the dose of the azathioprine alone, increasing or along with the allopurinol?
I think that's a good point that you have made. The metabolism of 6-mercaptopurine is to 6-thioguanine and then the mono, di and triphosphates, their nucleotides. So, and the active agent that is actually exerting their effect on the T cells and B cells are the 6-thioguanine nucleotides. So, measuring 6 TGNs would be helpful in deciding about whether the person is compliant with therapy, maybe missing out doses or not, or whether it may be metabolizing in such a way that there is need for higher doses if the metabolite levels are low. If the metabolite levels are high, then it probably means that there is a non-response and one may have to move to either 6-MP or mycophenolate or other second-line CNIs like tacrolimus for achieving response in these people. 6-MMP is a very interesting molecule. 6-MMP is has been implicated, its levels have been implicated in the hepatotoxicity related to azathioprine and mercaptopurine, and if their levels are high, it doesn't correlate as well as thioguanine nucleotides in causing hepatotoxicity, but those who have higher 6-MMP levels are more likely to exhibit hepatotoxicity. So if these are available, then it can allow you to tailor your therapies, modify the doses, or move to second-line therapies like mycophenolate or CNIs. So I guess that could be the utility. Does that answer your question?
When you have incomplete response, do you use a add-on approach or a substitution approach?
Sorry, could you just repeat that?
For incomplete response. So say a patient is partially responding to azathioprine, do you substitute or add on?
Yes. Well, I guess it'll have to be seen individualized. It's very difficult to just give one flat recommendation. If there is an incomplete response, that is where the 6-TG nucleotides would help. If 6-TG nucleotides are low, that might mean that he's being underdosed or he's being non-compliant with therapy, and you would step up the basic dose of azathioprine or 6-MP, whatever you're using. Similarly, intolerance to azathioprine is greater than it is for 6-MP or 6-TG, which can be used as therapeutic molecules in the situation of intolerance and there's a resistance. So you could try those, and if the person is still intolerant to 6-MP, 6-TG, then I guess moving to mycophenolate or CNIs would be the thing to do.
Any other question from the audience? Yes, please.
Same as Dr. Ujjwal Podar had mentioned, most of the cases when we see in the real life situation, we work up a patient of cirrhosis of liver who came with certain complications, and we'll end up diagnosing autoimmune hepatitis, autoimmune liver disease, and we don't have anything to offer because it's already burnt out case. So that merely only becomes a mere academic exercise. So we don't have anything to offer, even if we diagnose autoimmune etiology. Do you have anything to offer to those people who come with, say, suppose ascites, and we work up and we find out autoimmune etiology, enzymes remains normal?
Yes, so one is the enzymes are always not indicative of activity in the liver biopsy. If the person is not very far gone, and as I said, more the decompensation, less the chances of acting of this immunosuppression. But if the MELD score is not that far, if it is around 14, 15, if the biopsy shows activity, we are well within our rights to start immunosuppression, maybe a bit more cautiously, and maybe a bit for lower dose to start with. But I would be well within our rights to start immunosuppression there. Some of these patients will do well.
In this situation, what do you take as guide to start? I mean, all the guidelines that say that enzymes has to be 5 times or 10 times the upper limit of normal, then you start steroid. Yeah. But in these situations, enzymes remain normal.
Yeah. So the question will be, what exactly do we follow up as a marker for response to therapy? In a patient who has raised SGPT, we can follow up SGPT and see response. If the patient has high immunoglobulins, we can use high immunoglobulins as a response to therapy. Immunoglobulins will come down. If nothing, then it will be a difficult clinical call. Most likely, if one of these two things will be high, and if the biopsy is showing inflammation.
Last question,
Just,
Dr.
just to supplement what the question that Dr. Chetri had asked, I think by and large there is a very high threshold for starting immunosuppression once the patient has entered decompensation. Once there is decompensation, then you are more likely to run into complications of steroid therapy in the form of infections, etc., rather than confer much benefit on the patients. And whenever we have started, and on several occasions, I've had to withdraw immunosuppressive therapy once you precipitate complications of immunosuppression. So I guess eventually conservative management, or till the patient meets criteria for organ replacement, then you head for liver transplant.
Yeah, the similar experience I have. If there is no transaminitis, patient has already having the decompensated cirrhosis, there is no point. We have burnt our fingers so many times, not only with the high dose steroid, even with the very low dose of steroid, and if we continue, they go into sepsis and we lose them.
So I think we close the session. I thank all the speakers and my co-chair and the audience for a very interactive session. Thank you very much.
So we are good to go with the session 7, acute on chronic liver failure. The chairperson for the same are Dr. Paolo Angeli, University of Padova, Italy. Dr. Ajay Kumar, BLK Max Super Speciality Hospital, New Delhi, Dr. Dharmesh Kapoor, Yashoda Hospital, Hyderabad, Dr. Ashok Chaudhary, Institute of Liver and Biliary Sciences, New Delhi, Dr. Shravan Bora, Apollo Hospital, Ahmedabad, Dr. P. Shravan Kumar, Gandhi Medical College and Hospital, Hyderabad. So this one is for all the speakers. Once we are done with our speeches, it's a humble request, since we have more speaker and chairperson for this session, we request all the speakers to join us in the front row for their discussions later.
Good afternoon, everyone. There is a minor change in the sequence of talks because of the technical reasons to catch flight and all. Interesting session on acute and chronic liver failure. The first talk will be by Professor Rajiv Jalan, who needs no introduction to this Indian audience. In fact, he doesn't need any introduction to the international audience as well. The talk will be on new strategies for using GCSF and regenerative therapies in acute and chronic liver failure. Over to Rajiv.
Well, thank you again for this very kind introduction, and thank you, INASL, for allowing me to discuss some of these new ideas. There's my disclosures, which I've disclosed here before. So look, a part of this whole thinking about liver regeneration, really in simplistic form, stays around two elements. One is growth and tissue replacement, but it's also extremely important to think about functional recovery, because just the presence of hepatocytes does not mean the liver will function. So therefore, there are these two elements that we need to consider in whenever we are talking about regeneration. And I think the functional recovery is talked about less than I suspect it should be. Most of you know this. This is from really a textbook to suggest that there is regeneration that happens in the uninjured liver from the Wnt responsive stem cell population and the renewal of hepatocytes. And there are niches for adult hepatic progenitor cells, particularly in the canal of Herring and around the central vein. And they're probably more important in the context of an injured liver. It is also, these are data from here in India, and there's some other data which suggests really very nicely that there is evidence that chronic liver injury, there is sensitization of secondary injury, and there is a loss of regenerative potential, particularly in ACLF, which is much more marked than in patients with acute liver failure. So these are not the same syndrome. And I think this is really important to understand, because this will become relevant to what I will tell you later. The presence of ductular reaction is an evidence of non-hepatocyte regeneration, and probably indicates some of the mechanisms around lack of hepatocyte regeneration and hepatocyte proliferation. I think this is a really important paper from Bengao's group in NIH, who showed very nicely that if you take patients with acute liver injury or ACLF, the severity of inflammation is inversely related to regenerative potential in liver biopsies. And it's really nice. You can see here BCNA staining is Ki67. In the ACLF population, there's a markedly reduced evidence of ongoing regeneration. So there's good evidence that in ACLF, the severity of inflammation that you can detect is associated inversely with regeneration, and this is an important concept. And they went on to reproduce these data in an animal model where they took a carbon tetrachloride treated cirrhotic animal and gave it an infection with Klebsiella. So it's a pathogen-driven inflammation. And what they showed very nicely is actually depicted here on the right-hand side, where they showed that there is evidence of inflammation, particularly in those that are associated with a bacterial infection. But they went on to show, I think really nicely, that there is a STAT3 liver STAT mRNA upregulation. And what was really interesting is that they show an upregulation of P21, and they didn't really focus on this story. P21 is a marker of liver senescence. So induction of pathogen-associated injury in the context of a fibrotic liver is associated with reduced hepatocyte proliferation, as you can see from the BRDU cells, and also with evidence of very marked senescence, which is what P21 represents. And senescence is an important concept, particularly in the context of chronic liver injury, chronic liver disease, because the occurrence of senescence is associated with a cell cycle arrest. And the processes that lead to the cell cycle arrest through hepatocyte senescence could be through several molecular mechanisms, and the most powerful regulator of that is TGF-beta, which we know is a cytokine which is increased in the context of cirrhosis, both in the liver and in the circulation. And this is really just a summary of what I think we've been discussing for the last 2 or 3 days. That as a patient moves from compensated cirrhosis to acute decompensation cirrhosis to acute and chronic liver failure, there is a change in the kind of mechanisms that are involved in the development of the end organ failures. And this really relates to predominantly metabolic alteration and systemic inflammation, particularly in the context of most severely acutely decompensated and acute and chronic liver failure patients compared with the patients with compensated and early forms of organ dysfunction, kidney dysfunction, etc., where there seems to be more circulatory dysfunction that's driving the syndrome. So at this end here, and of course, there are cellular metabolic alterations which drives the story, and we're going to talk a little bit about regeneration in this particular population. Just sort of that as the backdrop, I think the important concept and I think this is a hugely important paper for many, many reasons that all of you know, because I think this really started an unbelievable amount of interest in the field, because it showed for the first time that GCSF may be able to reverse the disease, although as you will see, it was not proven out in the future, but it was a great proof of concept that the numbers here were small, but they showed a tremendous improvement with GCSF compared with placebo in the context of survival of patients with ACLF. As you can see, placebo mortality was nearly 30% compared with GCSF, where the survival was nearly 80%. So this really set the cat amongst the pigeons, and what they were also able to show was that GCSF mobilizes CD34 cells, and it can get inside the liver. So it was a very exciting time, 2012, and all of us really took this on with aplomb. But of course, over the course of the next 5, 7, 10 years, there has been a sort of a mixed bag of results that have emanated from the trials that were done using GCSF. And I'm not going to spend a lot of time except to say that the results are mixed. There were small numbers of patients, as you can see here, studied in these various studies. Most of them are single center studies with varying inclusion-exclusion criteria, not really allowing you to make any particular conclusion. And I think this study from Thomas Berg, who's here together with Cornelius Engelmann, I think is an absolutely classical study, because it's the first study done using CLIF criteria to correctly segment patients, stratify patients. And they studied a large number of patients in a randomized controlled fashion, where they treated patients either with GCSF plus standard of care versus standard of care, as you can see. And they followed the patients up for 360 days with a primary endpoint at 90 days. So this is probably the best study that has been done in the field, the graft study. And it was really interesting to see that there's absolutely nothing that GCSF does in this context in terms of survival at 90 days in this patient population. As you can see, that there are, there's not even a signal. Based upon the data that was presented from Asia, from here in India and other places. They went on to do quite a extensive post-hoc sensitivity analysis. And again, as you can see, even if they included the ACLF apasal criteria, there's really no signal for GCSF compared with controls. But what they also saw, and I think this is also really important to think about, that is, if you think about the complications, what they went on to show was 7 episodes of severe adverse reactions to the drug, and they had fatal outcome related to serious adverse reaction in 3 patients. And Cornelius, who was working with Thomas Berg at the time, came to our lab at the time, and we started to investigate the story of what happened with GCSF, and how does it work, and so on. And these are the first results that he got. He had come on a fellowship, and we thought that the fellowship would end with nowhere to go. So he studied these animals with ACLF, with CCL4 plus LPS. They were given GCSF, and the results were pretty astonishing. As you can see here, 48 hours after LPS injection, nearly 60% of the animals given GCSF had died. And this was associated with very marked inflammatory response as macrophage infiltration and F480 cell infiltration in the liver. So what GCSF was doing was producing severe hepatic inflammation and the death of these animals. So we decided, what the hell to do now, because we have nowhere to go. There's a fellowship which has been given to study this. And we found this paper, which was published before, which suggested that if you're using LPS, GCSF in a septic LPS model, then you kill these animals, as you can see here, and that's associated with liver inflammation. And what they also showed was that there is a marked upregulation of TLR4 in the liver, which is driven by LPS if you give them GCSF. So we went back to our program, and what we did was we had an interest in TLR4 already, and we looked at some of the data. And here's some of the data that we have. What we found was that in patients with ACLF, there's very much marked increase in PAMPs, the increase in DAMPs, and also these, when you incubate with a TLR4 cell line, there's a large signal. We also went on to show that in the hepatocytes, in patients with ACLF, either due to Hep B or to alcoholic hepatitis, there's very marked upregulation of TLR4. We did the study in animal models to reproduce this. That is, we did TLR4 inhibition. As you can see, if you give LPS to a bile duct ligated animal, all of them die. If you treat them with TLR4 antagonists before, all of them are alive. And if you treat them after they develop ACLF, 50% of these animals are alive. And this is associated with reduced liver cell death. So we thought that's really interesting. So the question really was whether inhibition of TLR4 by TAC242, which is a TLR4 antagonist, would improve GCSF-driven excess mortality and injury based upon these previous findings. And therefore, we took it to these animal models, and I'll show you some of the data. As we had shown before, if you had a CCL4 LPS animal, if you gave it GCSF, a lot of them died. But if you gave them with TAC242 or TLR4 antagonists before, you could save them. This just shows that TLR4 antagonists treated GCSF animals had very low liver injury, and with here showing reduced cell death and reduced ALT. This suggested to us that we can use GCSF if you inhibit a TLR4, use a TLR4 antagonist. And then we went on to look at the mechanisms. And what's interesting to note is that in the GCSF-treated animals, as we had shown before, there's infiltration of liver cells, inflammatory cells in the liver, and higher IL-6 in the GCSF-treated animals, which is completely prevented if you treat them with a TLR4 antagonist before. Finally, what was really interesting was that if you now looked at the same setup where this is an animal treated with GCSF alone, here's the combo, either TLR4 antagonist or the combo. What you do is reduce liver cell death inhibited senescence, reduces inflammation, and what was really interesting is that in the TLR4 antagonist alone, you don't improve regeneration here using two markers, which is cyclin A2 and Ki67. But if you use the combo, in addition to reducing inflammation, you improve regeneration. And this was really the basis of this cartoon here, where what we show is, if you look at this right component here, here is what's happening in ACLF, the marked inflammation and cell death, low tissue repair. You use GCSF alone, you drive more inflammation and cell death. If you use TLR4 alone, you can improve tissue repair as we have shown, but if you use the combo, you probably get a lot more benefit of doing the two. And this is really translated, this whole series of work that Cornelius did on the background of the work that he had done in graft, into this study, which is due to start very soon. It is a randomized controlled clinical trial of the GCSF plus TAC242 alone, standard of care, and we're going to include 78 patients. Primary safety is the primary endpoint, looking at the CLIF-C scores. We're going to include ACLF grades 1 to 3 on the background of steroid-unresponsive alcoholic hepatitis. We're grateful to ATANGO, which is a European Union, which is funding the study. And just to conclude, therefore, Mr. Chairman, inflammation, we think, is linked to a lack of regeneration are typical features of ACLF. Creating an anti-inflammatory environment, particularly in the liver, is the key to facilitate hepatocyte regeneration as it impacts upon senescence, which we think is an inhibitor here of regeneration. GCSF, we think, aggravates inflammation and tissue injury, but exerts its regenerative capacities if protected by TLR4 inhibition. And I just want to thank the EU particularly for this grant in order to start this trial. So thank you very much for your attention. I'm happy. I can take some questions if you want me to.
So Rajiv, do you think this is ready for prime time? Because you presented the graph study much before the work from ILBS. There was the Swiss study, which was the first one to show that there is infiltration of CD34 into the liver when you use GCSF. And then, of course, there was the realistic trial, which not only gave the GCSF, but they also then derived the CD133, which are the progenitor cells, and they actually again went on to show that there was increased complication rate, because the problem is going to be the same, an anti-inflammatory arm, which is what the TL4 antagonist is going to do. So you do not know where in the timeline of an ACLF, whether you are at the beginning of the pro-inflammatory state, or you are further on in the course of the illness, whether you should be safely using a TL4 antagonist. My other thoughts are, of course, I have not gone into the depths of this particular trial, that we use the agonists of TLR for treating things like hepatitis B. At least that is something which is in the pipeline, So probably ACLF due to hepatitis B might become difficult to use, because you are using an anti-inflammatory agent in a situation where you want heightened inflammation to throw the virus out. So those are the thoughts that come to the mind. So I think this is a space one would want to watch. Your comments.
So look, I think, for us, we have nothing at the moment. This is a safety study. So we've got a DSMB that's going to be monitoring the data very closely. We've got ethics to do 2 biopsies in these patients. We're going to be studying a lot of biomarkers, and hopefully I can tell you the story in 2 years as to what we find.
Quick question by Dr. Virendra Singh, and then we will go on to the next talk.
Yeah. See, this is regarding the GCSF therapy. In our 2 studies in which we used the GCSF in patients with the alcoholic hepatitis, these were open level studies, small studies. It had shown a promise. But the last study, in which there are somewhere around 65 patients, and this is again an open level study, this is a negative study. So I agree the effect is not consistent. Another question is that can we use the anti-inflammatory, the corticosteroid in a low dose, and then combine it with the GCSF therapy?
Look, I think, these are very dangerous things to do, I think. So the patient population that we're going into are corticosteroid unresponsive, or they have contraindications to use of corticosteroids. And that's the population that we'll include in this program of work.
You are using corticosteroid, but we don't use it because the infection.
Yeah, of
Our
course.
experience is otherwise.
Absolutely. So
Whenever we use corticosteroid, they're always.
Yeah, so in ACLF, 1 to 3 patients, we do not use steroids. So either they have contraindications to steroids or they're steroid unresponsive.
Okay, thank you.
Thank you.
Thank you, Professor Jalan. So we'll invite Professor Jasmine Bajaj for the next talk. I think he needs no introduction on this. He is a pioneer in the field of SCLF, infection, hepatic encephalopathy. And we'll go into the next session. The floor is yours, Professor.
Thank you. Thank you, INASL, again, and thank you to the chairpersons. So I've taken a little bit of liberty with my topic. You said futility, mortality. I added the word futility because, everyone will die. And if you look at the ACLF definition, no spoiler alert, most of them end up being people who already have at least 1 or 2 feet in the grave already. So why do we need to predict mortality/futility? We need to have an accurate prognostication. We need to identify patients who need extra monitoring or have preventable reasons for mortality. We have to importantly determine futility rules and consider liver transplant priorities. So I'm not going to waste too much time, except these definitions don't talk to each other. Humans are the same. These definitions are not. People react similarly across, regardless of the etiology. And if you look at the organ failure categories, majority of them are either too early or too late, which does not individualize this for one particular patient. And the hallmark of most ACLF diagnoses are that if the patient survived 3 months without dying, that patient had ACLF. That doesn't make any sense for one person that you want to actually figure out what's happening. It's like the old HRS definition. If the patient survived, they did not have HRS, but that does not help that individual patient. And what all are the other definitions, problems with the current definitions? There's discordance, there's not prognostic, but diagnostic, and need to be proactive. And if you look at the overlaps, there's a huge overlap between acute decompensation, acute liver failure, and more importantly, there's a very bad lack of sensitivity. So if you take any patient with critical care illness and put them with cirrhosis plus critical care illness, there is very little daylight between them. So we need a biomarker that has all these things, none of which currently exist. So what do we do? What is known and what's unknown is very difficult. What is ACLF? Prognostically, that actually is a universal marker, is largely unknown to my fact. But what is known is death. When someone is dead, they are dead. You really need to walk backwards from there and see what brought them there and try and prevent that for that one specific situation. To add to the woes, as done by several elegant studies, ACLF is not a static condition. Someone may have ACLF1 today, may have ACLF2 tomorrow, ACLF3 the next day, and we'll go back to ACLF1. How are you going to actually prognosticate that person? Same with this study. Therefore, we need to figure out what is truly a futile situation. That is helpful because that will tell us either this person needs a liver transplant because they're really not going to survive, or we have to start talking about end of life right now so that the patient may die with dignity either at home or in the hospital without us doing unnecessary things. So in this nice study done by the CLIF Consortium, AC more than 64 was considered futile in the absence of liver transplantation, regardless of day 1, day 3, day 7. Now that is very important information, as opposed to one specific thing, and then you're done with ACLF, yes or no. What about NACSLD? What we found is actually if people had more than 2 organ failures, NACSLD, very few people actually have NACSLD-related ACLF, but the ones who do are mostly in the settings of either you receive a liver transplant or you are futile in that situation. Same with APASL and ARC definition. They're very good to actually figure out who is going to do very, very poorly with score more than 11. But we need to go beyond organ failures if we have to truly prognosticate people, because organ failures are very crude regardless of what combinations you actually put together. There could be biomarkers, and more importantly, many centers around the world do not have access to the things that are required to make a diagnosis of organ failure and or ACLF. So this study done by us and also confirmed by the Chinese groups found that the microbiota on admission could actually predict who will develop organ failures in ACLF. Same thing here. The ones in the red died, the ones in the blue survived. But you can't go around collecting stool microbiota in everyone. So you really need to figure out other things. This is done in a multi-center study. Again, stool microbiota could predict on admission who is going to live or who's going to die, who's going to go to the ICU, and who's going to develop ACLF. The other thing you can do is very easy, is the neutrophil lymphocyte ratio. In this 4 academic centers in the US with 864 patients, the admission NLR ratio could predict who died, and this included the ACLF, MELD, and cirrhosis stage. Now, this is done very easily in all your CBCs, and this has been done multiple times in other conditions such as alcohol-related hepatitis as well. What about what the microbiota are actually doing? The microbial origin metabolites can differentiate between who will develop ACLF or not, and this has been done multiple times. The first study is the INASL on the right side, on the left side, and the right side is the Konark, and this has been done in the Chinese groups as well. Clearly, there are some metabolites that are circulating that add to the current definition of ACLF, which will tell you who is going to live or die. Not only who is going to live or die and who has several grades of ACLF here and now. But none of these are currently available for prime time. But what I'm trying to get to it is we need to look beyond organ failures because they're relatively crude. And as I'm going to talk about a little bit later, that may not be applicable for the most of the world. This is one of the examples of where you took a microbiota or other metabolites to predict who will develop advanced hepatic encephalopathy. Now, why do you need to know if someone has grade 3 and 4 encephalopathy if they're not confused right now? What difference does it make? The important thing is beyond prognostication, if you're talking about end of life, you need a patient to be alert and oriented and make their own decisions and not have the relative hijacks that decision for them. So if you know who is actually going to develop confusion or coma, right now is the time to actually either intervene and do other things. So what we found in 602 inpatients, in addition to the multiple microbial metabolites that are not really translatable into clinical practice, an intriguing thought was low thyroxine. Total thyroxine was much lower in these patients. So we went back, we collected another group of patients, and we sent the thyroxine to the local labs. And we found the same thing. A low thyroxine on admission could predict who, independent of everything else, who is going to develop grade 3 and 4 hepatic encephalopathy. So this is the way you actually end up translating these huge, complicated microbial and other metabolites into something that you can translate into clinical practice and validate it further. But there are many barriers. If you look at the bottom, these are all the barriers that you have. This is not just specific for ACLF. If you look at the societal levels, community level, interpersonal level, and individual levels, there are many barriers to people receiving adequate care. These lead to disparities, not only into the awareness of the disease, as we know now with NAFLD, as well as access to care, there's also multiple barriers into how the treatment is accepted and how people can actually even afford this treatment. So to actually design all of that, we went back to the basics. In a worldwide consortium, could you predict who dies and who lives if they are hospitalized? And many of you in the audience, and including my co-PI, Dr. Chaudhary here, have participated enthusiastically into this consortium. And I thank you for it because this has really added multiple levels of this. So the death was not only predicted by the liver disease, but lack of access to resources, especially in low to middle income countries. Now that seems obvious, right? But if you look at the definitions of ACLF, they're either from here, or from here, or from here. In tertiary level centers that really have all access or have patients who can afford all of those things. So access to liver transplant and intensive care and inability to afford medications and outpatient care was predictive of outcomes independent of inpatient events that are traditionally used for ACLF. And I'm going to give you one example. It's an oral presentation at ASLD about infections across the world in this consortium. And we found that the culture positivity in the African sites was very, very low. And we went back to the sites and said, what happened? They don't have access to culture bottles. That's why it's 0. So if you do not know these things, you would not come to figure out that these are some things that are true barriers that exist even in 2023 in our patients with hospitalized with cirrhosis. This is critical before we live in our ivory towers and make these definitions, that this may actually not be applicable or even affordable to the most developed to the most poor people in the developed countries and the most people in the developing countries as well. And this is something which is very important. If you look on the left side, the blue is the group that is in the countries which are advanced, which is you can see that, sorry, this is the low middle income countries. The death was lower and the higher when the liver transplant was lower, and these were completely predictive in the inpatient mortality and the transplant in the multivariable analysis. So we need to take a step back and figure things out and find out futility, liver transplant, ACLF, and in patients with cirrhosis using a holistic thing rather than being a prisoner of definitions that we have created. So liver transplant candidacy and severity depends on many things. You have to figure out whether someone is actually a candidate, actually see if you can make them a candidate, and if not, they go to hospice if the liver disease is very high. If the candidacy is there, you observe, and if the liver disease is not spared, then you can actually do this. But they are candidates and they are severe disease, then they get a liver transplant. What again is not mentioned here, as I spoke in the example before, is someone can have access to liver transplant or can afford the liver transplant if there is access. So that's really a problem in many of the countries in the world. So what are the arguments? This was a whole debate yesterday, but I want to actually relitigate this. There are arguments for prioritizing selected ACLF patients because MELD may not capture the disease severity, and there's acceptable survivors, and then we need to figure out in which care is futile or not. Clearly, there are some places in some scores that you can use. I'm not going to go over the details, including the retrospective, nicely done score. It's called the SALT score in the US. But there are arguments against prioritizing, because many of this evidence was based by retrospective studies in the UNOS database that does not have the criteria that you need. And more importantly, it is a zero-sum game. We have a fixed, in Western countries, we rely on deceased donors. So the deceased donors have a fixed pool. So if you give more to ACLF patients, you take away from someone who doesn't. In living donor, it becomes even more challenging because if the outcomes for living donors, these two studies are from India, is not optimal, not only you have a patient who's dead after transplant, you have a relative who has a big scar or someone else who has a big scar and potentially a complication. So you have to be very careful before offering transplant to patients with ACLF as a blanket version, including in living donor transplant. So ultimately, we now need to figure out who is in which the care is futile and not. So this is the definition of medical futility. Is a professional judgment that takes precedence over patient and autonomy and permits physicians to withhold or withdraw care deemed to be inappropriate without subjecting such a decision to patient approval. This is a very strong statement, which means even if the patient and the family said, yes, do everything you can, if the doctors and the medical team thinks it's absolutely not going to help, these patients can be withdrawn. But what is the context? Futility is very goal specific. It could be physiological, quantitative, and qualitative. So this is really important. So we have to figure out patient and family approval is important. Transplant candidacy is very key in this situation, and qualitative is not really that important. So we are talking about physiological and quantitative futility in these patients. And who will make that decision? Ideal case, medical teams, family members, and patients' current or prior wishes all converge into considering future care futile in this person. A likely case, the patient has not been able to tell in advance, has no advance directives, and relatives are currently in shock. They have no idea what to do because, as you know, many patients with liver disease are coasting along and suddenly they fall off a cliff. And within 2 to 3 days, you have to make this decision. Medical teams are also conflicted about transplant suitability and or offering end-of-life care between this cell. And other questions, at what percentage of mortality without transplant would a patient's further care be futile? 90%, 80%, more? Or value added to quality of life, not just the length of life, if the patient does not do well after transplant or their donor suffers too much, what to do with this? So there's a lot of questions that we have to figure together. But there are interesting points to be raised, and there's interesting points where we can all get together and come to this without any predefined notions. So patients with cirrhosis, as we know, have very high rate of death while hospitalized. The tools currently in use to diagnose ACLF often diagnose it when it's too late. Proactive approaches to predict ACLF and death are being validated and focus on metabolomics, inflammation, and microbiome. Death rates vary according to the income and access of the patient and the country they're being treated in. Futility rules and liver transplant eligibility modulate the risk of death, but these vary according to centers. And thank you so much for your time. And actually, I'm also have to leave, so if you have questions, now is the time to just...
Thank you. Now we open for questions. We can take maximum 2 questions from the house.
So, just what do you think is the reason for the decreased thyroxine?
Sorry, reason for the decreased thyroxine? You know, the same reason why resmetirom works. There is actually local hypothyroidism within the liver because thyroid, even though it's produced by here, it's also, there's some local things there as well. It also is a modulator of immune function. And it is something that may have, I'm not saying it's directly related, but it's a chance finding that we have confirmed. And I think a group in AIG has also confirmed that. And prior studies with encephalopathy, there's kind of an overlap between the two. So I think there's something there, but we need to do it a little bit further.
I don't think that this is something new because we know that the FT4 gets converted to FT3 in the liver.
Yes.
And it's got nothing to do with encephalopathy.
No.
So we don't publish, but we've run it in more than 1,000 patients. That patients whose
Please
liver
publish.
is very sick, we don't publish.
Why?
So, just like that. So we know that when you have got a sick liver, so actually the better test to do is an FT4. So you will see an FT4 which is in excess of 3, which is something that you would probably use to diagnose thyrotoxic individual in a normal population. So the FT4 to FT3 conversion does not occur because the liver is sick. So actually the total thyroxine might not change, but this ratio is far more discriminant than the total value. Maybe you can look back at the data.
No, we did. We did T3, T4, free T4, everything when we did the local analysis, and total thyroxine was the main thing in this. And to add to your question, the same 602 patients, we did different endpoints. One was ACLF, the other one was AKI and renal failure, and the third one was hepatic encephalopathy. This only showed up in hepatic encephalopathy. The same things were done for all the other things that there were some overlaps like phosphatidylcholines and lipids, etc. Regardless of what the endpoint was, they were truly liver function based. But there are unique things like for AKI, we had clearly some urea markers, etc. But this was unique for hepatic encephalopathy. So there was something about this total thyroxine level, and I don't know the mechanism right now, but it was unique because the same 602 patients, the prior study that I showed with microbial and rigid metabolites for ACLF and death and liver transplant, thyroxine did not show up in that at all. So there is something unique, at least in this data set with this.
Jazz,
In India,
sorry. I have a question for you, very pragmatic. Waiting for an ideal prognostic biomarkers in patients with acute decompensation, we know that one complication that had a tremendous impact on the outcome is bacterial infection.
Yes.
So my question is, in a patient hospitalized for acute decompensation, do you perform routinely antibiotic prophylaxis, yes or not? And if yes, with what? Norfloxacin, rifaximin, both?
As a general rule, in our centers, we don't do it unless there's a strong suspicion of bacterial infection, but not for prophylaxis. If we give them antibiotics, it'll be for treatment after culture drawing. But we don't because, unfortunately, a lot of our patients are already on some form of rifaximin, etc. already. And I think the current the trial that was read out during INASL, the Liver Hope, unfortunately, kind of crashed that boat a little bit with rifaximin at least.
in India, the problem is that when we know that the patient is not doing very well, our sick liver patients, and we want to extubate them and take them out of ICU, we're not allowed to do that. So, I mean, the bill keeps going up. We know that the patient is going to die, and we are unnecessarily intubating the patient, and we should extubate. The family thinks the bill is going up, financially they can't afford, but we need to change even the rules in the country, because here you can't extubate a patient even if you know that this is futile. I mean, the family does not have any money for liver transplant, and you are basically, you know that the patient is soon going to die. So I think the rules also from the government has to be changed.
So
no, they don't allow us.
So what the chairperson is saying, there's no rules that prohibit you. His mic is not working.
But you see, we are told that you're not
No,
allowed
you are
to
told
extubate.
because the patient, hospital authorities are not ready to take the responsibility for that. And that's the whole problem. And that we also face the same issue, but when you quote the rules, no, there are no rules. In fact, rules are silent on this issue.
So, lest you think things are much better in the US, they are not. That's why we have to make sure that we have this dialogue early and not wait till the patient is pre-terminal to actually have this dialogue, because it's too much to take in. It's too much for people who have, some of them didn't even know this patient had cirrhosis to start with. And now you're forcing them to make a decision that they never thought they would be in position with, which is why I wanted to actually start the dialogue. Let's not focus about mortality as a concept, but actually is who gets a liver transplant and whom care is futile, which is a lot more useful way of looking at it, rather than just focusing on that death, yes, no.
Thank you very much. An excellent, exciting talk.
Yeah. I'm going to invite Professor A.C. Anand. He's a professor of hepatology and editor-in-chief of Journal of Clinical and Experimental Hepatology. He's going to speak on etiology-specific treatment of ACLF. Professor A.C. Anand, this is all yours now.
Thank you very much. It's a great pleasure to be part of this academic feast, and I'm grateful to organizers for giving me this opportunity. I have been asked to speak on etiology-specific treatment of ACLF, and I'll begin by showing you a timeline of pathogenesis of ACLF. This timeline reminds me of a tagline I read in 1970s, early 70s. A movie had come, The Italian Job. And the tagline was, it took 30 years to plan, 30 minutes to execute, and 30 seconds to explode. Now, it is very difficult to conceive that something which has taken years to develop, you can remedy it by giving etiology-specific treatment at the time when it is exploding. But if you want to reverse the process, then possibly we have to go something like this. We have to prevent the death, prevent the development of organ failures, treat and prevent the precipitating events, and try to recompensate if it is a decompensated liver disease. Reversing fibrosis may not come in the treatment of ACLF, so I'll skip that. And even focus area 1 and 2, I think Dr. Jalan has covered very well in the Dr. Divi Datta oration yesterday, so I'll not be talking about that much. Preventing death, liver transplantation selection, and futility, I think my previous speakers have already covered, so I'm not going to talk about it. Similarly, there is a wide consensus about the definition of organ failures and the approach that we should take for treatment of organ failures, and therefore this also I will not be covering. I'll start with the precipitating factors. The precipitating event is possibly the most crucial etiological step in causing ACLF. There has been some controversy about hepatic and extrahepatic acute insults, as there is about basic definition of ACLF. I'll try to avoid that. The Venn diagram on the left and the pie diagram on the right show relative prevalence of acute events as is seen in West and the East. Type 1 is a non-hepatic injury, and type 2 hepatic injuries have been further classified as A, B, and C. Of these, worsening of the same disease is where possibly etiology-specific treatment can work, and I'll be talking about that in a little bit. Severity of acute insult also has an important bearing on the causation of ACLF, and this cartoon depicts the 3 levels of the disease, and the most severe one is ACLF on the top. For a patient with compensated chronic liver disease, the precipitating event would need to be very severe to push it to the level of ACLF. In patients with decompensated cirrhosis, even a minor precipitating event such as respiratory infection can push the patient to ACLF. It is actually the severity of cytokine storm that determines the outcome, and at this level, we need to somehow improve the patient so that the improvement is more common and resolution is more common while worsening is less common. These are the usual precipitating events, and there are standard guidelines for treatment of most of them. For example, GI bleed would be treated with terlipressin, endoscopic variceal ligation, and antibiotics. DILI by stopping the offending drug and, if required in selected cases, plasma exchange. Sepsis by control of source of sepsis, antibiotics, and albumin in case of spontaneous bacterial peritonitis. And I'll be spending a little more time on conditions where aggravation of basic etiology is also the precipitating event. Pie diagram on the left side shows the prevalence of various basic etiologies of cirrhosis, which are seen at my hospital, and I think this is representative of most of the hospitals in India. In etiologies like NAFLD, cryptogenic cirrhosis, cholestatic liver disease, and some genetic causes of cirrhosis, no specific treatment may be effective at the stage of ACLF if it is etiology specific. But I'll focus upon alcohol, hepatitis B and C, autoimmune diseases, Wilson's disease, Budd-Chiari syndrome, where the aggravation of basic etiology leads to ACLF. Hepatitis B is a common cause of ACLF in Asia Pacific and in China. There are papers which say that 80% of ACLF is related to hepatitis B. The triggers for ACLF in these cases can be hepatic as well as extrahepatic. When the hepatic may or may not be related to HBV infection. But it is where it is the HBV flare which is the cause of ACLF, that is where the specific treatment can be of much use. This paper from Dr. Sareen's group has shown that tenofovir improves the outcome in patients with spontaneous reactivation of hepatitis B presenting as acute on chronic liver failure, especially if the DNA level can record a fall of about 2 logs in 2 weeks' time. There are similar reports from elsewhere too. The choice of drug for this treatment would be those which are drugs associated with high efficacy and high barrier to resistance, namely tenofovir and entecavir. Interferons are contraindicated as they can make the flare worse. Hepatocyte transplantation, plasma exchange, ALSs have also shown some benefit in few small Chinese studies, but no definite recommendations can be made about it. There are both APASL as well as EASL recommend liver transplantation when the ACLF worsens. In grade 2 and 3, transplantation definitely improves survival significantly, and Dr. Sareen's group has recommended if there is cirrhosis and bilirubin is more than 10, prothrombin time activity is less than 40%, and platelet is less than 1 lakh per deciliter, one can go in for liver transplantation. HCV-ACLF does not have similar recommendations, possibly because the drugs are slow to act and benefit in terms of improved survival can only be seen after several months, as is seen in case of decompensated cirrhosis. Initial treatment of these patients should be on the lines of ACLF by any other etiology. Let's move on to the alcohol-associated ACLF, which is possibly the commonest cause of ACLF in most of the world and carries poor prognosis. Severe alcoholic hepatitis often overlaps with the diagnosis of ACLF, and the steroids can be tried in suitable cases, though no definite recommendations have been made in this regard. Similar is the situation with other forms of therapy like GCSF, where the world is divided about its use, and there was a lot of discussion some time back also, though some centers in India are regularly using it with reported benefit. In certain centers, plasma exchange or Prometheus albumin dialysis have been tried in small number of patients with very good results, but here again, no uniform recommendations have been made. Plasma exchange, though it is becoming popular in centers where it is available. Here is another report from South India where it reported improved survival, and this has been discussed in more detail by Dr. Ashish Goel in the previous session. There is no consensus on the use of plasma exchange, but if the centrifugal plex is available, a low or standard volume plex can be tried in patients with alcohol-associated ACLF. There have been one tantalizing report from ILBS about the use of FMT in alcohol-associated ACLF, showing significantly improved survival. However, we would like to wait for these results to be replicated elsewhere before we accept this therapy as a routine. Then there is autoimmune hepatitis-associated ACLF. Around 10 to 15% cases of AIH may present with ACLF, and AIH-ACLF represents around 3% cases of overall ACLF. Diagnosis is a challenge when the patient presents for the first time as ACLF because characteristic features may not always be seen. A small study from All India Institute of Medical Sciences suggests that patients with no extrahepatic organ failure with good baseline prognostic scores may benefit if administered steroids with close monitoring for change in MELD over 2 weeks. However, those with organ failure should be considered for transplantation. This means that PLEX can be tried with a partial definition of ACLF, but not with EASL definition. An earlier analysis of ARC database has also shown that patients receiving steroids had improved survival. The dose recommended, although this has been discussed by Dr. Ashish Goyal earlier, is about 40 milligrams for 1 month. No recommendations have been made regarding prophylactic antibiotics, though a few studies have used cephalosporins. It must be remembered that patients with advanced age, MELD more than 27 or even 24 in some cases, presence of hepatic encephalopathy and fibrosis grade more than F3 may not respond and should be considered for liver transplantation upfront. In India, young patients with Wilson disease may present with ACLF, often due to superadded viral hepatitis, and it carries poor prognosis. In Europe, too, ACLF has been reported with Wilson's, but not usually due to viral hepatitis. Therapeutic plasma exchange has shown promising result in the recent Indian study of 37 patients with Wilson disease, showing better transplant-free survival at 90 days. There are no definite recommendations for chelation therapy in Wilson's ACLF, though it has been used by many. It is believed that rapid chelation of copper and removal of potential toxins by plasma exchange is likely to be more beneficial, and D-penicillamine in such cases should be given after a session of plasma exchange. The last disease that I'm going to touch upon is Budd-Chiari syndrome, and about 5% patients with Budd-Chiari syndrome may present as ACLF. Anticoagulant treatment is not feasible in such cases, but endovascular interventions have been showing some definite role and improved survival. This is a chart from a PASL guidelines, which classify BCS ACLF into 3 categories, depending on whether ACLF has resulted from vascular thrombosis as a cause of chronic liver disease or as a cause of acute event. However, when thrombosis is a part of acute event, interventions to recanalize the hepatic vein are recommended and may benefit the patient by improving the survival. My take-home message is that etiology-specific management in ACLF can improve outcomes in selected cases, especially those where aggravation of the basic etiology is the precipitating event. Specific drugs and plasma exchange may be tried in these cases, while intervention in selected cases of Budd-Chiari syndrome will be helpful. Irrespective of etiology, all cases will be offered supportive care with the specific treatment for organ failure and selection of cases for liver transplantation. Thank you for your attention.
So we can have a discussion now. Sir, here just one from my side. ACLF has 2 entities. One is chronic, one is acute. I think we have covered mostly the chronic part with the flares. Means alcoholic hepatitis with having alcoholic hepatitis. But they can get a hepatitis A or they can get a DD. So whether the disease and acute insult, there is discohon. And second, there is also addition of 2 factors. We see alcoholic hepatitis coming, the hepatitis A. So there are the few another areas I can think also may have impact.
I told you in the beginning that etiology-specific treatment usually means the etiology of cirrhosis which has gone on. and etiology of precipitating event is always treated, isn't it? So etiology-specific treatment for cirrhosis and acute event will work when both of them have same etiology. So these are the conditions where the definite benefit has been reported. But if a patient comes with alcoholic cirrhosis and superadded viral hepatitis, there is no point in treating alcoholic cirrhosis at that stage.
Very succinct, sir, and probably the best slide was the AIH slide. So, just for the audience, nowadays we don't see hepatitis C virus so much. What are your thoughts on someone who's got hepatitis C virus under DA treatment and presents to you? So, would you stop the therapy, or what would be your plan of management for a patient
The
like this?
treatment is safe. If the patient is already on treatment, there is no point in stopping it. But HCV treatment is not going to make the change in outcome of these patients. Because ACLF, if it is precipitated by something other than hepatitis C, the hepatitis C treatment will not change the outcome. There are no reports where ACLF hepatitis C treatment has been recommended in ACLF.
Professor Angelo, would you have a view on that? Somebody who's on DAAs and goes on to develop decompensation and a severe liver disease. So, would you want to stop the treatment, or would you like to continue the treatment?
I would like to stop the treatment.
Because one school of thought is that probably it's precipitated by the DAAs. So, I think till such time this patient, and most of these patients would actually not make it without a transplant.
Okay.
So, we abruptly stop the treatment.
For decompensated cirrhosis, we do recommend treatment, and the benefits are seen only after about a year or so.
So that's why we have to be very cautious when we are treating patients with a MELD of more than 21. Some studies would say 24 with DAs. So I think it should be done only when you have a plan B in place.
Okay.
There is a question from the audience.
Excuse me, sir. So I have two questions. Any comments or insight regarding role of N-acetylcysteine for etiology-specific treatment of ACLF? And the second is any role of dual antivirals for treatment of Hep B-related ACLF?
Hep B related?
Yes, sir. Hepatitis B.
There are no reports of using two drugs for hepatitis B. That is number one. The other question you had was about N-acetylcysteine. If there has been a drug which has been the precipitating factor, and it has been shown to benefit with N-acetylcysteine, you can definitely try it. But otherwise, there are no routine recommendations for use of N-acetylcysteine.
So for alcoholic ACLFs?
Even in alcohol, there are no routine recommendation for use of N-acetylcysteine.
Thank you, sir.
So I think the last talk in this session, thank you so much, sir. Thank you. The last talk in this session is going to be how to improve prospects or outcomes of transplant for ACLF advanced grades, to be given by Dr. Subhash Gupta, somebody who's really done a lot of work in this area.
Thank you very much, INASL, for giving me this opportunity to speak. So you've heard some of the best speakers on ACLF, but it remains for me to tell you what is the real situation of liver transplantation for ACLF3. There are many sort of reports and literature of excellent outcomes after liver transplantation for ACLF3, but if you look at them carefully, most of these transplants have been done after the condition has improved. So really, there are reports of liver transplant for cirrhosis, but reported as results of liver transplantation for ACLF. And we'll share our data and also look at the data from India and abroad closely in this presentation. So you don't need to go on the background covered extensively by the other speakers, but I'll tell you why ACLF is a unique problem in our country. The patients with stable liver disease prefer to wait or prefer to see the Dr. Dharmesh because he can supply them with a cadaveric organ. So we end up doing only the patients who are very sick. So you look at DDLT experience elsewhere, LDLT experience elsewhere, and the lessons that we've learned so as to improve results in this condition, and results of our own center for LDLT for ACLF3, which we published this month. and in the end, give you a summary. Well, to start with, there was a sort of uh, a fairly nihilistic approach to patients with ACLF till this publication in Journal of Hepatology, which showed that patients with ACLF could also have good outcome if they got good ICU care. But if you look at patients in the ICU, they were rarely considered for liver transplantation. And this is from Journal of Hepatology. Only 2.9% of admitted cirrhotic patients underwent transplantation. Living donor liver transplantation is even less likely to be considered while patients are admitted in ICU with organ failure. However, with the MEL scoring system, which used organ allocation to the sickest patient, encouraging reports started emerging. So we'll go back to sort of initial years of liver transplantation. Patients with ACLF3, vasopressors, mechanical ventilation, renal replacement therapy, and the survival rates were as low as 62% and 46% at the end of 1 year. This is far less than the threshold of classically accepted values for liver transplantation overall. But interestingly, those who survived had a much shorter ICU stay. Then came this important paper from the French group, which was on disease donor liver transplantation. Patients with ACLF, 73 patients, excellent outcome. 1 year survival exceeded 83.6%. Of course, those who were in shock or in severe respiratory failure, they were excluded. And GI bleeding was also considered a sign of not a sign of futility, because this is not GI bleeding from varicose hemorrhage. This was diffuse mucosal bleeding that you see in very sick patients. And all patients develop complications from vascular, biliary, neurological, respiratory, because they started with a complication, so the transplant actually would not eliminate these complications. So we had similar results across the continent from US about liver transplant, excellent outcomes even with organ failures. So this sort of told you that at least cadaveric transplantation was not a bad thing for ACLF. But the interesting points that emerged from these studies was that the MEL score did not reflect mortality from ACLF3. And in one analysis, in those patients who had a score less than 25 and had ACLF3 did worse than those who had a MEL score greater than 35, possibly saying that these two conditions were completely different and prioritizing for ACLF3 may be needed. Of course, we had a lot of debate on this yesterday and not go into it right now. At the same time, if these patients are not transplanted, then they have high mortality. And if you look at this study, which is 144 patients with ACLF, 94 were evaluated, 33 could undergo transplantation. And of course, those who could undergo transplantation had good results, but overall, only 10 out of 111 survived without transplantation. So that was the disease donor liver transplant experience for ACLF. What about living donor liver transplant for ACLF? Now, there are problems with the living donor liver transplantation. It's a smaller graft associated with myriad technical complications and takes a long time to complete. It may seem that there is an endless supply of organs, but detailed workup takes time. Graft statosis, absence of adequate graft volume, donor risk needs to be minimized, legal clearances must be obtained, and a surgeon's nightmare is an orphan graft. That means you have a patient whose recipient has died and you have an organ that has been taken out. Therefore, I will say that LDLT for ACLF3 in this country is still in its infancy. But if you look at the published results, very interesting. LDLT experience for ACLF3. First report from Taiwan, 2013, where a partial definition was used. Excellent results. To Avisoin's group, again, excellent outcome from liver transplantation for ACLF. But if you read the paper carefully, none of the patients at the time of transplantation had circulatory, respiratory, or renal failure. The only sort of true paper that I find on LDLT for ACLF is from S.G. Lee's paper from Asan, who reported a sort of 70% survival, 5 years survival. And you must remember that Asan Medical Center reported zero mortality after liver transplantation in 2019. Again, the Taiwan group reported 2021 excellent 3 and 5 years survival, and I'll take you through each of these publications one by one. Then you had experience from Japan, where they used this kind of modified ACLF grade 3 scoring system. But here also, in those who ACLF 3 had 33% survival as opposed to 85% in the other groups. And the Chinese sort of came up with a COSH score. When less than 7, no survival benefit, they could go on with sort of without transplantation for a long time. And if you did more than 10, then again they died quickly after the operation. And you have an interesting paper from AIG, which again showed that patients with ACLF could be transplanted, but perhaps better if they were done when they were grade 1 and grade 2. And our own paper, which has been accepted for publication this month, we'll share some data from there later on. So what was Taiwan 2013? All were Hep B related ACLF, and they had excellent outcomes. No mention was on organ failures. Now, this is the only paper that I'd like to discuss in detail, which is they used a sort of ACLF when they used a slightly different definition of ACLF, which is quite the fashion. And high MEL scores were divided into ACLF and non-ACLF. And the survival is compared between the two groups, and the group which had ACLF did poorly as compared to those who did not have sort of at least sort of 70% long-term survival in ACLF group versus 81 in the non-ACLF group. Therefore, this suggested that those with high MEL scores should be transplanted before they developed ACLF. And of course, this suggested they've always been a great proponent of higher graft weight, and they noticed higher complications, biliary, and sort of re-exploration ACLF group. And they talked about the Medanta paper, but interestingly, they had excellent results. But if you look at the patient cohort, when they at the time of transplantation, they themselves write in the paper, none of them had renal, respiratory, circulatory failure at the time of transplantation. Now, the Kaushing paper, which came out in 2021, again showed very similar excellent results, but this time they seem to have changed the technique, suggesting that liver transplantation for ACLF3 may not be such an easy thing to do. So they re-explored them after 3 days, and then did the biliary reconstruction. And perhaps this also acted as a kind of a system to look at lavage and drainage, and they had excellent results. So if you look at the paper from AIG Hyderabad, 71 patients were listed, 87 were in grade 2 at the time of transplantations. The majority were grade 2. Very few were in grade 3, but they had sort of survival rates exceeded 70%, which is obviously much less than the survival rate for liver transplantation for cirrhosis. So what has been our own experience? So between 2017 to September 2021, we looked at our patients, and we looked at ACLF different grades, and then we compared it with chronic liver disease. And so we looked at results of transplantation based on ACLF grade just before transplantation. Of course, it would have been ideal to improve these patients prior to transplantation, but they're already on their downward spiral. And the living donor liver transplantation, there is sometimes a lot of emotional pressure to go ahead with transplantation. So our study was to look at the results in this group and identify factors for poor survival. So this is a sort of output over the years, and last year I'm proud to say we completed over 400 liver transplants in a single calendar year. So this group, we had 853 liver transplants, and we excluded those who had disease donor liver transplantation. 19 had combined liver kidney. 6 had 9 retransplants and 9 acute liver failure. So they had 704 patients with liver disease, 103 with ACLF, and 54 with ACLF-free. And this is the group that I want to focus on. The ACLF patients were younger, heavier, higher MEL score, and less likely to have HCC. In fact, if you look at the long-term outcome of ACLF patients, they're better because they have a much higher proportion of hepatocellular carcinoma in them as compared to the cirrhotic patients. And most of these patients had been transferred from another center for the purposes of transplantation. So these patients had, the recipients had lower graft ratio, needed more products, and had greater blood loss. And compared to chronic liver disease, there's twice as much mortality, 8% versus 20% in ACLF. But if they survived 6 months, then the long-term survival was similar. And every complication was higher in the ACLF group, including reoperations, tracheostomy, and renal replacement therapy. Post-transplant ICU and hospital stays were longer. So what about ACLF3? And this is the group that fared really poorly. And the 1 month mortality was 25%, 6 month was 37%, and 1 year 38.8%. That's shown in the graph there. And but grade 1, 2, 3 had 81%, 77%, and 57% 1 year survival. Those who did not survive, 30 out of 103 patients, the donors tended to be older, had then a higher Cliff C score, and there were higher incidence of pre-transplant respiratory failure. This is different from encephalopathy. They were actually in respiratory failure and need for mechanical ventilation. So what have we learned from our results? Obviously, we stop doing these transplants, or we need to do them better. Well, not transplanting is really not an option. These are young patients, a lot of emotional pressure. So therefore, major changes are needed, and I'll share some of the things that we've learned over the years or after dealing with these patients. They need a quick, like Dr. Dhamesh is saying, that he'd be happy for a 6-hour operation rather than a 12-hour operation. So we want to do a quick operation, implantation without clamping, and relocal laparotomies. Anesthesia critical steps, they need concentrates rather than products. Avoid intraoperative CRRT because you can end up introducing infection in the theater, and volume overload after they have come off after reperfusion has been done. They may actually need TPN for a while because many of these patients, they just don't tolerate oral feeding. Preoperatively, we need to keep them on ventilation, correct ARDS if we can, antifungal prophylaxis, adequate analgesia, and what we call bottom-up immunosuppression. You only start when the patient starts getting better. Renal function dysfunction is quite common, and you need to the general feeling in our department and everywhere else now is that these should be transplanted quickly rather than trying to do a combined liver kidney transplant. Exploratory laparotomy. Hepatic encephalopathy is quite common, and therefore early tracheostomy. And interestingly, we've experimented by using NSAIDs in the first few days rather than opiates because it helps them recover from encephalopathy better. And some patients we obviously should not transplant. And these are patients who are septic or are in respiratory failure, multiple inotropes, infective chest infiltrates, so those who have multi-drug resistant organisms. And in the end, I'd like to give you a summary, which is that organ failure has greater impact on survival than the MEL sodium score. Best results for transplant when the patient is recovered from ACLF, but that sometimes is not possible. And if you were to transplant patients who are very, very sick, you're unlikely to get better than 60% long-term survival. And older donors and need for mechanical ventilation for respiratory failure has the worst prognosis, and long-term results are satisfactory if they've survived the initial 3 months. And in the end, I would take this opportunity to invite you to the 6th World Congress of International Living Donor Liver Transplantation, which is being held in Jaipur, India. Thank you very much for your attention.
Very nice talk, Dr. Subhas, as usual. Did any of your patients undergo plasma exchange before going for transplantation, particularly
at our
class
center?
three
We
patients?
are not fond of plasma exchange, but many of them did receive plasma exchange from the centers they came to us from.
Okay.
Dr. Subhash, you must be commended on presenting your results very honestly. I think this is what this audience needs to know. Thank you very much for that.
So can I just ask one question? So what is your protocol for the MDR infection positive ACLF patients? When do you time them for a transplant, and the post-transplant, what do you do for such patients? What antibiotics?
Okay, that's a very good question. And I think we discussed this earlier on also. I think one of the things is not to do a culture when there is no indication for it. One of the problems that we find that you do surveillance cultures and you'll pick up something or the other. And if for example, it's a bit like if somebody has fever and no symptoms. So is the fever from an infection or what it is? So we are not very key, but yes, if there are chest infiltrates, if there's SVP, together with it, something to explain the organism, then we would have to take note of it. And obviously, these are not patients who should be transplanted.
So how much do you wait? Like, what is the protocol for waiting?
We, you,
7
can,
days, 10 days?
you just cannot wait in these patients. Like, you know that. You just cannot wait in them.
So that is the current challenge. So we wait at least for the culture to get negative.
It just never happens.
And the
It never,
clinical improvement.
it just never happens. Never happens. And you will, I mean, but if there are sort of from the infection, there is chest infiltrates, there's bacterial peritonitis, but just a blood culture which has come positive, I would not act on it.
Another very, I'm just asking based on your experience, have you seen outcomes of kidneys depending upon the status of patients on dialysis, being oliguric versus non-oliguric in ACLF?
We prefer those who are producing urine, but we've always done many patients now who've been anuric, and surprisingly, many of them opened up. But interestingly, the urine output improves, but creatinine clearance, the creatinine clearance doesn't happen. And many of these patients have then went on to have kidney transplant as well.
Dr. Subhash, sorry, last question. Do you have any data from any Indian centers doing cadaver transplant for ACLF class 3?
Dr. Dharmesh is sitting next to you. He'll answer that question far better than I can.
So when you are faced with a situation when you have to transplant ACLF3, in deceased donor setting, the organ does not announce itself. So you have just tried to make an attempt to downgrade this patient's ACLF grade. And if you are not able to do that, then you obviously don't go on to transplant him also. You actually declare futility, because organ is such a precious commodity. You should not be using for someone who's not likely to survive the transplant. And of course, in the deceased donor setting, the criteria for saying someone to be futile are pretty much what has been very elegantly quoted in the West, which is by way of the counts, the infiltrates, the inflammatory markers, the organ support that the patient is on, so on and so forth. So you have to be extremely judicious in accepting a patient for a transplant. The best scenario, and this we've discussed numerous times since yesterday, is still deceased donor, but provided you have good donation rates, which unfortunately do not exist in our country.
Thank you.
Thank you very much. All the speakers, they covered very well, and the audience participation also very good. Thank you very much.
Thank you, esteemed speakers and chairpersons, for this brainstorming session on ACLF. Now we'll break for tea. After that, we'll start sharp at 5:10 p.m. for the session on hepatic encephalopathy debate. Thank you. I'd like to invite Professor R.K. Dhiman, sir, Director of Sanjay Gandhi Institute of Postgraduate Institute of Medical Sciences, Lucknow, Dr. G.N. Ramesh, Senior Consultant Gastroenterologist, Aster MedCity, Kochi, Dr. B.G. Mohan Prasad, Founder and Chairman, BGM Gastro Center, Coimbatore, Dr. Ajay Jain, Senior Consultant and Head of Gastroenterology in Choitram Hospital and Research Center, Indore, and Dr. Abhinav Sharma, Professor and Head in Department of Gastroenterology in C.K. Birla Hospital, Jaipur. I would request the following chairpersons to come over the dais and start the proceeding. Thank you.
Welcome back, and this is debate. The statement that we are debating is all patients with hepatic encephalopathy should be given branch chain amino acids. So we have a speaker for the motion and a speaker against the motion. The time allotted is 15 minutes for each speaker, and that'll be followed by 15 minutes of discussion. So now to speak for the motion, May I request Dr. Punita Tandon to please come up?
And as a chairperson, before the speaker starts, I'm for motion. So I'm giving the judgment earlier, don't get confused. I'm for producing at least 3 or 4 motions so that hepatic encephalopathy is taken care. That's what we conventionally used to do. I'm not talking about this motion.
Okay. Hello, everybody. Thank you so much to the organizers for the opportunity to present. And yes, I've been given the task of speaking for the motion of branched-chain amino acids. I have no disclosures, but I am 2 minutes over time on this presentation, so I will, the buzzer will go off. So apologies in advance. All right, we're going to start with just some basics, which many of you will know already. We have 20 amino acids. Some of them are non-essential amino acids, which mean that the body can produce them. Others are essential amino acids, which mean we need to take them in by food. And some of those are branched chain amino acids, isoleucine, leucine, and valine. They have a branched aliphatic chain, and they bypass first pass metabolism through the liver, and thereby they can be used by muscle. So in the 1950s, it was described that there is a change in the ratio of branched chain amino acids and aromatic amino acids. Higher aromatics, lower branched chain amino acids in patients with hepatic encephalopathy. And that was postulated to be related to hepatic encephalopathy by something called the false neurotransmitter hypothesis, which later got replaced to thinking that branched chain amino acids instead have a benefit by ammonia detoxification outside of the liver. And indeed, there are now several reviews about the potential mechanisms of branched chain amino acids, including ammonia detoxification, but also that they are a source of protein, so positive nitrogen balance, that they stimulate mTOR pathway by reducing protein breakdown and preserving muscle mass, and that's predominantly through leucine, and some data that they attenuate the PI3K AKT signaling, resulting in tumor suppression, glucose homeostasis, and lipid synthesis. I'm going to just go through 3 of the randomized controlled trials. The first 2 haven't specifically focused on hepatic encephalopathy, but they're the large RCTs that you will probably know somewhat about. So the first one is by the Italian group, 2003, 174 patients with cirrhosis, all of them Child-Pugh B and C. They got patients to take in a standard diet, or recommended it anyways, up to 0.8 grams protein per kilogram per day. And then they were randomized into 3 arms: branched chain amino acids, 14.4 grams, versus an isocaloric intervention, maltodextrin, versus an isonitrogenous intervention, lactoalbumin. Their primary outcome was a combined outcome of death or deterioration, and deterioration had several things in there, including hepatic encephalopathy, worsening ascites, etc. And this was significant. So branched chain amino acids led to an improvement. They also had improvement in their secondary outcomes of nutritional parameters, including increase in the mid-arm muscle circumference, liver function parameters, and quality of life. A second study done in 2005 was the largest study to date, 646 patients with cirrhosis, half of them Child-Pugh BC. They again suggested to patients to take a certain diet, and this was a bit more regimented on their end. They randomized patients to branched chain amino acids 12 grams versus diet. This was not isonitrogenous as a control. Over a 2-year period, what they found was that the primary outcome here was also significant. So there was an improvement in that there was a reduction in death, or again, deterioration with various liver complications. Secondary outcomes: improved albumin and improved quality of life. And the third randomized control trial was done more specifically focusing in on that cohort of patients with overt hepatic encephalopathy. So this was by Juan Cordoba's group, looking at 116 patients who had just recently been hospitalized for overt HE. Mean Child-Pugh was 8. They were again asked to go on a standard diet, protein a little bit low, 0.7 grams protein per kg per day. And they were randomized to branched chain amino acids 30 grams versus maltodextrin, again, not an isonitrogenous control. Their primary outcome was presence of occurrence of overt HE, and it was not actually significant. They did, however, see improvements in minimal hepatic encephalopathy, as well as here again muscle mass. And I'll just point out, this is going to be very small for you, I think, but a challenge that I had with this study was the number of patients that were censored. So about a third of patients were censored for various things, death, transplant, but also for intolerance to supplements or non-adherence to diet. And it just makes me wonder about the power of this study to make these conclusions. So what does the Cochrane, the gold standard for systematic review, say about branched-chain amino acids for HE? Looking at 16 RCTs, including the data that we've looked at, 827 participants, 12 of the trials were for overt HE, the rest for minimal hepatic encephalopathy. The dose median was 20 grams a day, and treatment duration was a median of 4 weeks. And they found a significant improvement when these studies were put together. So a risk reduction of 0.73, high quality trials is how they reported them, with moderate heterogeneity. The subgroup analysis showed benefit of oral but not intravenous, and there was no significant benefit on mortality. Their conclusions were that BCAAs should be considered in the management of people with HE, but that additional trials were needed that included standard treatment like lactulose rifaximin routinely in patients. There's been other randomized control trial synthesis systematic reviews done, and this one focused on non-HE outcomes, and that's why I'm putting this here from 2022, 20 RCTs, almost 1,300 participants, showing that branched-chain amino acids increased muscle mass, plasma albumin, reduced cirrhosis complications, again, no impact on mortality. And we know this is relevant because muscle, again, in individuals who have cirrhosis, becomes more and more important as a secondary site of ammonia detoxification. Now, pathophysiologically, there's also rationale, and this is a really nice study done by Dr. Dasarati's group, looking at patients who had a 15-gram BCAA mixture enriched with leucine given. They had a muscle biopsy before and 7 hours after that BCAA mixture. And what they found was that the branched-chain amino acids increased mTOR signaling and reduced autophagy. They did point out a slight risk, though, that the levels of the other essential amino acids decreased, suggesting that those would need to be replaced when leucine is used to stimulate protein synthesis. Okay, so you turn on the protein synthesis factory, you're using up all your other essential amino acids, so you need to replace them. Now, I stand here as one of the so-called experts, but what have the experts in the world said about branched-chain amino acids from the guidelines? So the hepatic encephalopathy guidance from INASL really didn't make a statement or a recommendation. They just put the data down for the Cochrane as well as for that trial that I showed you from the American Journal, which had by Cordoba's group, suggesting that the high-quality RCT did not prevent recurrence. Going back to ISHN from 2013, they supported that branched-chain amino acid supplements would allow recommended nitrogen intakes in patients who are intolerant of dietary protein, so check mark there. From INASL, they also suggested that BCAA supplements and leucine should be considered when adequate nitrogen intake was not achieved, and they went as far as to say that it could be considered to improve neuropsychiatric performance as well. ESPEN also similarly said that in cirrhotic patients who are protein intolerant, BCAAs at a dose of 0.25 grams per kilogram per day should be used to facilitate adequate protein intake, that long-term BCAA supplements may actually improve event-free survival or quality of life, so from those first two big RCTs that I showed you. And then that in patients who required enteral nutrition, you could use BCAA-enriched formulas. Our very own INASL, this also supported BCAA supplementation, leucine-rich, to reach adequate dietary nitrogen intake. And I also had the opportunity to be part of the ASLD guidance, and we took a slightly more practical stance here, but again, supporting branched-chain amino acids, but saying that, you know, let's try and see if we can use a food-first approach and get our daily overall protein intakes, because branched-chain amino acids are clearly found in food as well. Okay, so I've shown you there's pathophysiologic rationale, shown you the Cochrane supports it, the guidelines across the world support that we should be doing this. So why are we not doing this? Are there risks that maybe we should not be doing this? And I would say from looking into the literature, this author, Holasek, is the one that has put out the most kind of publications on the potential risks of BCAAs. And the one that he points out is that when you are actually using branched chain amino acids, you create glutamine, and that glutamine then needs to be broken down. So it goes to the kidneys and the enterocytes and creates ammonia, increasing ammonia levels, potentially increasing encephalopathy. Okay, so that's probably the biggest risk that's pointed out. And again, fairly theoretical from even the reviews that he's done, studies reporting significantly increased ammonia levels that have actually caused anything clinically significant are not present as far as I could see. The other risk is what Dasarati's group pointed out, that when you're giving just a selection of essential amino acids, you will get a depletion in the other amino acids, suggesting that those need to be replaced. Okay, so let's get practical with this. Studies to date demonstrate promise for efficacy. The risks are theoretical. Branched chain amino acids are clearly important as far as being essential amino acids for building protein. While supplements are one option, I think for North America, anyhow, they've not been used as much because they can be costly and poorly palatable as a first-line approach. So I would support going with a BCA food-first approach. And there's many BCA-containing foods, including animal as well as dairy and plant proteins. There's also evidence from India, so beautiful studies that have been done here, that food is very powerful. And this is a nice study by Maharishi et al. Looking at a randomized control trial of nutrition education, getting to protein targets, reversal of minimal hepatic encephalopathy in these patients in the intervention group in 71% versus 23% of patients. Also improvements in quality of life, muscle mass, and strength. And then a second study from Dr. Taneja's group, and I've put this one here. So this again was a dietary intervention led by a dietitian. And they, of course, found improvements in the liver frailty index and in muscle mass. But what they also found is that you can increase protein intakes. So going from baseline protein intake of 0.99 to, in 1 month, going to within target, so 1.31. So again, this is possible. Now, what does the rest of the literature say outside of cirrhosis? And there is so much done already in sports nutrition, actually, and this is a big debate even in sports nutrition around should we use branched chain amino acid supplements or not. And one of the lead protein researchers in the world is in Canada. His name's Stuart Phillips. And this is just an excerpt I've taken from Men's Health magazine. But his bottom line is, if you can get it from food, get it from food, and branched chain amino acid supplements are actually not necessary if you can get the BCAAs from food. You only need about 2 to 3 grams of leucine at each meal in order to drive protein, drive muscle growth. And we know that that taken along with exercise, which really reduces or increases anabolic potential, can be very helpful. And so it's not a lot, a scoop of whey protein, a cup of cottage cheese, or if you eat meat, 3 ounces of chicken breast to get that amount. So in conclusion, I would say I join the guideline experts in supporting BCAAs in patients with HE to not only reduce HE, but to also increase muscle mass. But I've taken a slightly different approach. So first-line food approach to achieve BCAA targets, which I think is very possible from what we've seen. If that's insufficient, if they're not getting it enough, then I would say adding in a leucine-rich complete protein supplement. And one of the ones that I like the best is the whey protein isolate because of its very easy digestibility. And so this is what I would recommend in many of my patients. And that gets away from the fact that you then are giving them a complete protein. So you're giving them all of the essential amino acids. And if that's poorly tolerated, or they still have a poor clinical response, they're continuing to get episodes of hepatic encephalopathy and they're maximized on medical therapy, I don't see any harm in giving branched chain amino acids via supplements. I think further studies would be really beneficial, but that is where I stand at this point. So thank you very much for the opportunity to talk.
Thanks, Dr. Punita, for a wonderful delivery. I think you've given points for and against the motion. Now we'll request Dr. Burjesh Sharma to speak against the motion. We'll have the audience poll probably at the end of it, right?
Thank you, sir. Good evening, ladies and gentlemen. I'm thankful to organizers for giving me this opportunity. I will speak against supplementation of branch chain amino acids in patients with hepatic encephalopathy. In early 70s, alteration in ratio of plasma branch chain amino acids and aromatic amino acids was postulated to be a major factor in development of hepatic encephalopathy. However, it was a hypothesis only. There was no scientific evidence. And based on this hypothesis, branch chain amino acids got premature recognition as a factor for development of hepatic encephalopathy and also for clinical use in treatment of hepatic encephalopathy. Few years later, a study was done which showed in patients with liver cirrhosis, there is reduction in the level of plasma branch chain amino acids and aromatic acids are raised. Aromatic amino acids are raised. However, the main finding in this study was that plasma levels of branch chain amino acids are reduced and aromatic amino acids are raised in patients with cirrhosis. However, there was no difference in patients with liver cirrhosis without encephalopathy and with grade 3 or 4 encephalopathy, thereby signifying that branch chain amino acids are lower in patients with liver cirrhosis. However, they do not play a role in development of hepatic encephalopathy because with hepatic encephalopathy also the levels were same. First study I came across was published in 1982. With this study, patients with liver cirrhosis with encephalopathy of 6 months or longer were given oral branch chain amino acid 30 grams versus placebo in a double-blind randomized crossover fashion. The amino acids contained 70% leucine, 20% valine, and 10% isoleucine mixture. Duration of treatment was 14 days. However, 4 patients were treated for 5 to 22 weeks. And after 14 days of treatment, there was no difference in clinical, psychometric, and EEG findings in response to branch chain amino acids. And 4 patients who got treatment for 5 to 22 weeks, they also showed similar results. And main thing is that after injection of branch chain amino acids, branch chain amino acid level went 3 to 8 fold higher within 1 hour and returned back to baseline within 3 hours. After injection of branch chain amino acids, there was a reduction in level of amino acids like tyrosine by 35%, phenylalanine by 55%, and methionine by 65%. This shows that if you give branch chain amino acids, there is rise in level of branch chain amino acids and reduction in level of aromatic amino acids. That means there is normalization of branch chain amino acid to aromatic acid ratio. Even after normalization of this ratio, as I told in earlier slide, there was no improvement in encephalopathy. Therefore, even after proving this, indiscriminate use of branch chain amino acids continued for treatment in hepatic encephalopathy. This was a study, randomized controlled trial, 40 patients grade 3 to 4 encephalopathy, branch chain amino acid versus lactulose. 70% of patients in branch chain amino acid responded as compared to 50% in lactulose over similar period of time. And main thing was the difference in recovery rate of encephalopathy was not significant between these two groups. In this study, double-blind randomized controlled trial, nutritional supplementation was done enriched with branch chain amino acids or lactalbumin or maltodextrin, 174 patients, and duration of treatment is 1 year. And Dr. Tandon has also quoted a study. However, the main finding was that over 1 year follow-up, there was no significant difference in encephalopathy test scores. Return test decreased by below the cutoff value of 60 seconds in patients with latent encephalopathy in similar number of patients treated with branch chain amino acids, lactalbumin, or maltodextrin. Also in 3 groups, there was no difference in deterioration from normal mental status to latent hepatic encephalopathy. However, this study had many problems, specifically with use of branch chain amino acids. 1/3 of patients could not complete the follow-up, and there was withdrawals. And these withdrawals were 3-fold higher with branch chain amino acids as compared to other nutrition supplementations. And these withdrawals were due to, this non-compliance was due to bad taste of amino acids and intolerance to large amount of water to be taken along with branch chain amino acids and its adverse events. Benefits of branch chain amino acid supplementation only seen when non-liver related deaths were excluded. Also, despite significant improvement in nutritional status, this is the main thing, the nutritional status improved, muscle mass improved, however, encephalopathy did not improve, which is the mechanism as stated for branch chain amino acid to act. L-acetylcarnitine, we know, is a physiologically active substance synthesized in mitochondria, crosses blood-brain barrier, and has been used in treatment of encephalopathy. In this randomized control trial, combination of branch chain amino acid plus L-acetylcarnitine was compared with branch chain amino acid alone, and it was found that improvement in Glasgow Coma Scale score, venous ammonia levels, and severity of and EEG findings was seen when patients were treated with this combination. However, with alone branch chain amino acids, there was no improvement in these parameters. In this double-blind randomized control trial, oral branch chain amino acids versus maltodextrin was compared in 116 patients. These patients had liver cirrhosis and a previous episode of hepatic encephalopathy. Duration of follow-up was 32 to 36 weeks. And in this study, over follow-up of 32 to 36 weeks, there was no difference in number of patients having recurrence of encephalopathy, chronic persistent encephalopathy, chronic recurrent encephalopathy, number of hospital admissions and hospital stay in both these groups, thereby showing that branch chain amino acids do not have any specific action. And also, in this study, 1 year survival in both the groups was similar. It was no different. In this retrospective cohort study using extended follow-up data from hepatitis C antiviral long-term treatment, again, dietary branch chain amino acid intake was analyzed in patients with advanced liver cirrhosis, 656 patients. Dietary intake was assessed by food suspensive questionnaire, which estimates nutritional intake over the past year based on self-reported frequency and portion of food. The median absolute branch chain amino acid intake was 11.9 grams per day. Median follow-up was 5 years, and incidence of hepatic encephalopathy was 11.4 per 100 years and was not related to intake or no intake of branch chain amino acids. Similarly, there was no association of branch chain amino acids with number of patients undergoing liver transplant and number of liver-related deaths. And also, survival according to 4 quartiles of branch chain amino acid taken in this study was similar. It was no different. This study is from PGI Chandigarh, in which combination of lactulose and branch chain amino acids was compared with lactulose alone for hepatic encephalopathy in patients with acute and chronic liver failure. 76 patients, and this study showed that there was no difference in number of patients having resolution of encephalopathy at day 3, at day 7, time taken for resolution of encephalopathy, and time to improve by 1 or more HASA grades, and also in use of rescue drugs in both the groups of patients. This study concluded that intravenous branch chain amino acid infusion does not lead to sustained recovery from overt hepatic encephalopathy in patients with acute and chronic liver failure. There are many systemic reviews and meta-analyses published on use of branch chain amino acids in patients with hepatic encephalopathy. In this meta-analysis, there were beneficial effects of branch chain amino acids on improvement of hepatic encephalopathy. However, there was no difference in mortality there was no reduction of mortality with branch chain amino acids. This was a study on this was a meta-analysis on studies with branch chain amino acid supplementation in cirrhosis with portosystemic encephalopathy. And this study showed beneficial effects of branch chain amino acids in reduction of grades of encephalopathy in patients with liver cirrhosis. However, there was no difference in complete resolution of encephalopathy and mortality. And on sensitivity and subgroup analysis, the authors found the data was not sufficient to analyze for reduction and improvement in encephalopathy. And also, on subgroup analysis, there was no difference in worsening of encephalopathy. And survival was same in both the group of patients. In this meta-analysis, the summary of results was that branch chain amino acids may improve encephalopathy. However, certainty of evidence is low. Branch chain amino acids do not reduce mortality, but certainty of evidence is moderate, not low. And this meta-analysis comments in discussion that patients and clinicians putting more value to uncertain benefits will use branch chain amino acids. Our patients and clinicians give less importance to uncertainty and more important to cost. They will not use branch chain amino acids because certainty of evidence is low. And branch chain amino acid at significant cost. However, it is not possible to perform a proper balance between benefits and costs due to limitations in the certainty of the evidence. This is a Cochrane database systemic review, 16 trials, 827 patients. There are beneficial effects of branch chain amino acids in improvement of encephalopathy. However, 15 trials, 760 patients, no difference in mortality. Branch chain amino acid did not reduce any mortality. And in this meta-analysis, there are no difference in efficacy of lactulose and branch chain amino acids, and there are no beneficial effects on quality of life and nutritional status. So the point to be noted is that in this meta-analysis, there are no improvement in nutrition parameters, no improvement in nutrition status, no improvement in muscular mass or muscle index. However, encephalopathy improved. Therefore, the mechanism of improvement of encephalopathy still was not clear. This meta-analysis shows that with use of branch chain amino acids, there is a reduction in number of complications of patients with liver cirrhosis. However, the studies included in this meta-analysis had different duration of follow-ups. And when they did subgroup analysis according to duration of follow-up, with setting of 6 months as threshold, they found that long-term branch chain amino acids have beneficial effect on improvement of encephalopathy. However, in this meta-analysis, most of studies were from Japan. Therefore, they did post-hoc analysis according to country of origin of study. And what they found is that post-hoc subgroup analysis, the complications including encephalopathy were significantly reduced in studies, only in studies from Japan. Our studies from other countries did not show any reduction of complications or encephalopathy. And also, the survival mortality was same in both with or without branch chain amino acids. This is a recently published systemic review. 4 studies on MHE. In 2 studies, branch chain amino acid not effective. In 1 study, it is effective. And in 4th study, branch chain amino acid plus symbiotic combination was effective. Our alone branch chain amino acid was not effective. On this meta-analysis, 7 trials on overt hepatic encephalopathy. There were branch chain amino acids were not effective in prevention of first episode or in prevention of recurrence of encephalopathy. So there are many problems, many limitations of these studies and meta-analysis. Heterogeneity of population treated, clinical assessment, study findings, and risk of bias. Also, there were differences in study designs, stages of liver disease of patients included, and outcome variables evaluated. Terminology used in different studies was different. Some used latent encephalopathy, some used chronic, clinical, minimal, and recurrent encephalopathy. Also, assessment of improvement was done using different criteria like portosystemic encephalopathy, West Haven index, and psychometry. most of studies use portosystemic encephalopathy, which has been rejected by FDA because of inclusion of venous ammonia levels and severity of flaps in this criteria. Resolution encephalopathy was considered as complete recovery in some studies, and some studies even took incomplete improvement as resolution of encephalopathy. And many studies included clinical hepatic encephalopathy from the analysis because it is associated with increased mortality. Also, in most of these studies, there were variabilities in doses of branch amino acids used, frequency of administration, route of administration, duration of supplementation, and follow-up of the patients. And also, ratio of individual amino acids in total branch amino acid supplements. Concomitant interventions were not commented, and subgroup and sensitivity analysis could not verify these results. Some studies reported with branch chain amino acids that increase in BMI and everything. However, they did not comment on worsening of ascites or pedal edema with use of branch chain amino acids, and this BMI may be due to increased fluid retention. With branch chain amino acids, there is poor compliance and higher withdrawal rate. That is due to poor palatability, a large volume of water to be taken, and need for several admissions if intravenous injections are required, and also adverse events like nausea, vomiting, and diarrhea. Now, various workers, they found that encephalopathy might improve with branch chain amino acids. However, there are no corresponding improvement in ratio of branch chain amino acid to aromatic amino acid or in muscle mass. Therefore, these workers thought the branch chain amino acids might be having direct effect on nervous system and they might be neuroprotective. With that aim in mind, they conducted further studies. However, the results they found that branch chain amino acids were not neuroprotective, these were neurotoxic. I will not go into details of these studies. I will just summarize the results by saying that in animals with hyperammonemia, and X fistula, a model for portosystemic shunt, there are lower concomitant, lower concentration of branch chain amino acids in the blood. However, in CSF and brain tissue, the branch chain amino acids were not less. It was similar to that of controls. And branch chain amino acid supplementation carries risk of overdose in these patients. Also, ammonia has been shown to increase intracellular level of branch chain amino acids and their neurotoxic derivatives in the brain. Branch chain amino acid treatment with and without ammonium chloride, that is, with normal ammonia and with induced hyperammonemia, irrespective of ammonia levels, branch chain amino acids increase the leakage of intracellular LDH from astrocytes, reduce proliferation rate of astrocytes, and affected multiple metabolic pathways in astrocytes, thereby showing that branch chain amino acids are neurotoxic. Coming to recommendations, these INASL and ESPEN guidelines.
I think your time is up, Brijesh.
I am just short, 2 slides. Do not recommend these branch chain amino acids in patients with hepatic encephalopathy. And ASLD guidelines, oral branch chain amino acids are recommended in patients with only intolerant to dietary proteins. And ASLD does not recommend intravenous branch chain amino acids. To summarize, ladies and gentlemen, trials and meta-analyses have shown that branch chain amino acids are not effective. Some trials and meta-analyses have shown positive results. However, certainty of evidence is very low. And reason for giving branch chain amino acids in chronic encephalopathy is that they improve BMI, they improve muscle mass. However, these results can be obtained by simple modalities like late evening snacks, which has been shown to have similar efficacy. There is no clear evidence of benefit of expensive and bad taste medicine when similar effects in acute encephalopathy can be obtained by lactulose, which is cheaper and more effective. Higher adverse events and no cost analysis has been done. And this shows the various meta-analyses other than investigator-initiated trials has also included data provided by pharmaceutical companies, pharmaceutical-funded trials, and profit-funded trials. Higher withdrawal rate in branch chain amino acid group, whether patients and clinicians say they do not know whether branch chain amino acids prolong life or not. But with daily intake of branch chain amino acids and so much of water, they say their leftover life becomes difficult. They do not know how to pass leftover life. Also, they may not prolong their, they may lower liver-related deaths. Branching in amino acids may lower liver-related deaths. However, total mortality is same. That means number of funerals in both the groups are same. Negative effect of these studies and these problems left branching amino acids in moribund state and mortal blow to the treatment. Therefore, ladies and gentlemen, cautious interpretation of these results, published results, and their implications at the clinical level before writing should be done before writing year-long prescriptions for branching amino acids with drug company logo embossed pens, keeping in mind that various trials and meta-analyses have shown they are not effective. Trials and meta-analyses showing the efficacy have low certainty of evidence, high withdrawal rate, poor taste, high side effects, and similar results can be obtained by cheaper and more effective drug lactulose, and increase in muscle mass can be obtained by very simple method, late evening snacks, which has similar efficacy. Thank you, ladies and gentlemen, for your kind attention.
Thank you very much, Brijesh. I think I'll give the opportunity to Dr. Punita to rebut. You get an opportunity to for rebuttal, a quick rebuttal, and then we'll also have comments from the chair.
Thank you. That was so good. Such a good review of the literature. So I think bottom line is that I would agree with you that the studies to date are mixed and that we need better data. But I would also say that we need to think about who we would actually give branched chain amino acids to. So it's not like we're going to be replacing lactulose or rifaximin with BCAAs. It's going to be a trial where we have patients who are not responding to standard dietary intake as well as lactulose and rifaximin. Yeah, I'll give you this after. Who are not responding to that, and then we give them branched chain amino acids on top of that versus an isonitrogenous intervention, and very carefully look at what are the advantages or not. So that's, yeah, my conclusions are still the same. I think it's a nitrogen source more than anything.
Thank you, Dr. Punita. I think the audience that you have listened to both the speakers also. The question was whether the BCAA should be given to all cirrhotic patients with hepatic encephalopathy or history of the hepatic encephalopathy. Those are in favor of yes, they can raise their hands. And those feel that it should not be given, they can raise hands now. So majority is for the not to give. I think I'll just summarize what both of they have said. I did not want to influence your decision, therefore I'm just talking after your decision that you have displayed just now. So many studies and very heterogeneous results actually. The one study says something other, and even within the study there are contradictions also. But nevertheless, if you look at the Cochrane review and other meta-analysis also, they say there is some evidence that it is beneficial to the patient with the hepatic encephalopathy, and sometimes the grade has gone down also. But at the same time, they also say the muscle mass. If you remember, the BCA mechanism action is through the muscle also. It is directly metabolized also. Therefore, that suggests the increase in the muscle mass is justified. But it is doubtful as far as the role on the hepatic encephalopathy is concerned. And other complications not beneficial, quality of life not beneficial, mortality does not decrease. As far as the cost is concerned, in India it is cheap, it can be given, but there is no true cost effective analysis so far. I'm just a minute. What personally I feel actually, I might be wrong or maybe right also. There is not sufficient evidence as of now in the literature to suggest that it should be given in all and every patient of the hepatic encephalopathy. But I tell you one thing, for the point of the nutrition, at the part of the nutritional supplement, I do prescribe BCCA to my patient with the decompensated cirrhosis.
I'll just say one last thing. I mean, I think we need to separate out this idea of supplement versus BCAAs in food, okay? So we need to understand that nutrition first, food first. We're doing BCAAs in everybody. If we're actually getting them up to protein targets, we're giving them enough leucine, right? So that's where we really need to, I think, focus. The BCAA supplements, in addition to that, we need better studies. I would agree.
So can I ask a question to both of you? Patient, you have given pros and cons of the BCA in hepatic encephalopathy. Suppose a patient who comes with a recurrent hepatic encephalopathy, what is the role of BCAs in these patients?
If you ask me this question to answer, I will directly go to the scientific evidence available. Individual studies and meta-analysis have shown branch-chain amino acid versus controls. There is no difference in prevention of first episode of overt hepatic encephalopathy and also in the recurrent hepatic encephalopathy. There is no role, there is no difference. And first, okay, please ma'am.
No, even though I think you have to answer his question. Would you like?
Would you prescribe or not?
I don't use branched-chain amino acid supplements in, I don't actually use them, but I do use nutrition. I mean, I do use that, and I do use lactulose, and I do use rifaximin. So I think that we have to, again, separate out what the treatment is for HE, the base that we need to use, and then do BCAAs actually add additional benefit? We haven't evaluated it properly in a large randomized trial in that population.
Dr. Jain, I said branch-chain amino acids are not effective in these. But please listen to me. Even if there is unequivocal evidence that these are effective, even then I will have many reservations to use a drug with which withdrawal rate is very high because of very poor palatability, bad taste, and a large amount of water to be taken along with that. Patients become life becomes difficult. So he said, encephalopathy may or may not improve, but his life is so difficult he cannot live.
Can we have a comment from Professor Virender?
Yeah, this is one is the question to Dr. Punita. Which is the best protein in which we get the BCAA?
So,
because the eggs or the meat or the soya products or the milk products, which is the best one?
Yeah, animal-based proteins and dairy. So I guess whey would be really nicely digestible here, and for many people who are vegetarian, that would still be okay.
Yeah, this is for the audience. I see a lot of patients with the decompensated cirrhosis and ascites, and in all of them, I give them the egg protein. The eggs, I ask them to eat 2 eggs, 4 eggs, 8 eggs, 10 eggs, even more than that if they can tolerate. And they do very well. See, the high protein, and then ask them to do exercise. You call them after 2 months, they are very, very happy. Their ascites comes down, and then the whole scenario changes. So this makes a difference. I don't know whether this is because the protein or because the BCAA.
So I will not be treated by you, Dr. Virender Singh. I think, right? I'm a Jain, so how will you treat me then?
Rest of the discussion can go on tea or dinner. So we may close the session. Thank you to all speakers and
thank you.
I think I would appreciate Dr. Punita, who gave a very balanced view. She was supporting Brajesh Sharma's view that it should not be given to all, especially in hepatic encephalopathy. So, thank you so much.
Thank you very much. We had an excellent debate. Thank you, speakers and chairpersons. We conclude this session. Now we have symposium on SCC in Baravati Hall, that is second hall number 2 at 6 p.m. and followed by general body meeting at 7 p.m. for INASL members at 7 p.m. Thank you.
Thank you, Akash. Good evening, all. So the hectic day came to an end, and it's my pleasure to invite you on behalf of organizing committee for today's cultural evening by Bollywood singer Javed Ali and gala dinner. So see you in the evening, 8 p.m. right here. Thank you so much.
Gentlemen, before I start with the formal welcome or say anything further, as we are in the city of temples, as we are in the land of Lord Jagannath, might I request everybody to raise both of your hands and say with me, Jai Jagannath. You can be a little bit louder. Let's start with a lot of energy, a lot of positivity for this evening, as this is the finale evening of entertainment at INASL. Everybody, once again, can I see both your hands? Up, 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 up. Sabke? Yes? Okay. And sabko ek baar, zor se. Jai Jagannath. Now that is the energy that I was looking for to start. Once again, a very good evening. Namaskar, hello, and a very, very warm welcome. Welcome to, first of all, Odisha. It's known now as the India's best kept secret, but I believe in the last 3 days, little bit here and there, you are now aware of what are the secrets here. Certain secrets are out there, certain are yet to be discovered. How has been your journey till now in Odisha? Did you like it? Everything well? Yes? I know कि दिन भर काफ़ी serious बातें हुई हैं. This conference has been so insightful, full of knowledge sharing and all of that. But now this evening is to unwind, to enjoy, to get entertained, to enjoy to the fullest. So I really want everybody to be super participative. Formally, officially, welcome to this gala and musical night of the 31st Annual Conference of Indian National Association for Study of the Liver. I understand, I have the privilege, I have the honor to stand in front of some very eminent personalities from across the country and across the globe. These 3 days till now and tomorrow, I'm sure, is going to be even more insightful, especially when we have the privilege of having 19 eminent hepatologists from across the globe. Can we have a round of applause and welcome our delegates who have made it to India, who have made it to Orissa, to enlighten us with their thoughts, with their wisdom. Thank you very much for joining everybody, not only from Orissa, I understand from India also. यहाँ पे बहुत हमारे ऐसे सदस्य उपस्थित हैं. Thank you very much. Welcome. I hope these 3 days have been good, and tonight is going to be very, very special. All right, what did we do in these 3 days? Especially the only thing that I can talk about is something that is not medical related. Of course, I cannot talk anything technical, but I can definitely talk about the theme that we have followed. The mission that we kept in mind was to go green, to use paper less, to use plastic less, and somewhat we have succeeded because all of you have cooperated with us. But ladies and gentlemen, do you know, in these past 3 days, as part of our CSR initiative, we have reached to 400 plus policemen, we have reached to 400 plus students, we have reached to 300 plus senior citizens to make them aware about how important a healthy liver is. क्या आप जानते हैं इस बारे में, or am I the first one to give you this information? I think that deserves a huge round of applause for the entire organizing committee of the 31st INASL for coming up with such a different thought to reach out to everybody, somebody who doesn't understand the technicalities. All right. With that, I sincerely, from the bottom of my heart, would like to take the moment and would ask you to join me in appreciating the efforts of our president, Professor S.P. Singh sir. एक बार जोरदार तालियां हो जाए. It's a very, very difficult task to organize a conference in such a large scale, but he has done it. And also our Secretary General, Professor Ajay Duseja ji. बहुत धन्यवाद. Thank you very much, sir, for putting in so much of effort and hard work. How can I also not mention our organizing secretary of 31st INASL, Professor Manoj Kumar Sahu. Thank you very much, sir. day in, day out, running, making everybody comfortable, reaching out to everybody personally. It's a very, very big task that he has done it efficiently. Also, our joint organizing secretary, Dr. Sushant Shetty and Dr. Manas Panigrahi. बहुत बहुत धन्यवाद आपका भी. Those who actually put in a lot of work are generally the people जो पर्दे के पीछे रह जाते हैं और उनको धन्यवाद देना संभव नहीं हो पाता है. So I'll take this moment to do that, along with the entire organizing committee, the local committee and everybody, because this is the final evening of entertainment. So I'm just going to mention everybody for their hard work and everything. All right. So with that, काफ़ी बातें हो गई हैं, but I'm sure मेरी बातें सुनने के लिए आप यहाँ पे आए नहीं हैं. By the way, my name is Mansi Mishra, and I'm your host for the evening. And probably this is the first and the last time you'll be seeing me on stage, because as I said, मेरी बातें सुनने के लिए you're not here, but you are here to listen to that voice who has the depth to bring in emotions in you, who has the capacity to give you goosebumps when you listen to him. Everybody, I'm sure you are knowing कि मैं किन के बारे में बोल रही हूँ. Are we ready to welcome him? Yes? Yes? I know कि, when I meet doctors, I hope always कि it's in this kind of scenario when there is so much of enjoyment and entertainment. वरना patient बन के जाऊँगी तो बहुत दुख वाला माहौल बनेगा. लेकिन आज खुशी का माहौल है, तो everybody I want to be full power enjoyment वाले zone में. Because the person now who is going to come on stage, if I say he has a golden voice, it is underrated. Because he has the voice, जो अगर मैं बोलूँ कि मुर्दे में भी जान भर देते हैं, तो शायद गलत नहीं होगा. A voice जिनको आपने लगभग 16 different languages में सुना है. Yes, ladies and gentlemen, the versatile singer who has given his voice in 16 languages. He is also the second Indian to perform at the United Nations. Yes, indeed. When India achieved the 70th independent year, so he was invited to the United Nations Assembly to perform. Along with that, I might add, he is a hit maker. There is not even one song उनका जो super hit नहीं हुआ है. He is also the mentor in a very popular reality show, Superstar Singer, Indian Idol, and Saregama Little Champ. So, it is indeed definitely a super proud moment for me. It is indeed a super amazing opportunity for all of us to listen from the voice of nation. And now I am not going to say his name. Can you say it along with me? Yes? He is not here to entertain me. He is here to meet all of you. I want everybody to say his name together. Are we ready for that? Are we ready for that? No, you are whispering, I'll whisper then. It'll be a bhutiya conversation. I want everybody to say it. Are we ready for that? All right, so ladies and gentlemen, put your hands together to welcome. One more time to welcome. To welcome Javed Ali.
Oh चलना मेरे संग संग है गुजारिश, कहने दो हमको जिंदगी चरणों से जुट के हंसेगी, मोती होंगे मोती राह में। मेरी अधूरी अधूरी तू आ गई मन को, अब दो तू बादल बाज बाज। गुड इवनिंग, नमस्कार, आदाब, हाउ आर यू ऑल, कैसे हैं सभी हमारे जितने भी यहाँ पे माननीय जितने भी डॉक्टर्स बैठे हुए हैं, सबको मेरा तहे दिल से नमस्कार नमस्कार नमस्कार। आप चाहें तो तालियां बजा सकते हैं। और बहुत ही कमाल आज का दिन है क्योंकि हम सेलिब्रेट कर रहे हैं, खुशी मना रहे हैं, और साथ ही साथ मैं सबसे ज़्यादा शुक्रगुजार हूँ प्रोफेसर डॉक्टर मनोज साहू जी का, जिनकी वजह से मैं आज यहाँ पे आया हूँ और आप सब लोगों से मिलने का मुझे मौका मिला है। तो आइए म्यूज़िक सेलिब्रेट करते हैं, और म्यूज़िक में अलग अलग जो रंग होते हैं हमारे, वो क्या क्या रंग होते हैं वो मैं आपको गाते गाते बताता हुआ चलूँगा, और चाहूँगा कि आप भी उसमें मेरे साथ में शामिल हों। आपका भी थोड़ा सा पार्टिसिपेशन चाहिए मुझे। आप मेरे साथ में गाएंगे? नहीं नहीं, एकदम जोश के साथ में होना चाहिए। आप गाएंगे मेरे साथ? ये बात पीछे। तो आइए सबसे पहले रोमांटिक मूड एंजॉय करते हैं। अगला जो गाना है वो मैंने गाया था फिल्म जोधा अकबर के लिए, और आप पहचान ही गए होंगे कि कौन सा गाना है। तो आइए इस गाने को एंजॉय करते हैं एंड सिंग अलोंग विद मी। क्लैप एवरीवन। Raise your hands, everyone, come on. Clap, everyone, come on. Beat me. सितम सोचते हैं अब ये हम कोई एक बार मैं आप सब लोगों के लिए तालियां बजाना चाहूँगा, क्योंकि ये जो साइड है ये हर लाइन गा, ईच एंड एवरी लाइन गा रही है। आप भी गा रहे हैं, आप थोड़ा सा, मुझे पता है अगले गाने में आप इनसे ज़्यादा अच्छा गाएंगे। तो आइए बढ़ते हैं आगे अगले गाने की तरफ। और नेक्स्ट गाना मैंने गाया था फिल्म बजरंगी भाईजान के लिए, और मुझे पूरा यकीन है कि आपने ये गाना ज़रूर सुना होगा। इस गाने में इट्स अ थीम सॉन्ग, पूरी फिल्म में बजता रहता है। इस गाने में एक वर्ड है जो मैं चाहता हूं कि आप सब यहाँ पर जितने भी हमारे डॉक्टर्स हैं और जितने भी बाकी लोग भी हैं, सब मिलकर मेरे साथ में गाएं। और वो एक बार नहीं, 2 बार नहीं, बल्कि 3 बार आपको गाना है। आप गाएंगे मेरे साथ में? नहीं, आपका जोश नहीं है। आप गाएंगे? ओके, सो रेडी? क्योंकि तू आपको याद है ना गाना है आपको? सर कम ऑन, रेडी? क्योंकि तू मुझे बीच में से आवाज आई किसी की कि कोई गा रहा है दर्पण। इट्स नॉट दर्पण। व्हाट इज दैट एग्जैक्ट वर्ड? क्या है? यस, क्योंकि तू अब मुझे आना पड़ेगा वहां पे। क्योंकि तू, इधर ही ठीक हूं मैं। क्योंकि तू वन मोर टाइम। क्योंकि तू मुझको घर मिला, बुलाना तेरा साथ दे रहना, ढूंढते तेरा खुदा मुझको रब क्योंकि तू जो तू वो याद जाने सब मेरे कब तक चले, इन्हीं से तो मेरी सुबह भी ढले शाम ढले मौसम ढले, ख्यालों का शहर तू जाने तेरे होने से ही आबाद है, हमारे हक में यही है आते जाते जो तेरा जो सदाए हवाएं हवाएं ले जाए तुझे कहाँ, हवाएं हवाएं बेगानी ये बात, हवाएं हवाएं ले जाए तुझे कहाँ, हवाएं हवाएं ले जाए तुझे कहाँ, ना मुझको खबर न तुझको पता हो। Amazing. Oh. One more time. Oh, oh. Oh, oh. Ready? Oh, oh, oh. Oh, oh, क्योंकि तू क्योंकि तू कर, क्योंकि तू कर। मैं थैंक यू सो मच। कितनी कमाल ऑडियंस है, कमाल आप गा रहे हैं, कितना सुर में गाते हैं। और मुझे यकीन है जितने भी यहाँ पे आई थिंक सब डॉक्टर्स ही बैठे हुए हैं, तो डॉक्टर्स इतने सुर में गाते हैं। मैंने देखा है हमारे बहुत अच्छे दोस्त हैं, कई बहुत कमाल ऑर्थोपेडिक सर्जन है हमारे, बड़े अच्छे दोस्त हैं। वो कहते हैं कि ना हम जब ऑपरेशन थिएटर में होते हैं तो म्यूज़िक लगा होता है और हम ऑपरेट करते होते हैं। एम आई राइट? तो म्यूज़िक मतलब कितना इम्पॉर्टेंट रोल रखता है हमारी लाइफ में, और मुझे लगता है कि म्यूज़िक से अच्छी थेरेपी दुनिया में नहीं है, राइट? तो आइए इसका मज़ा लेते हैं और आगे बढ़ते हैं और रोमांस को ही बरकरार रखते हैं। रोमांस में एक ऐसा आइकॉनिक सॉन्ग मैं समझता हूँ जिसको, जो गाना रोमांटिक म्यूज़िक का जब नाम आएगा, इस गाने को भी याद किया जाएगा। और मुझे पता है कुछ लोग यहाँ पे बैठे हैं जो, ऑफ कोर्स मैं मेरे गाने तो ऑफ कोर्स सुना ही रहा हूँ, लेकिन एक रेट्रो गाना भी आपको सुनाना चाहता हूँ। और वो गाना भले ही रेट्रो है लेकिन मॉडर्न रेट्रो है। जस्ट एंजॉय। आपके हाथ ऐसे म्यूजिक के साथ में थिरकने चाहिए, ये बात। तुम जो मिल गए हो तो ये लगता है जहाँ अपना कोई न था, दिल को जो मिल गया है तेरा सहारा, एक नई जिंदगी का निशान मिल गया। तुम जो मिल गए हो तो ये लगता है जहां मिल गया। एक भटके हुए राही को कारवां मिल गया। तुम जो मिल गए हो तो ये लगता है जहां मिल गया, जहां मिल थैंक यू। दोस्तों अब बढ़ते हैं हम एक मेडली की तरफ। अब मैं इसमें मेरे गाने भी और कुछ 90s के गाने भी इसमें प्रयोग कर लाया हूँ, और कुछ ऐसे गाने हैं जो मैं नहीं बल्कि आप गाएंगे मेरे साथ में, मुझे यकीन है। अगर आप गाना चाहेंगे तो, और मुझे यकीन है कि आप गाएंगे, क्योंकि इधर वाली साइड तो पक्का यकीन है वो तो गा ही रही है, और यहाँ वाले भी गा रहे हैं, बट समझ जाइए। लेकिन चलिए कोई बात नहीं, हम म्यूजिक का मजा तो ले रहे हैं ना, कोई बात नहीं। पीछे वाले इस मेडली में कुछ ऐसे गाने हैं जो शायद आपको 2000 के भी लगे, बट 90s के गाने हमने इसमें कुछ ऐड किए हैं। जस्ट एंजॉय दिस ब्यूटीफुल रोमांटिक मेडली। सका ये बातें दिल तो ना कह सका। दिल इबादत कर रहा है, धड़कने मेरी सुन, तुझको मैं कर लूं हासिल, लगी है यही धुन। जिंदगी की शाख से लूं कुछ हंसी पल मैं चुन, तुझको मैं कर लूं हासिल, लगी है यही धुन। जो भी जितने पल जीऊं उन्हें तेरे संग जीऊं, चाहे जो हो अब मेरा उन्हें तेरे संग हासिल लगी है यही धुन। जिंदगी की शाख से कुछ हंसी पल में चुन, तुझको मैं कर लूं हासिल लगी है यही धुन। छुपा बादल में शर्मा के मेरी जाना, आगे मेरी जाना। गुमसुम सा है मदहोश है ये समा और है। चांद छुपा बादल में शर्मा के मेरी जाना, लग जा तू बल खा के मेरी जाना। ओ आँखों की गुस्ताखियाँ माफ हो, ओ आँखों की गुस्ताखियाँ माफ हो। तुम्हें देख के छुपती है जो बात ना कह सकी, झुकी आंखें वो कहती है। ओ आँखों की गुस्ताखियाँ माफ हो। दोस्तों से झूठी मूठी दूसरों का नाम लेके तेरी मेरी बातें करना, यारा रात से दिन करना। लंबी जुदाई मेरी बड़ा मुश्किल है, रोज सफर करना, यारा रात से दिन करना। कब ये पूरी होगी दूर ये दूरी होगी, कब ये पूरी होगी दूर ये दूरी होगी। रोज सफर करना, यारा रात दिन करना। चुपके से रात की चादर तले, रात की भी आहट न हो, बादल के पीछे चले जले कतरा कतरा, गले कतरा कतरा। रात बिना हिले आधी आधी, रात भी नहीं आधी आधी। चुपके से लग जा गले, रात की चादर गले, चांद की भी आहट न हो, बादल के पीछे चले। दीवाना कर रहा है तेरा रूप सुनहरा, मुसलसल कर रहा है मुझको अब ये चेहरा। बता अब जाए तो जाए कहाँ, दीवाना कर रहा है तेरा रूप सुनहरा, मुसलसल कर रहा है मुझको अब ये चेहरा। बता अब जाए तो जाए कहाँ।
ही हकीकत, अब तू दरिया, तू ही प्यास, तू ही दिल की बेकरारी, तू सुकून, जाऊं मैं अब जब जिस जगह, पाऊं मैं तुझको, साथ हो के ना हो तू है रूबरू, रूबरू, रूह
यू दोस्तों, फ्रेंड्स, अब हम थोड़ा सा मूड चेंज करते हैं और रोमांस से हम जाते हैं सूफियाना अंदाज की तरफ। मैं बहुत लकी हूँ कि मुझे ऐसे कुछ गाने मिले हैं कि जो गाने लोग ऐसा मानते हैं कि वो बहुत ही एक आइकॉनिक मानते हैं उन गानों को। एंड ऑफ कोर्स मैं भी मानता हूँ उन गानों को, क्योंकि उन गानों के साथ लोगों का एक ऐसा दिल से गहरा एक रिश्ता जुड़ा हुआ है कि वो चाहते हुए भी नहीं उसको हटाया जा सकता। तो ऐसा ही एक गाना, उन सारे गानों में से एक गाना जो मैंने गाया था फिल्म रॉक स्टार के लिए। मुझे जानना है कि कौन सा गाना गाया था मैंने। इधर मेरे बहुत सारे फैंस बैठे हैं, ये पूरी लाइन जो है वो मुझे डेडिकेट। तो ये गाना जो है, कुछ गाने ऐसे होते हैं जो आप दिल से सुने तो उनका जो असर है वो दिल में रहता है। तो ये भी गाना कुछ ऐसा ही है और मैं चाहूँगा कि आप कानों से तो सुने लेकिन इस गाने को दिल लगाकर सुने तो मज़ा आएगा। एंजॉय। और लास्ट बट नॉट द लीस्ट, एक बात और शेयर करना चाहूँगा कि ये गाना वर्ल्ड के बेस्ट टॉप 10 सूफी सॉन्ग्स की अगर आप सर्च करें तो उसमें टॉप 10 गानों में मेरे गाए हुए 2 गाने आते हैं। उनमें से एक कुन फायकुन और एक अर्जिया दिल्ली 6। तो आप तालियां मेरे लिए भी बजा सकते हैं।
कदम बढ़ा ले, हदों को मिटा ले, आजा खालीपन में पिता घर तेरा, तेरे बिन खाली आजा खालीपन में, तेरे बिन खाली आजा खालीपन में। रंग रेजा रंग रेजा रेजा रंग रेजा Faya kun 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 जब कहीं पे कुछ नहीं भी नहीं था वही था वही था वही था वही था जब कहीं पे कुछ नहीं भी नहीं था वही था वही था वही था वही था वो जो मुझ में समाया वो जो तुझ में समाया मौला वही वही माया वो जो मुझ में समाया वो जो तुझ में समाया मौला वही वही माया कुन फाया कुन फाया कुन सदक़ल्लाहुल अलीयुल अज़ीम रंग रेजा रंग मेरा तन मेरा मन ले ले रंगाई चाहे तन चाहे मन रंग रेजा रंग मेरा तन मेरा मन ले ले रंगाई चाहे तन चाहे मन सजरा सवेरा मेरे तन भर से गजरा अंधेरा तेरी हल्दी लो सजरा सवेरा मेरे तन भर से गजरा अंधेरा तेरी गलती लो खतरा मिला जो तेरे दर पर से ओ मौला फाया कुन 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 जब कहीं पे कुछ नहीं भी नहीं था वही था वही था वही था जब कहीं पे कुछ नहीं भी नहीं था वही था वही था वही था वही था फाया कुन फाया कुन सदक़ल्लाहुल अलीयुल अज़ीम सदक़ा रसूलुल नबीयुल करीम सल्लल्लाहु अलैहि वसल्लम सल्लल्लाहु अलैहि वसल्लम ओ मुझ पे करम सरकार तेरा अर्ज तुझे कर दे मुझे मुझसे ही रिहा अब मुझको भी हो दीदार मेरा कर दे मुझे मुझसे ही रिहा मुझसे ही रिहा सदका रसूलुल नबीयुल करीम सल्लल्लाहु अलैहि वसल्लम सल्लल्लाहु अलैहि वसल्लम सल्लल्लाहु अलैहि वसल्लम सल्लल्लाहु अलैहि
Thank you. Okay, the next song. दोस्तों एक गाना मैंने गाया था. It's a folk song, but folk and Bollywood combination है इस गाने में. ये गाना था फिल्म रांझना का. हाँ, और आपने मुझे अनेकों रियलिटी शोज में देखा है एज अ जज, एज अ मेंटोर, कुछ सीखते हुए, कुछ सिखाते हुए. तो म्यूजिक में कभी भी आप ये नहीं कह सकते कि आप पूरा सीख गए हैं. एवरी डे इज़ अ लर्निंग डे. तो हम हर किसी से कुछ ना कुछ सीखते रहते हैं, तो ही हम प्रोग्रेस करते रहते हैं. और हर प्रोफेशन में यही बात है. तो आइए कुछ ऐसा माहौल पैदा किया जाए यहाँ पे, क्योंकि इतने खूबसूरत आप सुर में गा रहे हैं, तो आपको कुछ गवाया जाए, आपके साथ कुछ गाया जाए. आपको मंजूर है? तो इसमें थोड़ा बनारस का रंग है, तो हम राजस्थान की कुछ बात करेंगे और आप हमारे साथ में शामिल हो जाइए. ओके सरिया बालमा अबोने पधारो पधारो मारे. आपको देश गाना है. पधारो मनोज जी. Guys, पधारो मारे देश. इतना गाना है आपको. देश पधारो मारे नहीं देश. क्या बेस है आपकी आवाज में. नेचुरल बेस है. हमें पता नहीं क्या क्या करना पड़ता है बेस लाने के लिए. आपको खुदा ने ऐसे ही दिया है. एक बार और सुनना चाहूंगा. देश मतलब ऐसा बम का गोला है आवाज. हाँ जी, आप बड़ा अच्छा डांस कर रही थी. पधारो मारे देश देश देश. अमेजिंग, जोरदार तालियां. इतना सुर में गाया. वेरी गुड. पधारो मारे मतलब इनके अंदर का जो आर्टिस्ट था वो पुड़ुक पुड़ुक करके बाहर आ रहा था। कहता ना कि ना एक मौके की तलाश होती है और वो मौका जब मिलता है तो आदमी एकदम दिखा देता है कि मैं भी कुछ हूं, राइट? क्या बात है, वेरी नाइस, अमेजिंग। इधर कुछ विल यू सिंग विद मी? ओनली वन नोट, ओके। द सिंग द पधारो ओके ता सिंग 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 एटलीस्ट ट्राई ता वेरी गुड, लगा सुर लगा। ओके इधर जा रहा है सर। पधारो मारे
पधारो मारे
जब ऐसा कोई गाता है तो हाथ टूटने तक तालियां होनी चाहिए। जब तक हाथ नहीं टूट जाए तब तक तालियां। ओके एक आपको गाते हैं। पधारो मारे देश देश, वेरी नाइस, नाइस ट्राई, गुड ट्राई, गुड ट्राई। ओके चलिए ठीक है, आ जाइए। पधारो मारे देश, पधारो मारे देश, सॉरी वेरी। तो यहाँ पे जितने लोग बैठे हुए हैं उनमें से कम 4 लोगों ने सही सुर लगाया। मैं काउंट कर रहा था तो आप चारों मेरी नज़र में एकदम पास हो गए, क्वालिफाई किया आपने, आगे की राउंड में जा रहे हैं आप। ओके अभी हम सब मिलकर गाते हैं। पधारो मारे 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 तुम दगड़ दगड़ तुम दगड़ दगड़ तुम दगड़ दगड़ तुम दगड़ दगड़ तुम क्या बात है। जितने लोगों ने सुर में गाया है और जिन्होंने ट्राई किया है सुर में गाने का, उन सभी लोगों के लिए तालियां। ओके गाइस, एक रोमांटिक मेडली जिसमें आपको थोड़ा सा रोमांस भी और थोड़ा सा एनर्जी भी, दोनों का कॉम्बिनेशन सुनने को मिलेगा। सो आई एम श्योर आपको मज़ा आएगा। एंजॉय।
अजब सी अदाएं हैं, ओ आँखों में तेरी अजब सी अदाएं हैं। दिल को बना ले जो पतंग सांसें ये तेरी वो हवाएं हैं। आँखों में तेरी अजब सी अदाएं हैं। अजब सी अदाएं हैं। दिल को बना ले जो पतंग सांसें ये मेरी वो हवाएं हैं। आलिया आलिया सुबह मैं जल गया, सूरज को मैं निकल गया रूबरू रोशनी, रूबरू रोशनी जो गुमशुदा ज़ख़ाम था वो मिल गया, वो खिल गया, वो लोहा था पिघल गया, खिंचा खिंचा मचल गया, सितार में बदल गया रूबरू रोशनी, रूबरू रोशनी धुआं छटा खुला गगन मेरा, नई डगर नया सफर मेरा, जो बन सके तू हम सफर मेरा, नजर मिला जरा धुआं छटा खुला गगन मेरा, नई डगर नया सफर मेरा, जो बन सके तू हम सफर मेरा, नजर मिला जरा रोशनी, रूबरू रोशनी।
Guys, Srivalli. Thank you. Okay. Srivalli. बट जितने भी हमारे यहाँ पे डॉक्टर्स हैं, या थैंक यू, थैंक यू। हाँ, श्रीवल्ली, लेट्स गो। ओके, सभी डॉक्टर्स को यहाँ पे ये स्टेप करना पड़ेगा श्रीवल्ली का। जितने भी डॉक्टर्स हैं, पीछे वाले हाथ हिला दो, हाथ हिला दो। और यहाँ पे जितने भी डॉक्टर्स हैं हमारे, कमाल, मुझे पता नहीं कितने लोगों को आता है, लेकिन 99% लोगों को तो ये स्टेप आता ही होगा। ओके, रेडी? एवरीवन रेडी? जो लोग डांस करना चाहते हैं वो डांस करें, जो गाना चाहते हैं वो गाएं, बट सबको इन्वॉल्व होना पड़ेगा इस गाने में, राइट?
नजरें मिलते ही नजरों को नजरों से चुराए, कैसी ये हया तेरी जो तू पलकों को झुकाए। रब जो पोशीदा है उसको निहारे तू, और जो गर्विदा है उसको टाले तू। तेरी झलक शर्फी नैना मदक बर्फी, तेरी झलक शर्फी श्रीवल्ली करे दो हल्फी। आपकी आवाज नहीं आ रही है, एवरीवन एवरीवन। तेरी झलक शर्फी नैना मदक बर्फी, तेरी झलक शर्फी बातें करे दो हल्फी।
on, all doctors, everyone. Everyone, come on. Very good.
नजरें मिलते ही नजरों को नजरों से चुराए, कैसी है तेरी जो तू पलकों को झुकाए। नजरें मिलते ही नजरों को नजरों से चुराए, कैसी है तेरी जो तू पलकों को झुकाए। रब जो पोशीदा है उसको निहारे तू, और जो गर्विदा है उसको टाले तू। तेरी झलक पर भी,
One more time.
तेरी झलक बातें करे दो हर भी।
Come on.
नजरें मिलते ही नजरों को नजरों से चुराए, कैसी है तेरी जो तू पलकों को झुकाए। नजरें मिलते ही नजरों को नजरों से चुराए, कैसी है तेरी जो तू पलकों को झुकाए। रब जो पोशीदा है उसको निहारे तू, और जो गर्विदा है उसको टाले तू। तेरी श्रीवल्ली नैना मदद कर दी, तेरी झलक शर्मी श्रीवल्ली बातें करे दो हर भी। ओ तेरी झलक शर्मी श्रीवल्ली नैना मदद कर दी, तेरी झलक शर्मी श्रीवल्ली बातें करे दो हर भी।
Oh.
ओ सारा जमाना है मेरे पीछे, पर ये दीवाना है तेरे पीछे। सर ये झुकने ना दूं दुनिया के आगे, पर तेरी पायल देखूं करके सर नीचे। ना तमन्ना हीरा बनना मुझको है बस तेरा मन, एक झलक तेरी आंखों की आम से जा जाए। मदद पर भी तेरी श्रीवल्ली बातें करे दो हर भी।
आप डांस नहीं कर रहे, come on.
तेरी सहेलियां सादा मामूली, उसके मुकाबले थोड़ी तू भली। जैसे ये सोलवा चढ़ जाए सावन, तू क्या हर लड़की दिखे फूलों की कली। लाल लिपटी लाल साड़ी वो भी दिखे राजकुमार, झुमके कंगन और गजरे से धूप निकल जाए। फिर भी मदद पर भी श्रीवल्ली बातें कैसी ये है तेरी जो दूबलों को झुकाए, अब जो जीता है उसको निहारे तू, और जो गर्विदा है उसको टाले तू। You guys are amazing! बजेगा बजेगा नगाड़ा भी बजेगा। बदन पे सितारे लपेटे हुए हो, जाने तमन्ना किधर जा रही हो, जरा पास आओ तो कहना जाए, जरा पास आओ तो कहना जाए। बदन पे सितारे लपेटे हुए हो, जाने तमन्ना किधर जा रही हो, जरा पास आओ तो कहना जाए, जरा पास आओ तो कहना जाए। मम्मी जब न होंगे तो मैं दिलरुबा, किसे देख कर आए शर्माओगी, न देखोगी फिर तुम कभी आईना, हमारे बिना रोज घबराओगी। बदन पे सितारे लपेटे हुए जो जाने किधर जा रही हो, जरा पास आओ तो कहना जाए, जरा पास आओ तो कहना जाए। आजकल तेरे मेरे प्यार के चलते हर ज़बान पर, सबको मालूम है और सबको खबर हो गई। आजकल तेरे मेरे प्यार के चलते हर ज़बान पर, सबको मालूम है और सबको खबर हो गई। आजकल तेरे मेरे प्यार के चलते हर ज़बान पर, सबको मालूम है और सबको खबर हो गई। Come on! हमने तो प्यार में ऐसा काम कर लिया, प्यार की राह में अपना नाम कर लिया। हमने तो प्यार में ऐसा काम कर लिया, प्यार की राह में अपना नाम कर लिया, प्यार की राह में अपना नाम कर लिया। आजकल तेरे मेरे प्यार के चलते हर ज़बान पर, सबको मालूम है और सबको खबर हो गई। आजकल तेरे मेरे हसीना जुल्फों वाली जाने जहां ढूंढती है काफिर आंखें किसका निशान। ओ हसीना जुल्फों वाली जाने जहां ढूंढती है काफिर आंखें किसका निशान। महफिल महफिल है शमा फिरती हो कहाँ, महफिल महफिल है शमा फिरती हो कहाँ। वो अनजाना ढूंढती हो, वो दीवाना ढूंढती हो, जला कर जो छिप गया है वो परवाना ढूंढती हो। गर्म है तेज है ये निगाहें मेरी, काम आ जाएंगी सर्द आहें तेरी। तुम किसी गिर में तो मिलोगे कहीं, अरे इश्क हूँ मैं कहीं ठहरता ही नहीं। मैं भी हूँ गलियों की परछाई, कभी यहाँ कभी वहाँ, शाम से ही हो जाता है मेरा विदा तू दवा। ओ हसीना जुल्फों वाली जाने जहां ढूंढती है काफिर आंखें किसका निशान। ओ हसीना जुल्फों वाली जाने जहां ढूंढती है काफिर आंखें किसका निशान। महफिल महफिल है शमा फिरती हो कहाँ, महफिल महफिल है शमा फिरती हो कहाँ। वो अनजाना ढूंढती हो, वो दीवाना ढूंढती हूँ, जला कर जो गया है वो परवाना ढूंढती हूँ। आजा आजा मैं हूँ प्यार तेरा, अल्लाह अल्लाह इनकार तेरा। आजा आजा मैं हूँ प्यार तेरा, अल्लाह अल्लाह इनकार तेरा। हो तुम पे हजारों की आंखें, चाहिए तुमको सहारा। हो पलकों में आऊं छुपा लूं, नाजुक तन ये तुम्हारा। आजा आजा मैं हूँ प्यार तेरा, अल्लाह अल्लाह इनकार तेरा। Need some more energy, everyone. Make some noise. Hey.
ओके। गजरारे गजरारे तेरे खारे खारे नैना, गाइस 3 आवाजों में एक साथ में ही गाऊंगा। ऐसी नजर से देखा उस चौक पर हमने कलेजा रख दिया चाकू की नोक पर। हाय 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 हाय, बवाल हो गया वो रायता। मेरा चैन वैन सब उजड़ा, हालिम नजर हटा ले। मेरा चैन वैन सब उजड़ा, हालिम नजर हटा ले। बर्बाद हो रहे हैं जी, बर्बाद हो रहे हैं जी तेरे अपने शहर वाले। मेरा चैन वैन सब उजड़ा, हालिम नजर हटा ले। बर्बाद हो रहे हैं जी तेरे अपने शहर वाले। हो तेरी अंगड़ाई ना टूटे तू आजा, तेरी अंगड़ाई ना टूटे तू आजा। गजरारे 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 तेरे कारे कारे नैना। गजरारे गजरारे सुरमे से लेके तेरे वादे, आंखों की जुबानी आते हैं। मेरे रुमालों पे लब तेरे बाल के निशानी जाते हैं। वो तेरी बातों में की मामों की खुशबू है, वो तेरा ना गर्मियों की लू। वो तेरी बातों में की मामों की खुशबू, वो तेरा ना गर्मियों की लू है। आजा टूटे ना गड़ाई, तेरी गजरारे 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 तेरे गारे गारे नैना। वो तेरे नैना तेरे नैना तेरे नैना जुड़वा नैना।
गजरा रे दर गारे नैना ओ दर नैनो में ढक के रहना ओ दर नैनो में छुप के रहना ओ गजरा रे दर गारे नैना अरे गारे नैना गजरा रे कारे Hi, madam. I'm your own leader. तू ही मेरी है सारी ज़मीं, चाहे कहीं से चलूं तुझ पे ही आके रुकूं। Jump everyone, come on. One more time. तू ही मेरी है सारी ज़मीं, चाहे कहीं से चलूं तुझ पे ही आके रुकूं। तेरे सिवा मैं जाऊं कहाँ, कोई भी राह चुनूं तुझ पे ही आके रुकूं। मिले तो लम्हे थम गए, तुम मिले तो सारे गम गए, तुम मिले तो मैंने पाया है खुदा। मिले तो जादू छा गया, तुम मिले तो जीना आ गया, तुम मिले तो मैंने पाया है खुदा। Everybody jump! तुझ में किनारा देखे, दिल को सहारा देखे, आ मेरी धड़कन थाम ले। तू ही शहर है मेरा, तुझ में ही घर है मेरा, रहता है तेरे साथ में। तुम मिले तो अब क्या है, कभी तुम मिले तो दुनिया मिल गई, तुम मिले तो मिल गया आसरा। मिले तो जागू जा गया, तुम मिले तो जीना आ मुझसे डरने है वक्त तेरे हाथ में तू ही शहर है मेरा तुझ में ही घर है मेरा रहता है तेरे साथ में तू मिले तो बन गया ये जहां तुम मिले तो हर पल है नया तुम मिले तो मिल गया आसरा तुम मिले तो जानू जा गया तुम मिले तो जीने आ गया तुम मिले तो मैंने पाया है खुदा तुम मिले 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 तुम ओ रंग बुरे दी रंग रंगीली लड़की जैन कबीली उसे चंचल नैन कटोर Come on. रंग बुरे दी रंग रंगीली लड़की जैन छबीली उससे गुड्डी हो नशे में उड़ी जाए रे हाय रे सच्चे खप्पे तप्पे किल्ली हो पट्टा खा गुड्डी हो नशे में उड़ी जाए रे हाय ओला मेरा माली हरियाली जंगल वाल तुझे हर गाली पे गाली उसकी कदम कदम रखवार ऐ वे लोग लाल की रोज रोज तू है आबद वाली तूने नाम रब का नाम गाएगा अली 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 ओ तूने नाम रब का नाम गाएगा अली 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 अरे बचपन से उसका एक दीवाना था जिसका काम गली के आशिक भरे घटाना था कब से जिसको मान रहा था अपने दिल की रानी को और किसी पे ही यारो मरने ने मर जाने को एक कहानी खत्म तो दूसरा किस्सा शुरू हुआ नकारा 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 बजा नकारा 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 बजा नकारा 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 बजा और रंग बरेली रंग रंगीली छैल जमीली रात चंचल नैन कटार ने उसका रूप बना दिया उसके रूप से कदम में तो चलता शुरू हुआ नकारा 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 बजा नकारा 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 बजा नकारा 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 बजा दिग दिग दाना 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 दिग दिग नकारा 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 बजा नकारा 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 बजा नकारा 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 बजा Good night.
Ladies and gentlemen, the voice of our nation, Javed Ali, everybody! All right, ताली बजा दिया, शोर मचा दिया. मैं चाहूंगी मेरे साथ आप सब मिलके बोलेंगे, We love. One more time, louder. We love.
Done. Thank you so much for being such a wonderful audience. Thank you so much. Good night, Shubhratri.
Sir, you made us enjoy dance so much. I would like to invite on stage Professor Manoj Kumar Sahu, Professor S.P. Singh and Professor Ajay Duseja. And on behalf of the INASL family, we would like to felicitate you. Thank you for your presence, for your entertainment. And this one is from everybody, guys. You have to be here. Samne, I would once again invite Professor Manoj Kumar Sahu, Professor S.P. Singh, and Professor Ajay Duseja to kindly come on stage and felicitate the voice of our nation, Javed Ali. अच्छा सभी इसमें सन्नाटा नहीं मचना है. This is from everybody, from the entire family of INASL. Everybody hands up in the air and give it up, give it up.
Just a minute. Sorry. Please. Just 1 minute. Can you have? Oh, just. Is he going?